Hospital to Kim Dae-jung Convention Center. As you know, President Kim Dae-jung received Nobel Peace Prize 2000. 2015, we invite Dr. Osuji. 2016, we invite Professor Lui Bin from China. 2017, we invite Dr. Matthew, Malcolm Bell, Dr. Lehman, Dr. Glassi, Dr. Yamazaki, Dr. Chris Wang. 2018, we invite many foreign faculty members, Professor Chua Tae, Professor Lui Bin, President Okawa, Dr. Gurube, Dr. Lehman, Dr. Gulati, and Dr. Chris Wang. 2018, we invite Dr. Yasuda from Osaka NCVC, Dr. Lehman and Gulati from Mayo Clinic. 2019, we invite Dr. Wakatsuma, Dr. Chiko, Dr. Matthew, Dr. Huang, Dr. Akasaka, Dr. Wahya, Dr. Miyazaki, Dr. Bill Gogas, Dr. Chris Wang. 2012, we had the 20th anniversary of GICS meeting. And last year, we had 21st GICS meeting, when by many faculty members from European countries, United States, and Asian countries. Professor Yasuda, Professor Gyuro Han received GICS award. Dr. Osuji received GICS award last year. Actually, he nominated 2022. However, he could not attend due to COVID-19 pandemic. That's why he received GICS award last year. Today, we'll have 22nd Gwangju International Intercardiology Symposium. We'll have live case demonstration, oral and poster presentation, and education sessions. Goal of GICS meeting is exchanging our clinical experience in the field of cardiovascular intervention and improving our friendship of the world. So today we'll have currently live transmission from Jeonnam National University, Ilsanbek Hospital. Professor Young-Eun and Dr. Saito will be our operator. Dr. Robert Shore, here's my director at Mayo Clinic, Dr. David Holmes, and Dr. Lehman, Dr. Osuji will give a special lecture today. We have TABA case live transmission from Jeonnam National University, Catholic Medical Center, and Jeonbuk National University Hospital. We have a joint session in Korean Society of Myocardial Infarction. We have a KCTA program for nurses and technicians. We have Korea Mayo Symposium. We invite Dr. Kirk Garrett, Dr. Gulasi, Dr. Malcolm Bell. We have Korean Jamir Kamil Joint Symposium. We invite Professor Miyazaki, Brenda Ogawa, Dr. Nishihara. We have DS Symposium. Every year we have Achilles Heel project with scientists from Germany and Spain. We have Korea London Symposium organized by Professor Do Seom-shi. We have 2 sessions regarding stent technology, new gene and cell therapy. We have Korea UK collaborative seminar every year organized by Professor Do Seom-shi, Professor John Master, and John Martin, Anthony Master. We have TABA Symposium organized by Professor Jo Wang-kim, Professor Gurube, and we have KCTO Joint Symposium, Bifurcation Joint Symposium, Aorta Symposium organized by Professor Lars Miller from Chicago University and Professor Jo Wang-kim. We have Honam Circulatory Society Joint Symposium and Base Symposium organized by Professor In Kyung-kim and Professor Hye Jin-gi. Tomorrow we'll have live transmission from Brigham Women's Hospital, Harvard University, organized by Professor Young-Eun. We have a structural heart case from Jeonnam National University, Mitral Club, and Catholic Medical Center. We have a TAMIS Joint Symposium organized by Professor David Huang. We have CHIP sessions. We have a KTRA joint session, special lectures given by many scientists, especially Dr. Spence King is a legend of PCI from Emory University. We'll have oral competition, China session, organized by Professor Lui Bin. We have aorta session, AAA, and session Cardiac Shock. We have collaboration GIST and Korean Interventional Medical Device Society, organized by Professor Seung-Hoon Na. And finally, we'll have congenital heart sessions. Since 2016, we have GICS award ceremony. First winner was Dr. Saito. And last year, this GICS award was given to Professor Gyuro Han, Professor Satoshi Yasuda. This year, GICS award winners will be Professor Lui Bin from China, Bu Young-kim from Korea. Congratulations. Before closing, I'd like to express my special thanks to our sponsorship: Yuhan, Sanofi, Boston, Medtronic, Abbott, Dio, Celltrion, Pfizer, Biotronic, Organon, Beatrice. and Serbia, Edward, Donga, Boryang, and other gold memberships. These are our publication. We have published more than 1,900 papers. I hope all enjoyed 2024 GICS meeting. Thank you for attending.
Thank you for your wonderful words. Good morning, ladies and gentlemen. We once again welcome you to 22nd Gwangju International Interventional Cardiology Symposium. I am Tae-Yoon Kwon from Cheonnam National University, and I am very honored to moderate the 2024 GICS. We would like to get started with the first session. This session is the live case session 1 and 2, coronary and coronary. This session is going to be co-chaired by Kenji Wakasuma from Chukubade Memorial Hospital, Japan, Xiaoliang Chen from Nanjing First Hospital, Nanjing Medical University, China, and Jung Myung-ho.
이제 나오나 소리가?
코미테이터.
근데 우리 여기 마이크 쓸 거 있어?
And Myung-ho Jung from Gwangju Veterans Hospital. Chairman, please come to the front and have your seats.
Also, I like invite panelists,
간호대학 저 학생이라고.
Dr. Hu and Dr. Bill Gogas, Dr. Mizrong, Dr. Donggu Kang. And my co-chairman will be Dr. Wakasuma, and Dr. Chang is online. Okay. So, Professor Youngenan, can you hear me?
Yes, I can hear you.
Okay. Good morning.
Good morning.
Would you please introduce your team and case?
Okay, so good morning, everyone. My name is Young Nam from Cheonnam National University Hospital. Welcome to everyone. So, this year is the 22nd year of the GICS live symposium. So before the introduction of my case, I introduce in the two doctors. In the next to me is Min-cheol Kim, the assistant professor in Cheonnam National University Hospital. The next is Sung-ho Park, in the fellow in my hospital. Actually, we have the imaging commentator, Choi So-yeon, but still she is not available, but probably near soon she will come to join us. So we will introduce our case first. Min-cheol Kim, please.
Thank you, Professor An. I am Min-cheol Kim from the Cheonnam National University and the second operator of today's case. Let me introduce today's case. Next slide. The patient is a 63-year-old male patient. His symptom developed 4 hours ago before our hospital visit. His atherosclerosis risk factor was hypertension and current smoking, and his laboratory findings showed the elevation of cardiac troponin. Next. 12-read electrocardiogram revealed the S-segment elevation on the left lateral segment. Next slide. So we perform emergent coronary angiography.
Professor Youngenan,
Yes.
we cannot see your slide and cath
I'm
lab,
sorry.
so just a moment.
Okay.
There's some connection problem here. So your case is acute myocardial infarction.
Yes.
It's
Actually,
multiple reason.
Yes. So actually, we performed in the primary PCI yesterday.
Yesterday.
So yeah. So I think this case is a procedure itself is not so complicated, but we frequently meet with this kind of the patient. So I think it's many discussion points can be present.
Yeah, very interesting case.
what shall we do in the multiple case?
So your patient acute myocardial infarction, multiple precision. So you perform PCI.
So actually, the before the introduction, my case in the maybe you can some discussion with the panelists that the what shall we do when we perform the primary PCI and then non-culprit region, somewhat intermediate or severe, what we can do. So can you see the slide?
Not yet. So okay, just right. Your name.
My name?
Yeah,
So
just your
can you-
name. First slide.
Yeah, second slide.
Okay. Second slide.
Okay. Yeah.
Okay, I'll introduce again. The patient is a 63 years old male patient. The patient's symptom to door time was 4 hours, and patient atherosclerotic risk factors were hypertension and current smoking. His level of cardiac troponin was elevated. Next slide. 12-lead electrocardiogram revealed S-segment elevation on lateral lead, so we diagnosed the S-segment elevation myocardial infarction. Next. So we performed emergent coronary angiography 1 day ago, and RCA angiography revealed a diffuse stenosis with focal severe stenosis and distal RCA prior to bifurcation. Next slide. Left coronary angiography revealed total occlusion at distal circumflex. And next slide. And diffusely moderate stenosis and proximal to distal LAD and significant stenosis and proximal shaft of diagonal branch. Next slide. So we performed primary PCI. We thought that circumflex was culprit artery. So after balloon dilation, we examined the OCT for culprit lesion. Next slide. So OCT showed the lesion length was 30 millimeter and distal reference 2.5 and proximal reference of 3.75 millimeter. Next. So 3.25 by 33 millimeter drug-eluting stent was implanted and followed by post dilation using 3.5 millimeter diameter non-compliant balloon. Next slide. Angiographically, the PCR result was very good. Next slide. The follow-up OCT showed a good position of stent and no edge dissection. There was good expansion of stent and minimal stent area was about 9 square millimeter in proximal segment. Next slide. After PCR, we examined the 2D echocardiography and MI in the inferior lateral wall and with mild LV systolic dysfunction. Next slide. So we will proceed our case. Yeah.
So, as I mentioned to Professor Jung, that this is a STEMI with multivessel disease. Can I see the last slide, please? 마지막 슬라이드 좀 보여주실래요? Okay. So the non-culprit region in the LAD, what shall we do? The moderate stenosis proximal to middle LAD. So how can we evaluate this moderate stenosis? By angiographically or functionally or some imaging guided, and then how can we do the distal RCA significant stenosis, and then how can we treat the strategy for non-culprit region? Is immediate PCI is possible, or we have to do in the stage PCI in a hospital or within 40 days after discharge?
Okay.
So could you make some comment?
Okay, I'd invite a panelist for question or opinion. Dr. Gogas?
Yeah, thank you. So this case signifies 2 major points. The first one is the staged PCI after we finish the procedure in the acute onset. And the second one is the complete revascularization that we need to have as a goal
거
for
틀어줘보세요.
every patient.
보이게.
Now, there are a lot of things to discuss,
audio
especially
slide.
after the PREVENT trial that was presented some months ago. And I think either imaging or physiology can assess the LAD, but I think the distal RCA is almost 99% occluded, so we need to assess both vessels and proceed with complete revascularization. I would prioritize the LAD as opposed to the RCA. Thank you.
Okay. Please. Yeah, first of all, and a very successful PCI, congratulations about the ST elevation in myocardial infarction. And I would like to know the diabetes and high bleeding risk, because if I do the multivessel PCI, we do need to know the background history of the patient. Anyway, and recent data suppose the multivessel PCI, after especially in the first hospitalization of the ST elevation myocardial infarction. However, in this case, we should care for the patient background and the multivessel PCI. In our hospital, we should discuss with the heart team conference for the CABG, of course, and after that, we would like to do the PCI in the elective case after the discharge.
Okay, thank you very much. But in the this is a systemic case, so I think it's not good for us to make a PCI or bypass surgery, because even though there are some good candidate for bypass surgery, it's very difficult to rush into the a bypass surgery, the proceeding, the after STEMI, the development. Anyway, this patient is very urged into the emergency department. So, to my best knowledge, the patient has no suffer from the diabetes and also the hypertension, and then I think it's no history of the high bleeding risk burden. And also the okay, that's all.
So,
Thank you.
Dr. Chen from China is a co-chairman. Is online. Would you please discuss your opinion in this case? Can you hear me? Okay, we cannot hear you.
We can't hear you, Professor Chen. We can't hear you.
Okay.
So, the Professor Chung,
Yes.
can we show you the today's angiogram?
Okay, please
Okay,
show
so
us me.
yeah, please. 저 angiogram 좀 틀어주실래요, 오늘 거? So can you see the angiogram today?
Yeah, we can see very well.
Yeah. Okay. So actually, just before we prepared something. So actually, we try to wire into the LVD, and then also somewhat critical region in the diurnal branch. So the LVD, and then also the diurnal branch we got the two wire, and then the patient slightly suffer from the chest pain. The reason why that, can I sit? Yeah. Okay, 이거는 하고 나서 하기 전, 관련하기 전. Okay, so I think it's some compromise in the diurnal branch. So we perform the dilatation with the 2.0 milliliter balloon, and then we performed in the FFR, and then OCT we already did. So actually, FFR I mentioned to the audience that could you show the FFR? The baseline. 안 보이는데. FFR. So FFR, I think is the baseline is 0.89. So actually, the pullback is 0.76. So actually, the maximum pressure gradient, the present jump was present in the mid to proximal LAD. So actually, I think this patient is a good candidate for the intervention. Oh, Soyeon-che, how are you? So actually, she just arrived, and then would like to make a comment from the Professor Che about the OCT imaging.
This is Soyeon Choi.
Just calm down and then
Yes.
and then see and then
Yeah.
show.
Okay.
Yes, let me see again.
Okay.
Actually, when we consider to perform physiology and imaging study for non-corporeal lesion in patients with acute coronary syndrome, we can see the narrow segment and looks like a calcified lesion and very long diffuse. Here is very small lumen area. So we have to think about several things. First, non-corporeal lesion physiologic study is feasible. So in this case, FFR measurement showed ischemic region, and imaging and physiology are compatible in complex lesion in this like long diffuse region. We have data, long XPR study and randomized large scale data. And we have also new data from PREVENT study, even flow limiting lesion, imaging showed, if there is imaging showed vulnerable plaque, PREVENT PCI might be helpful for reduce MACE. So actually in this case, non-corporeal lesion and very long diffuse disease, ischemic evidence, we need to treat with stent. And OCT findings showed very long diffuse region and calcified and minimal lumen area is very tight, need to PCI. So compatible OCT and physiologic study.
So thank you very much, the Professor Che. So do you think that if we can make the PCI in the stent implantation, you want to like cover with the diffuse long lesion, right?
Yes.
So Professor Jung,
Yes.
so I think I'd like to make a question to the audience or the panelists. That
Okay.
my point is that what is the most optimal guidance for the non-corporate region? Because practically we cannot use both of them, the FFR and then OCT or IBUS. So I think FFR is the first option to evaluate in the ischemic burden for the non-corporate region. However, some doctors have some argue that the acute setting in non-corporate artery in the FFR value is really stable to the chronic phase. So I think that some doctors have some underestimation of FFR value. So we think about that one. And another one is if the Professor Che already mentioned that if FFR is negative and then OCT is a positive finding and then very vulnerable plaque and then with some critical region, but the FFR is negative, can we also treat the region using the stent?
So Dr. Aogajima, so how do you think? Do you prefer FFR or
우리
OCT?
저기 반론하자. 2.5mm면 좋겠지.
Thank you. Regarding this case,
되겠지?
if I treat this case, of course, this is a triple with disease, and I understand that the LV function is not so good involving the anterior wall.
Yes.
In this kind of case, I definitely treat LAD. And also the diagonal branch is obviously stenotic, and the area is not so small.
Okay.
Maybe I will treat this case with two-stent strategy, such as mini flush.
Okay, Dr. Bill Gogas.
Do you agree with the opinion?
Yeah, so first of all, about the imaging modality, due to the fact that this is a stage PCI and the patient has already received contrast, I wouldn't select OCT for this case. And due to the fact that there is also diffuse disease, I wouldn't select also FFR because FFR shows good results when we have focal disease. So the imaging modality that I would select would be IVUS. Now, in terms of the strategy, I would again talk about the definition criteria that Professor Shao Liang Chen has invented. And I would say that here the side branch has significant disease. It looks a little calcified and also has diffuse disease about 10 millimeters. So if we select to stent the LAD diagonal, the best technique would be a two-stent technique. And because the DK cross has shown the very good results, I would go with a DK cross.
Okay, do you recommend DK cross for LA
Professor
diagonal?
Chung,
Yes.
I think I tried to balloon implantation for the diffuse LAD region. So, but I think some discrepancies that I don't want to to stent for the LAD to diagonal branch bifurcated area because OCT finding demonstrate that the ostial area of the diagonal branch, I think it's not so plaque burden that was absent, and then also it's a very short segment even though this region is present. So I don't think it's two stent is not the mandatory. Maybe we can have a provisional. So what?
Any other opinion from panelists? Okay.
Yeah, I totally agree with the procedure with the operator, and first of all, I would like to use the multimodality imaging for the indication of the PCI, and in this case, we usually check the LV EDP because some kind of the FFR is based on the premise of the LV ED pressure is quite normal. Therefore, if pressure is high, we would like to pay attention to the abnormal correlation with FFR and the stenosis. And for the procedure, I totally agree with the operator. And many Japanese like to the modified gel technique, and we do not use the two stent for the main branch, side branch. Thank you.
Okay. Thank you. So, Professor Young-Nan,
Yes.
you are trying a balloon dilation?
Yeah, balloon dilatation is a 2.5 millimeter
2.5.
diameter.
Okay.
Yeah.
How much pressure? How much pressure do you have?
Maybe I think up to the 10, 12, 14, 15. Depression.
How was the
Based
patient?
on OCT measurement, the total length of the region is almost to 50 millimeter, and proximal reference is mean lumen diameter is 3.2, around 2, and distal lumen diameter is 2.5. So actually, two different stand.
Yeah. So Soyeon,
Yes.
if we can choose in the stand, so do you think how can we usually can stand from the OCT parameter? So actually, the distal part of the LAD, mid LAD, probably 2.75. The
Lumen diameter is almost 2.5. So if we can get EM diameter, we should round down the stand side. If we just get lumen diameter, round up. So there is to 0.25. So this is long diffuse region. There are big difference, proximal and distal difference, vessel size. So maybe two stent, your strategy?
Yes,
Two different stent?
yes.
Yes, so maybe 2.7, 2.75 or distal region and 3.25 for proximal region.
Yeah, how about in the 3.0 for the distal
okay.
part? Yeah. I think it's 3.5, yeah. And actually, this imaging is from the Abbott is a new, the release version. It's of the star.
Okay.
So I'm not sure that some brightness was increased. So, but in the we don't know exactly right now.
But I prefer single long stent instead of overlap two stents.
Really?
Yes. So
I think if you think about in the proximal part, it's very proximal part.
yes.
It's like some discrepancy in the reference diameter from proximal to distal.
Okay.
And then also, we don't have like the very long stent. Actually, maximum is 4.8,
Yes,
right?
Okay.
But in the approximately 50,
Yes, 50.
So I think it's somewhat like
Okay.
a short stent.
How about other panelists? Do you prefer single long stent or overlap two stent?
예, 3초.
3.5. Okay. So I think it's we avoid in the second diagonal branch. So then
Yes.
28.
아, 예, 28.
3.0, 28.
28.
Okay.
Okay. So overlap zone will be below
okay.
diagonal.
Yes. So I'd like to the overlap with the stent in the below proximal. Which one is better?
Maybe above to prevent sacrifice diagonal branch.
조금 더 긴 걸 해가지고 위에까지 커버를 할까요? 32mm 정도 해가지고.
제 생각에는 다이아고널 길을 커버를 먼저 하시고 앞쪽을 큰 거를 하시는 게 어떨까요? 그러니까 길은 좀 짧게.
Okay. 그러면
Okay. It's up to you.
Okay. Yeah. So Professor Choi the suggesting the 28 lengths in the 3.0.
3.0.
30. 26. So 26 is okay. So actually, we also choose in the Onyx new version of the Onyx Frontier stent, 3.0, 26 millimeter. So how about in the immediate PCI or some stage PCI? So can we treat the patient yesterday, or can we need in some stage PCI?
So time interval is just 1 day. So Dr. Kogas, do you prefer state intervention? How was the time interval between primary PCI and state intervention?
Yeah, for the stage PCI, we usually wait about 1 week.
1 week?
Yeah, about
Okay.
7 to 10 days to proceed with the other vessels.
테스트 해볼까요?
And here we have to consider also the contrast that he is receiving with the OCT for this procedure and the contrast he received the previous day at the ACS.
Yeah.
There are a lot of things to consider. Yeah.
Yes. It's a contrast in this nephropathy is another limitation for state intervention.
7, 8, 9, 10. 노미널 얼마예요?
노미널 8.
12? Okay.
10.
10.
Okay, well expanded.
Depression. 디스탈은 좀 클지도 모르겠다. 그치?
Please check position of guide wire on diagonal branch. How's the patient condition?
It's okay, but in the some chest pain suffer from.
Okay.
환자분 괜찮으세요?
So what kind of guide wire do you use in LAD diagonal?
SPU 3.5.
And guide wire.
Guide wire.
Yeah.
So run through for the diagonal branch and then LAD for like Cyan blue.
Cyan blue. Okay.
3.5 할까요? 3.5. Okay, 3.5에. So 26 괜찮겠다.
Yeah.
Okay.
Hello, I'm Dr. Chen Yishu from Taipei Medical University Hospital. I have, regarding the question about the revascularization time for the second procedure, I
Okay.
have some simple
Okay.
comments on it. Just like you were doing the primary PCI yesterday, whether it's, what is the time for the intervention in acute stage? Is it the duty time or in the schedule daytime? I think that would be
Actually,
the problem.
Actually, frankly speaking, this is for the like live case preparation. But in the 내가 좀 슬라이드가 마지막 슬라이드 한번 줘볼 수 있어요? 아니 그거 말고 그 다음 거 요거. So actually, so we had a big project to the option STEMI trial. It's immediate complete revascularization. And also in-hospital stage complete revascularization after primary PCI for the impact with artery.
Yes.
So actually, we already recruited the 994 patient. Right now, we are conducting to follow-up. So the guideline mentioned that it's like the in-hospital or within 45 days.
Yeah.
So,
But in the
Or
I'm not
delayed
sure.
revascularization.
so
Okay.
include your patient mean time interval from first procedure and second procedure. That's the question. Mean
Okay.
time interval between primary and stage intervention. Maybe it's 3 days or 5 days?
3 or 5 days.
3 or 5 days, okay. Not 1 day.
Yeah, because
Yes.
I remember
It's a
in
very
the-
special case for today.
Okay. Yeah.
Professor Youngna is a PI of option STEMI. He's doing another option non-STEMI studies also. We're expecting good result. So please keep, okay.
Yeah. So this is an ongoing trial to test for the concept that you're doing it in the first place or doing it in hospital stage. But I think I remember in the complete trial that global study that showed that the treatment for non-corporate lesion is a benefit for patients to reduce future MACE events. And they have a subgroup analysis regarding the second stage time. I think the majority of the patients who received staged PCI within 2 weeks may have the similar results as the others. So I think maybe in the first place, if the situation is good enough, the patient is stable, or the facility is capable for treating all the vessels with the physiological and imaging studies, we can do it in a simple single stage. Otherwise, it should be well prepared like today, that you can measure for the other non-corporate lesion, whether it's benefit for patient to treat it all. Yeah, just like the patient also suffer from impaired cardiac function and elevated NT-proBNP, which can have different physiological results, just like a chronic FFR data, just like Dr. Mizuno said. And I think maybe for this situation, we should use imaging modality rather than a physiological testing if the patient suffer from impaired LV systolic function. That's my opinion. Thank you.
Is there any medical insurance problem in Taipei, Taiwan? And if patient also underwent FFR or OCTK intervention 2 times, how about in?
No, I think in the acute stage, we still use FFR, just because the hemodynamics and the condition is, I think, is different from chronic stage. And we also have the reinsurance, the reimbursement issues. Just like if you have to do the PCI twice in a simple procedure, maybe it will not covered by the reimbursement.
Okay. So you place second stent in the
Yeah.
proximal lady. So Professor Youngna,
10.
we have a special lecture session from United States. So please keep going your procedure.
Right.
After then, we come back to you. So I'd invite
NC걸 하나 줘볼래요?
Dr. Robert Shore from United States.
3.5 NC.
Can you hear me, Dr. Robert Shore? Okay, we can see you. So Dr. Labashore is my great teacher at Mayo Clinic. 30 years ago, he gave us a talk about microvascular obstruction in STEMI, the very finally lifting. Dr. Labashore, please.
Oh, yes, yeah.
Okay, we cannot hear you.
We can't hear you.
Just a moment. I learned research technique from Dr. Labashore 1994, 1995. He was my great teacher, and I learned research technique from Dr. Schwartz. And I returned to Korea. I set up animal cath lab in 1996. So we have performed animal cath lab 3,730 cases, maybe a large number of peak heart experiments in the world. So thanks to great teaching from Dr. Labashore. 마이크로 좀 확인해 주세요. 커넥션. Dr. Labashore, please just wait for a moment. We are connecting.
Looks like someone has me on mute.
Okay, we can hear you now.
Can you hear me now? Okay.
Yes, please.
It's such a pleasure, Dr. Zhang, to be back in touch with you, and congratulations on such a wonderful meeting. Yet one more year. You were one of the best fellows we had, and our professional relationship and our personal relationship has been wonderful over the years. So once again, congratulations and thank you very much. I will share my screen now, and we will talk about microvascular obstruction.
Mm-hmm.
Tell me if you can see it.
So, okay, we can see your slide.
Perfect, good. So we will talk about microvascular obstruction. The question is the veil finally lifting? And did the slide change right now? Do we have another slide now?
Okay, just a moment. And
Can you see my screen is the question.
We cannot see that.
Cannot see the screen?
yeah, just a moment.
We come back here.
Dr. Labashore came to Korea 3 times. With one time, his daughter. He has a very wonderful, beautiful daughter, one diamond, and 2 sons. They became a cardiologist.
Can you hear me and can you see my screen, Myung-ho?
Yeah, not yet.
I don't know what the problem is. I'm trying to share and can you see it now?
Okay, so slide.
It says I am screen sharing.
Yeah, slide, please.
Let's try this one. Can you see the screen now?
Yeah, we can see your face. That's right.
Can you see the slide screen?
Yeah.
Good. Well, microvascular obstruction in STEMI has been a major problem. I do have a conflict of interest in this talk. I'm a co-founder and inventor of CoreFlow Therapeutics, a technology to diagnose and to treat microvascular obstruction in the real time in the cath lab. We all know that sudden death after STEMI occurs as a result of severe microvascular obstruction. This is a patient who had an unfortunate event 4 days after admission. His problem, you can see at the apex of his heart, there is a large area of hemorrhage. And in taking that heart down to Dr. Renu Brahmani, a very prominent pathologist, she showed that there was microvascular obstruction. Microvessels here completely occluded with thrombus. Now, one of these studies that Dr. Zhang did in our laboratory was very good. He showed that platelets are an issue in stent thrombosis, but they are also a major problem with myocardial infarction and microvascular obstruction that occurs. MVO is very important, at least in hospital outcomes, specifically mortality. Mortality is a major problem. If you look at patients with and without microvascular obstruction, 12.6% versus 3.8%. Reinfarction occurs, 2.4 versus 0.7%. Cardiogenic shock, 7.4%, 1.7%. And finally, heart failure, 5.2% versus 2.1%. So a very large impact on prognosis, both in hospital, but also out of the hospital in terms of late prognosis when MVO, microvascular obstruction, is present in the setting of the acute STEMI. It's very prominent. If we take a look at the STEMI patients, all patients, the infarct size is 25%, septal failure is 80%, and we see that there's a major increase even in patients who have TIMI3 flow. The prevalence of MVO is almost 60%. So you are very pleased that you have finished a case. One has then an acute STEMI. There is a nice TIMI3 flow through the stent. There is still a risk of about 60% that this patient will have MVO. There's also a major problem with long-term survival. 1 year survival after STEMI in a patient who has MVO. 95% have total resolution up here with no MVO. 84% survival with only partial MVO. And if there is 68% MVO, there is basically no resolution. So this is a major problem between complete, partial, and no resolution. Again, showing once again there are very prominent short-term impact in the cath lab and in the hospital, and yet 1 year, 2 year, 5 year survival, even these numbers hold up with a very large problem related to survival and the presence of the MVO. So we decided that it was important maybe to start to understand, could we better understand MVO in the cath lab? We all know the best way to study MVO is in MRI scans, but can we in fact build a technology that will allow us to detect and possibly treat MVO directly into the cath lab? The idea here is bullet one, we will go with acute STEMI and acute coronary syndromes. We wanted a catheter-based method. Also, we thought that if we can diagnose it, maybe we can treat it in the cath lab. As you probably know, there have been multiple attempts to treat MVO, all of which have failed, and we need to reassess the possibility of giving perhaps an intracoronary drug, as you'll see at the end of my talk, as a way to treat that. We developed a technique we're calling controlled flow infusion. This is a novel technology for real-time coronary microvascular assessment. We take a balloon, we blow it up in this case, an LAD, so we completely obstruct flow. Our balloon is a proprietary perfusion balloon so that we can infuse normal saline distally. This allows us to know exactly what is the flow in terms of milliliters per second, milliliters per minute. We don't have to measure it because we know what's there. We then have a distal pressure wire downstream that gives us a combination then of pressure plus knowing the flow from this controlled flow infusion. This allows some very rigorous characterizations of what is the distal microvasculature look like, because we now know the pressure that is driving the flow into that distal tissue. We also know exactly what the flow is because that flow is being provided by a pump. This is a waveform from a patient who is showing a typical controlled flow infusion sequence. If you see here, the red is the flow, so the pump starts at 0, 5, 10, 15, 20, 30 milliliters per minute in 15-second intervals. So every 15 seconds, the pump is increased, and we generate a flow, which in turn results in a pressure that you can see here measured by the distal intracoronary pressure wire. This information is extremely rich in information about the distal myocardium. And you can see here, we take this data, we process it mathematically. We have a spreadsheet that gives us all of these numbers that we can then calculate microvascular resistance. And as you will see, diagnose MVO directly in the cath lab. We studied this system in the MOCA-1 clinical trial. This was a trial in Europe of the feasibility and safety of the controlled flow infusion technique. All patients were LED STEMIs. The MVO diagnostic accuracy was done and compared with MRI that had been done 3 to 5 days after. So we're comparing our new controlled flow infusion technique for MVO with microvascular obstruction seen by MRI scan 3 to 5 days later. We also had a therapeutic arm where we give tirofiban. As I mentioned, Dr. Zhang showed very clearly, and when he was in our lab at Mayo Clinic, that platelets are a key component to coronary thrombosis. I also showed you a moment ago that it is a key component to microvascular obstruction. And therefore, we chose to give tirofiban intracoronary by the controlled flow infusion technique. That is, blow up a balloon, use our perfusion catheter, and infuse tirofiban in the same dose that one gives it in the cath lab now intravenously, just giving it in the coronary artery distally through the pump. Patients had 30-day follow-up, and we had 3 phases. First phase was a roll-in phase. 6 patients were done. This again, 6 European centers. The second phase was diagnostic, where we in the cath lab looked at 44 patients, looking at diagnostic only. And then therapy, it was the third phase, where we took, of these 44 patients, we took 11 of those patients and gave them intracoronary tirofiban. We studied the technique very well, worked very carefully knowing what the numbers were. We have a number that gives us a sensitivity now of 95%, a specificity of 91% of diagnosing accurately a binary yes-no decision about MVO in real time in the cath lab. This is a 95% confidence interval. As I said, sensitivities of 95 and to 91% between sensitivity specificity, and accuracy of over 93%. Again, all in the cath lab and within 10 minutes of putting the catheter into the patient, and especially then measured against MRI scan done 3 days later. Well, we're running short on time. The therapeutic considerations, as you see here, this was a patient who had a severe amount of microvascular obstruction by MVO. You can see in the apex, the distal and androseptal area down here way at the apex. And this patient unfortunately died before he was treated. Here is his heart. Here is the slide that I showed you in the beginning. This region where the myocardium ruptured was in fact where the distal MVO was. This is a picture of the slides from this patient. This was not a patient from the trial, by the way. This is a patient prior to the institution of the trial. I'm showing you that there are platelets, platelets, platelets everywhere. Each one of these is a platelet. These platelets are aggregated densely, obviously connected by fibrin. The reason that we chose tirofiban to lyse these clots with our technique. As you can see here, platelet inhibition is certainly inhibited, but also these platelets are disaggregated in the animal model that we used as Dr. Zhang mentioned. If we look at patients with the waveform before and after infusion, you can see in this case, every red tracing are patients, these are 3 patients separately. The red tracing is patients who had microvascular obstruction before, and then after infusion, we saw that the substantial reduction in pressure, suggesting a strong possibility that in fact, what happened was the microvascular resistance was markedly decreased in these 3 patients, again, just in our clinical trial. We took 7 patients, and the indices that I mentioned, every single one of these indices had a substantial drop following therapy. Again, we tested the patient before treatment, we tested the patient after treatment. Each one of these represents one of 7 patients. You can see a typical reduction in resistance is 38%, 50%, 47%, 15%. One single patient had an increase by 4%. This patient unfortunately had a catheter that wasn't working. But the other 2, all of these, you can see had a marked reduction in microvascular resistance with tirofiban therapy, again, given after the diagnosis was made in the cath lab of MVO. So because the talk is short, I will wrap up here. In summary, we feel the controlled flow infusion in the cath lab is now a technique that is working in real time. It appears to be 92% highly accurate in terms of the binary diagnostic. Is MVO present or is it absent? diagnosis can be with the results of this trial, over 90% diagnostic. I also don't want to say anything more about therapy except to say that nothing is proven, but the indicators that I showed you suggest an early indication of microvascular hemodynamic improvement that hopefully will have some impact on late survival and late infarct size. So I want to say thank you after this discussion to my wonderful Korean friends. The porcine model of stent thrombosis, this is a paper that Dr. Jung wrote. A great job. And I will say with our work together, I hope are finally lifting the veil on microvascular obstruction, and we will have a technique not only, I think, now proven for good diagnosis, but as we begin a trial in the United States over the next 2 months, we will be doing a therapeutic trial as well. So with that, thank you very much for your attention, and I hope to be able to visit Korea again sometime, once again, to see my great colleagues there. Thank you.
Okay, thank you very much, Dr. Lava Schwartz, excellent lecture about the microvascular obstruction, and congratulations on your TIRO-5 study. And please send my best regard to your wonderful family. Okay.
And to your wonderful family as well, please. You have a great
Okay.
family as well, Myung-ho.
Thank you. Next speaker will be introduced by Dr. Wakasuma.
Yes, let's move on to the next lecture. The next lecture is by Dr. Holmes, Mayo Clinic, Rochester, Minnesota. His title is How We Get Here. Dr. Holmes, please.
Okay.
It's a pleasure to talk with you this morning. I wish I were there with you. We're going to talk about how we got here, the story of left atrial appendage occlusion closure.
Sorry, I can hear you, but not on the screen. Please wait a moment.
Okay. We can see your slide.
There was a case report. It was actually published in 1949, but it had occurred in 1944. It was a case report of 2 patients with atrial fibrillation and rheumatic heart disease with recurrent atrial embolization underwent resection of the left auricular appendix. One of them was a 38-year-old woman with embolic occlusions of the left common iliac, the right popliteal, and right cerebral artery. The left atrial appendage was 3.0 centimeters by 2.5 by 2 centimeters at the time of surgery, and that left atrial appendage was filled with thrombus. The second patient was a 52-year-old man with embolic occlusion of the abdominal aorta. Immediately postoperatively, he developed a fatal middle cerebral artery stroke. And at surgery, the left atrial appendage documented remnants of thrombus with fibrin, red blood cells, and debris. And so we've known since 1944 the issue of atrial fibrillation and recurrent arterial embolization. What do we know about the substrate of that? We know that atrial fibrillation dramatically increases the incidence of stroke. This is old data from 1985 and 1987, and it hasn't changed. Comparison of patients with atrial fibrillation who are cardiovascular patients versus those patients that do not have atrial fibrillation, they are 6 times increased incidence of having a stroke in those patients with cardiovascular disease that have atrial fibrillation. What do we know about other pieces of background? Atrial fibrillation is the most common arrhythmia. Affects more than 3 million patients in the United States. Projected to 16 million by 2050. Lifetime risk in men and women is greater than 40. 1 in 4 of those patients will develop it. The third piece of information is, as we've talked about, atrial fibrillation patients have 5 or 6 times increased risk of stroke, and the majority of strokes are thromboembolic. And then final piece of that is that stroke is the #1 cause of long-term disability and the 3rd leading cause of death in patients with atrial fibrillation. What other pieces of information do we know about stroke and atrial fibrillation? We know that both paroxysmal, persistent, and permanent atrial fibrillation all appear to increase the risk of ischemic stroke to a similar degree. #2, as age increases, the percent of total stroke attributable to atrial fibrillation increases. In our classic Premium study from the United States, the risk of ischemic stroke attributable to atrial fibrillation increased from 1.5% during the age of 50 to 59 to 23.5% in those older patients at the age of 80 to 89. The final piece of information is, where does that stroke come from? Where does that thrombus come from? This is old data again, but it has really stood the test of time. In this study, in the 4 largest transesophageal studies that comprised almost 1,200 patients, showed that 98% of the thrombi were found in the left atrial appendage in those patients with non-valvular atrial fibrillation. So we've known a lot about the background frequency of it. We've known about where the thrombus comes from. We've known the fact that it results in stroke. The question is, why haven't we done more in the last 8 decades? This is a wonderful slide about this. My wife said, "What you doing today?" Oh, I said, "Nothing." She said, "You did that yesterday." I said, "I wasn't finished yet." And so this has been a journey in evolution. Why has that approval taken so long? Should have been quicker. It's a huge number of patients. The problem is that we have had the perception that drugs are better than devices, that conservative medical therapy is best. Thirdly, we've felt in the past that new drugs have solved the problems of old drugs, such as warfarin. We felt that atrial fibrillation ablation solves the stroke issues. And one of the issues is that atrial fibrillation patients are seen by electrophysiologic services who are interested in ablation rather than stroke prevention with atrial fibrillation, left atrial appendage occlusion. And so that's why it has taken so long. What happens during this time where we're trying to analyze whether this technology is good? Well, the technology changes. We've learned a lot of lessons since the earliest days of left atrial appendage occlusion. There have been changes in patient selection criteria. There has been unregulated expansion. Some physicians have said, well, this seems like it makes sense. Why don't we use it? And it has resulted in unregulated expansion. For a while, there was worsening performance and outcome with safety issues related to pericardial effusion, related to transeptals. There was a transition from selective application to a commodity. That's what's happened during this transition. There's been some loss of quality control. And then there were some political considerations that were implemented depending upon whether this was an electrophysiologist seeing the patient or an interventional cardiologist. What would be my personal reflections, having put in the first watchman in this country? The first reflections relate to the fact it was a new device category. When we took this to the FDA, it took 3 different times to get through the FDA to find there to be approval. The second reflection relates to the fact that we anticipated that there would be new anticoagulants that would take care of all the problems. The third, the small sample size versus the drug trials that had thousands and thousands of patients. We had perhaps 1,000 patients or 2,000 patients. There's been confusion about guidelines and patient selection. One of the issues for the trial design has been the fact that stroke has been a safety as well as an efficacy endpoint. That makes analysis very difficult when you have one specific endpoint being both safety and efficacy. The final piece of information related to the fact that the boundary and statistical analysis for the initial FDA approval in this country was felt to be unusual. I'll mention that specifically because the group of patients who were in the control group, who were then treated with anticoagulant, did far better than any other group that had ever been seen. And so there was the issue for that, as well as the fact that there was a relatively broad boundary that was felt to be unusual. All of that led to panel members who were concerned about the safety of left atrial appendage occlusion. What have we learned since that time? We've had multiple randomized clinical trials, and as you know, multiple large registries. Many of them come from your country. The hypothesis that in patients with non-valvular atrial fibrillation, that stroke results from the left atrial appendage thrombus is correct. Secondly, the benefit of left atrial appendage occlusion remains stable over the course of time. We've now had a long time to review these patients and follow them. The next bullet point is that more than 90% of patients can be taken off of anticoagulation without harm. And some patients may never need an oral anticoagulant at all if they receive a left atrial appendage occlusion device placed appropriately. And finally, there's a learning curve. The more you do, the better you are at doing it. All of these are terribly important lessons that we have learned in the field of left atrial appendage occlusion. Are we finished yet with this journey after now 8 decades? Well, we still have other potential goals. The most important goal would be to achieve a Class 1 guideline indication for left atrial appendage occlusion, or level of evidence A. The second would be to document the superiority over DOACs. There are 2 very large trials of more than 5,000 patients that will help us to evaluate that. The third would be to document the superiority over competitors. We need to remember that there are multiple devices in this space. There will be head-to-head comparisons, and we will have to look at that very closely in terms of the trial design and the outcome. We need to identify the optimal post-implant medications. Is it going to be dual antiplatelet therapy? Is it going to be half-dose anticoagulant? Those are things that are still under study. We want to make the procedures safer. We want to make the procedures easier. We want to expand the patient database and expand the user database. What we'd like to have would be if the patient comes to see you, or a patient comes to see you with the onset of atrial fibrillation, you examine them, you do the requisite tests, and then you're able to sit down with them and say there are 2 different options that could be used to help your situation. Number 1 would be used for long-term anticoagulant therapy with the issues of bleeding. That is true. The second is we could put in a device. There are some small but significant risks associated with that would allow you to avoid anticoagulant therapy. But we will be able to put the decision in the patient's and the family's hands by giving them the data for both of these options that can be used for prevention of stroke in those patients with non-valvular atrial fibrillation who are at increased risk for stroke. It's been a pleasure to talk with you about this journey. We're still on it. We don't have the final answers yet, but they will be coming as we get better and better technology, as we get better and better using that technology, and as the results and the patient selection get better and better. Thank you very much. Have a wonderful meeting. I wish that I were there with you.
Okay, thank you very much. Professor Young-Nan,
Yes, yes.
would you please introduce your procedure?
Can you see our coronary angiogram findings?
Yes, we can see very well.
Okay, so like when probably previously I was performing the distal part of the stent, so it's like 3.028, the onyx frontier in the distal part and the proximal part in the 3.528. So total the stent length in the 52. The overlap site is below the diagonal second diagonal branch. So, and then we performed in the 3.5 NC balloon application in the several times, and the maximal pressure is 18. So, and then we performed in the OCT. So, could you make some comment from the Professor Choi?
Yes, actually, Dr. An demonstrated beautifully OCT-guided complex PCI. So, final OCT showed that we measured 2 different sites. Distal part stent, minimal stent area 4.24. Actually, previous minimal lumen area was 0.1 square millimeter. We put 3 millimeter diameter stent. Expansion index is more than 80%, actually 82%. So perfect expansion. And proximal part, minimal stent area is 6.7, and there are little malopposition area, but at that site there is a small branch, so we don't need more pressure. So perfect result.
Okay, thank you very much.
So, but just only one thing is that in the still in the we wonder that in the what shall we do in the donor branch, the ostial region. But I think that in the probably we can have so many options to the evaluation by FFR. But in the we don't want to some damage into the ostial area of the donor branch, and also the TIMI reflow in the donor branch, even though after stent implantation. So I think it's still want to observe in the donor branch.
Okay,
And then follow.
Okay, so please show us a final angiogram.
Okay, so then I remove the wire, and then so with the NTG infusion.
How was the patient condition?
Actually, when we performed in the stent implantation, the patient suffered from a slight dyspnea, and then the oxygen saturation is dropped into the 94. So we inject in the 1 ampule of the pyrisemide, and then right now it's 99%. Then also the patient, I think it's good.
Very good.
In the relief of the dyspnea.
Final angiogram, it looks very good. Wonderful. So, Professor Yanggenan,
yes.
Congratulations on your very successful live demonstration. Thank you very much.
Thank you. Thank you. Thank you.
I invite case number 2 presentation, Professor Chun Young-do from Ilsan Back Hospital. Professor Do, please. For prepare video recording case.
Yes, good morning, ladies and gentlemen. I'm Chun Young-do from Inje University Ilsan Baek Hospital. It's my great honor to present video taped live case. The title was "When We Go or Retreat." In the plan is always the not plan the procedure. Let me show you the case. The patient was a 76-year-old female who suffered with chest pain on exertion for 5 months. Her risk factor was the diabetes and hypertension. She has been prescribed aspirin, amlodipine, losartan, and anti-diabetic medicines. The laboratory result was within normal range. We assessed the patient as a stable angina. The ECG showed the non-specific STT changes and with sinus rhythm, and the echocardiography showed the normal ejection fraction without regional wall motion abnormality. So we checked the coronary CT angiography. The CT angiography demonstrated the moderate to severe degree of the calcified the stenosis from LAD os to the mid LAD, and LCX showed the moderate to severe stenosis in the middle portion. The RCL looks just a minimal coronary artery disease. When we compared the CT angiography, she checked already 2015. The coronary artery disease progression was insignificant or significant. It's questionable, and we're wondering if this is the progressive coronary artery disease or not. So we tried to the treadmill test for her, but she stopped the treadmill test at stage 2 with some dyspnea and chest discomfort. The STT change was noted, but we didn't decide this result was positive or negative. So for this patient, we have some discussion point. She complained chest pain, and target lesion was LAD ostium and proximal LAD and proximal circumflex. what is the next plan to the evaluation for this patient? So we tried to the FFRCT with non-invasive test. FFRCT value from domestic company was the 0.72. For this patient, what is the next step for the evaluation and treatment for resolve her chest pain? So we decided the plan devised more evaluation by invasive method and angiography and angiographic physiology and coronary invasive physiology or imaging guided PCI planning. So we decided started coronary angiography. We tried to distal radial artery using to prevent the complication. Yes, we tried to the 6 French sheath to the distal radial artery, but radial artery caliber was not so big. So at first we changed the plan, the 5 French from the 6 French. So we have a first limitation for the coronary invasive procedure, but limited the size of the catheter.
So do you use a distal snowbox approach in your patient, all patient?
Yes, more and more patient this uses the distal radial artery in recent my clinical practice. The ultrasound guide looks very good. This 5 French was feasible to access the coronary artery, and we started the coronary angiography. And the right coronary artery showed the minimal to mild disease as the CT scan demonstrated. And the left coronary artery was like this. In the apicaudal view, this proximal circumflex has the relatively significant stenosis, and the proximal LAD has also significant stenosis, and the plaque burden may be extended to the LAD osteum. The areocranial view demonstrated quite similar status of moderate to severe degree stenosis. So we performed the coronary angiography for this patient. What is the next step? Can you, the audiences and panels, provide us some suggestion or discussion?
How about the Japanese doctors? Do you prefer snowbox approach using 5 French guiding catheter or sheath? Do you have any experience? How about Taiwan?
Yeah, is that a glide sheath?
Okay.
I mean, you can put a 6 French of catheter inside the sheath. Otherwise, if you use 5 French intervention for this kind of lesions, larger size, that would be more difficult. Yes. But I think for a female woman, elderly female woman, we seldom use distal radial approach. Yeah, because of the size. Otherwise, if you do the echo evaluation, her vessel in distal lumen is larger, I will do the procedure as usual. Otherwise, I think I will choose the typical radial approach.
Ultrasound demonstrated that the 6 French can be feasible, but when we insert the 6 French cassette sheath, the patient complained of severe pain. So this is the reason why we changed the 5 French sheath.
Can you use IVC intervention or bifurcation lesion treatment? Is available 5 French?
It's to the complex PCI is not
Okay.
cannot perform the fibroblasts.
Okay. How about this patient? Are you sure?
This lesion, so we have some problem, and for this lesion, for this patient.
Yeah, I totally recommend the size up of the sheath or put the nitroglycerin to resolve the spasm of the radial artery. And in many cases, elderly female has a spasm for the radial artery. Therefore, we usually use some kind of painkiller and some kind of nitroglycerin to reopen some kind of radial artery. And in this case, I'm not for sure whether you do both of the LAD and the CX. If you have to do the procedure from the 5 French, and I recommend to just only the LCX. And later, we have to discuss about the calcification LAD. That is the most important thing for me and for the first impression.
So we can use radial or femoral approach for complex region.
Yes, that is.
Yes.
So for in this patient, my first plan is distorted from the beginning of the procedure.
I will try to radial approach 5 French guiding catheter to try, and then FFR and FFR pressure is a significant score, and then I've guided PCI. Because of true bifurcation is not she has not significant bifurcation. So 5 French guiding catheter is applied to PCI. So I think. So.
Okay, thank you. Anyway, we checked the coronary angiography. What is your next plan? So we started the change the guiding catheter to evaluate the complex, maybe complex procedure. Remove the sheath and the 6.5 French sheathless guiding catheter applied. That can be changed with the 5 French sheath.
5 French, okay.
And we checked the angiographic QFR. The QFR value was 0.72. And we confirmed to compare the FFR CT and the QFR, and we checked the invasive FFR for the LAD. The FFR value was 0.71. So, and the next, what is our next plan? To planning for the PCI, we need to check the intravascular imaging. So we started the intravascular ultrasound, but the IVOS catheter for LAD was not crossable for this kind of severe stenosis.
Why? I mean, the LAD is visibly also looks significant.
Slide, please.
I mean, you don't.
So.
Next slide, please.
So do you believe value of FFRCT?
Excuse me, sorry. The slide is not progress.
Okay.
This is the QFR. QFR value was 0.72, and the invasive FFR was 0.71.
Very accurate.
And we started the IVOS evaluation with the 6.5 sheathless guiding catheter, but the IVOS catheter was not crossable, the lesion. So we tried the balloon angioplasty first and then checked the IVOS. The IVOS like this. There's a multiple severe stenosis with the calcified mixed plaque in the middle to proximal LAD. Anyway, we tried the multiple balloon angioplasty for the LAD. This IVOS, the image was after balloon angioplasty. Our procedure plan was distorted the second time. This is diagonal branch. And in this LED has a size discrepancy from the middle portion to the LED proximal and ostium. The proximal LED size was was greater than the 0.35 millimeter, and the distal LED has only 2.8 millimeters diameter. So you said, what's our next plan?
What type of balloon did you use for the LED?
2.0 and 2.5 millimeter diameter, the balloons for the LED.
I mean, non-compliant balloons, cutting balloons, whatever.
No, the plain balloon was used.
Just plain balloon.
Yeah, just plain balloon to enable cross the IVUS catheter.
How about non-compliant balloon or scoring balloon or heavily calcified lesion?
Yes, in the atherosclerotic plaque burden was extended to the LED ostium. As the total length of the stenosis was 0.85 to 86 millimeters from middle to the LED ostium. What is our next plan? What's your recommendation for this patient? The FFR values was already decreased, and the target lesion was 2 LED and circumflex.
And long calcified lesion. So, how about Dr. Bilgogas?
Yeah, can we see the angiogram after balloon angioplasty? Can you play the angiogram after the lesion preparation?
Yeah.
Because we can't see it. Not the IVUS, the angio.
Yes.
He would like
This
to
is
see
angiogram, after balloon angioplasty.
Okay, looks good.
And from the IVUS perspective view, and I usually I perform the debarking because some kind of just eccentric calcification. Therefore, we should do some kind of debarking for the stent dilatation and optimal stent dilatation. However, we should discuss with the IVUS imaging specialist, and that is one of the options. However, the guiding catheter is not the optimal position. Therefore, we should discuss some kind of the coaxial and some kind of the best rotor brader or some other debarking device would perform the more precisely.
So do you have any previous experience rotor ablation through snapbox approach?
Yeah, in our posterior rotor brader, we will choose it. However, unfortunately, in your case, you have already dilated a 2 millimeter balloon or something like that.
Yeah.
We should discuss the sizing of their other debarking devices.
The calcium is the eccentric position, so I think rotablation is not good for the debarking, and maybe we need probably the DCA procedure in the middle LED, but we don't have the device.
Okay, keep going on your presentation.
Yeah. So we decided to put the stent in the LED, and we make the giant stent 2.75 and 48 millimeters from the LED, just near the LED ostium to the middle LED. So we deploy the stent by angiography guide as you can see, the 6.5, the Swissless guiding catheter the backup support was not so good as well as the conventional 6-branch EBU guiding. But anyway, we put the stent like this, the giant stent like this, at the proximal LAD. And then we check the IBUS again. But the IBUS system showed some big problem. As you can see, the distal part of the stent was implanted. Looks good. The stent position pretty good. Let me show the IBUS, the proximal LAD. It's still the IBUS inside the middle LAD. The distal LAD was the 2.8 millimeters, and the stent position looks good. This is a diagonal branch in proximal. The IBUS is going to the proximal LAD and left main. Our plan was to put the stent just distal of the LAD ostium, but the angiographically we put the stent just the distal of the LAD ostium, but I was showed the stent was extended to the left main and the stent in a position. For this patient. My plan was distorted the third time. And still we didn't put the stent in the proximal LCX. It's quite a big problem. We should put the stent in the LCX, and we have to improve the stent position in the left main. What is your next plan?
Please show us a final angiogram. Maybe a recorder view.
Yes.
How's the length of a stent strut in the protruded left main?
The 3 or 4 millimeters.
Oh, yeah. 3 millimeter, 4 millimeter. So, Dr. Bilgogas, how's your opinion?
Can we see the angiography after standing?
Angiography.
Because, I mean, if we don't see the angiography.
So, Onasuma, how can you overcome this situation?
Sorry, I cannot truly understand this situation. The stent is fully covered the left main, or just protruded to the left main?
Not fully covered, but the stent strut was partially positioned in the distal left main and covered as the LCX ostium.
Okay.
And then the stent was not expanded because the size discrepancy. We put the 2.75 diameter stent in the LAD, so the left main diameter was greater than the 3.5.
Maybe this 2.75 Zions can be expanded maximum 4 millimeter or more.
Yeah.
So you need to do a part or something, and then wiring to the circumflex, and do PCI for the circumflex. And maybe we need to treat the bifurcation part of the left main.
Yes. Anyway, if we sacrifice the left circumflex, we try to the pot proximal optimization in the left main and LAD ostium, but we have to need to do another stent procedure for this patient and with this situation.
But anyway, you cannot leave the stent strut at the left main part. Anyway, we need to do a part or something.
So So we decided to bail out this situation. We started the adjunctive proximal optimization balloon angioplasty for the left main and LAD ostium. So with the 3.5 and 15 millimeters non-compliant balloon. After the non-compliant balloon angioplasty, the left main position was improved, and left main position was pretty good, and the LCX ostium was seen like this. And then we decided to try the LCX procedure, and we planned if once the situation is for the left main bifurcation, the kissing balloon angioplasty. So anyway, we tried to the balloon cross to the stent inside the stent strut of left main. The balloon was crossed, and then we can put the giant stent 2.5 and 50 millimeter can be delivered, but at the first time
I mean, we can't see your angiogram. Yeah. Oh.
Yeah.
Fine.
So the giant stent was not crossed, not easy. So we opened the left main side branch using the balloon, and then we put the giant stent into the proximal LCX, and the left main region was changed to the complex bifurcation, left main bifurcation region. So we tried to the kissing balloon angioplasty with the final proximal optimization, but with this, the 6.5 small size of the Swissless guiding catheter does not allow the kissing balloon delivery inside the coronary artery. So we failed to the kissing balloon delivery finally. And then we cannot change the guiding catheter without additional the vascular access. What is our plan? So finally, we decided kissing balloon was failed, and we decided just final report using the 4.0 and 10 millimeter NC balloon. So, but in the delivery, the NC balloon inside the left main and the LAD was not easy because the poor backup support of the flexible guiding catheter. Finally, we can put the NC balloon, the left main proximal optimization. This is the final angiography. So we finally failed out from the complex situation when we did not plan to the procedure. Can you suggest provide me your suggestion for panelists and?
Okay, Dr. Virgogas.
Well, angiographically, the result looks excellent, but we need to see with IBUS about the compromise of the ostium of the circ. If we need to do an extra kissing balloon. Another point I need to point out is that when we do a procedure, I mean, we always think about complications. That's why we need to be ready up front. I don't think that the guide catheter and the distal radial artery that you chose was the right selection. Because then, you know, if you have a complication, we cannot act fast. You need to change access, you need to change guide catheter. But things went very well here. But I'm just saying that we need to be always prepared for the worst in every case and be prepared.
Okay. Any other comments?
Okay. Yeah, great results. Much better than imagined.
Yeah.
Therefore, I totally agree with your procedure. And however, I totally agree with Bill. And approach should be considered for the next time. And because the classification is already classified by the CAT scan. Therefore, when we see the CAT scan with the classified LAD, therefore, this is a very complicated case for the LAD. Therefore, we should do some more difficult procedure. For example, some kinds of debulking and eyewear or other debulking devices could be easily by using the more larger catheter and a femoral approach or something like that. Anyway, and congratulations.
Thank you.
Okay, thank you very much for excellent presentation about your distal lateral approach. Thank you very much.
Thank you.
And closing remark will be delivered by Dr. Makasuma.
First of all, I would like to express my sincere appreciation for giving me this fantastic opportunity to sharing with Professor John. And thank you very much for attending this opening live demonstration. Thank you.
Thank you for your wonderful words. Now it's time to wrap up the session. From now, we'll have a short break. Please feel free to use this time. The next session will start at 11 a.m. So may I ask you all to be back 5 minutes before the session starts. Thank you for your cooperation. up. And it's time to open the next session. This session is live case 3 and 4, coronary and coronary. This session is going to be co-chaired by Bin Luin from the second hospital of Jilin University, China, Naoto Inoue from Tokyo Heart Center, Japan, and Moo-hyun Kim from Dong-A University, Korea. Chairman, please come to the front and have your seats.
The co-moderator is Dr. Kim from Korea. Some panelists from Japan and Korea. Now let's start our section.
As the panelists come up to the stage, please. Dr. Mizuno, Dr. Sonoda, Dr. Matsuzawa, Jang-woon Lee, Seung-wook Lee, please. Hello, Dr. Saito.
Hello, good morning.
Good morning. Are you ready?
Yes, we are ready, but still maybe seems very difficult. Okay, you can introduce.
Hello, everybody. My name is Dusun Shim at Jeonnam National University Hospital, South Korea. I'd like to introduce our team for today. We have a world-famous interventional cardiologist, Professor Shigeru Saito from Shenan Kamakura General Hospital, Japan, who's the first operator. And I'll be the second operator. And we have Professor Dae Yong-hyun, who's the third operator from our university hospital. And we also have Dr. Yamanaka working with Professor Saito. So Saito, would you please say hello?
Okay, hello. Hello, everybody.
And Professor Hyun will introduce today's CTO case. Professor Hyun, please.
Okay, next, please. 49 male patient who have hypertension came to the emergency room due to chest discomfort. Troponin I and CKMB were elevated at initial lab. Next. EKG showed ST depression at anterolateral lead and the TUAV inversion in precordial lead. Next. 2D echo showed regional wall motion abnormality in LAD territory and severe LV systolic dysfunction was observed. Next. We did angiogram under the diagnosis of myocardial infarction. There was CTO with microchannel in mid RCA. Next. And severe stenosis was observed in proximal to mid LAD. Next. We performed LAD lesion we think it was a corporal lesion, and we did a PCI for this lesion. Next, cardiac CT showed diffuse CT lesion in mid RCA. Next, M-SPECT revealed mixed viable myocardium in RCA territory. Next, we tried intervention for RCA lesion after 6 days later with via transfemoral approach. Next, we did wire via bilateral angiography, but we failed. Next, 9 months later, we checked the 2D echo. It showed improved LV systolic function, but the patient complained chest discomfort again. So we plan to do intervention for RCA lesion again. Next, JCTO score was about 3 and the CT rectal score was 4. The patient belongs to very difficult group. Next.
Okay.
So this is the case presentation, and Professor Saito will be taking the lead. And Chairman, would you please take over and discuss with the panelists?
This is the previous one.
Oh, hello, Dr. Naoto is on the Zoom. So Dr. Naoto, say hello to the everybody.
Yes, say hello, hello, hello. Good morning.
Any questions about the
seems
case?
to be very difficult. Could you show me the collateral vessel again?
Yeah, this
Collateral
one.
view.
Okay, you can see. So there is looks very nice septal channels. So I started from this channel, but surprisingly, the wire crossing was so difficult.
We cannot see the collaterals.
You cannot see?
Yeah, from left.
Cannot see.
콜레터럴 잘 나온 거 좀 해볼까?
This one.
Yes, this one. Okay.
Okay.
We can see very good collateral channel.
Yeah. I expected a relatively easy collateral passing through the by wire because you know from the we have the LAO for this projection, no?
LAO.
So it looks like tiny channels from left.
This one, this one,
Yeah,
this
시내,
one,
시내.
시내, this one,
Yeah, right. Left one.
this one.
We can see LAO view.
Test injection.
Okay.
Test injection. Yeah.
No, this one, this one.
This one.
Yes, that's one.
Left
Okay.
one. 자, test injection.
And
시내. Yeah.
시내 is
시내.
this one.
Yeah. Right one. 시내.
No, I want to have this one. Yes.
Right.
Yes. Okay.
So maybe
Can I see the connection? So I cannot see the move the table. Okay. One more. Okay.
Right first.
Actually, it's connected.
So maybe Dr. Sonoda, is there any idea about this case?
Integrate?
Integrate maybe after.
Yeah, I think
one more try.
already passed through the RCA distal, so we're gonna integrate approach again.
Yes,
So,
this route is surprisingly. No, I'm handling the retrograde wire, but looks very difficult. Surprising. Test injection.
Test injection.
Yes, here I feel very strong resistance.
Did you take angiography through the microcatheter?
Yes, I did.
Show me.
What is the microcast and the guide wire now?
Guide wire is 2003. The microcatheter is
Caravel.
caravel, long caravel.
Dr. Seto, did you try the antigrade before retrograde?
Not yet.
No.
So very strong resistance here. I can push the microcatheter. Surprising. No. So maybe I have to go to the antegrade approach. Here, very.
No, I totally agree with your opinion. And because previously we used the field FC or something, right? Field XT, just only a field XT. Therefore, we should try another Asahi wire. We can use it.
Yes, Gaia first, Gaia second, or something. Okay, I want to go to the antegrade. Okay. So can I have caravel, short caravel?
Short caravel.
And can you move the image to that one?
But this micro-injector view looks like relatively good collaterals.
Yes, yes.
Yeah, I agree. But you felt the strong resistance.
Yes.
I would like to confirm that this caravel is crossing the stent strut, right?
Stent strut? No.
Distal side? I'm not
distal to the stent.
Oh,
yes.
really? Okay, thank you.
Yeah.
Sean, caravel.
Okay. Can you move the static image to upside from this? What is this? This is
right antegrade.
Antegrade.
Yeah.
Okay.
Remove this one.
No, just
keep it.
And we have to take cine once more. Which one? This one?
Right one, yes.
Okay.
Right cine.
Okay.
Yes.
Yes. Okay. Can I have Sion, and with microcatheter?
Dr. Lee Jang-won, any comment for the case?
Microcatheter. Okay.
Today's angiogram shows some good channels in RCA.
Inside.
Maybe. So we'd like to try RCA antegrade approach first.
Dr. Seto, what kind of wires you will choose?
This is a caravel, short caravel, and also the Sion. So, which one is this?
Cine, right one, cine.
No.
Right, left.
Fluoro.
Left.
Second. Okay.
Talk device.
So, Dr. Zhou, this time I know that Dr. Saito is a radialist. You do a femoral or radial?
This is femoral.
Okay.
Of course.
Test injection.
Okay.
Sung Lee, do you have any comment?
Maybe the channel is connected to distal RCA. If I operated and integrated first to try, integrated trial is first. Surprisingly, maybe easy pass through the wire to distal.
This is too much bend, so I have to exchange.
Okay. Why?
Okay.
Remove.
Yeah.
Slowly. Why?
Yeah.
Dr.
Which one?
Matsuzawa,
No,
any
Sion blue.
Sion blue.
Yeah, this is Matsuzawa.
Do you have introduce?
Introduce, yeah.
And can I take this is RO and LO.
RO.
Okay. 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 Take angio.
Take the angio.
This one. Okay.
Yeah. Shine.
This one.
Shine. Right.
Okay. Wire.
Is this Sion or Sion blue?
Sion blue. I changed from Sion to Sion blue.
Dr. Joe? Dr. Shim?
Yeah.
Sorry. It looks like the forward flow is a little bit, I think, continuing. I don't know how long does it do the before in the CTO intervention?
In the past, how long did you try?
Maybe
40
just
minutes.
just
9 months later.
No, I mean how long do they try the?
1시간?
1 hour.
1 hour.
Yeah, we tried for about 1 hour in the past, but failed. And
Okay, I think no parallel wire
The
technique.
what was the final selected wire before the procedure?
It was no, the CTO wire.
CTO wire.
Gaia second. or
Gaia
something.
second
Gaia
and
second.
filter XT.
It was tried. No. Yeah. Test.
Okay. Test injection.
Too far. Test. Yeah. Okay.
Test injection.
Very strong resistance in the wall. The friction between wire and the coronary artery wall is so high for this patient.
Probably
Okay.
there is some tough stenosis around the
Yeah. So maybe do you have なんだっけワイヤーハイドロフィックのグラディウス。
Sion black? No.
Gladius. Gladius?
The friction is so high.
might be a very serious dissection.
Yes, yes. So maybe I have to take some hydrophilic wire.
Dr. Saito, how about Sion Black?
Sion Black is another choice, yes. So maybe here we don't have Gaia. No, so you have Sion Black?
시온 블랙.
Black.
블랙? 예, 시온 블랙 있어.
I think in MDCT, there might be a not so significant classification.
That is for peripheral, maybe. Sion Black, okay.
시온 블랙?
Dr. Inoue?
Yes.
Just
when this guide wire is not advanced, what is your next choice?
I would like to use Sion Black, and Sion Black is very good for the touches and very complicated region. I don't need a stiff wire, and we can see the micro channel and the RCA. I think a Sion Black is better for this region.
Test injection. Here, very strong resistance. I will push the microcatheter. Strong resistance here. Test injection. Cannot. Okay, I will make a more strong bend.
Yeah. Dr. Saito, if the wire cannot pass over, will you try knuckle?
Knuckle, yeah.
I don't know, because so long diffuse lesion.
Yeah, that sounds very good idea. Anyway, first I make a more strong bend.
One question, in the previous procedure, did you pass such kind of the stenosis area in the previous CTO procedure during the PCI?
Yes, in the false lumen, yes. 2 years ago.
Any good solution from the floor? If you have any good suggestion, you can talk.
I will choose not the plastic jacket, the just coil wire, because this site does not seem so significant stenosis. Therefore, we can more hard one. I can choose it. And plastic jacket.
So what do you recommend?
Yeah, route or some kind of the filter.
Test injection. Yeah.
Lecture.
Okay, Dr. Saito, do the procedure and we'll have the lecture time and then
Yes.
come back, okay?
Okay.
Thank you very much.
No, we invited speaker come from Mayo Clinic, USA, Dr. Lerman. Its topic is about coronary sinus reducer in refractory angina. Ami, can you hear me?
Dr. Lerman's lecture is online or on site?
Can you call Dr. Lerman? Yes. Yeah.
Hello, everybody, and thank you for the opportunity to participate in this prestigious GIC 2024 meeting. Sorry I cannot be there in person, but I would like to thank personally Professor Jong for his relentless energy in putting this meeting and our relationship with Mayo together. I would like to share with you our data and presentation on a novel therapy for angina using coronary sinus reducer. Recurrent angina at 1 year after procedure in PCI is very common. In multiple studies, including the Courage, FAME, Syntax, and Freedom in the ischemia trial, more than 35% of the patients remain with chest pain following successful intervention or optimal medical therapy. Thus, the current therapy is not sufficient to reduce individuals' symptoms. When we try to classify coronary anatomy based on chest pain and physiology, we can look at the figure here and say that on the left side, there is the anatomy of normal epicardial vessels. On the right side, the patient that we usually see that underwent multiple procedures, bypass surgery, stent, and PCIs, and still have evidence of chest pain and ischemia. And in the middle is our regular practice. Both of these anatomies, from the left with no obstructive disease and the one that underwent multiple procedures, can be classified and looked as non-revascularized coronary artery disease. I would like to draw attention to the coronary sinus, which we are currently experiencing growth in the use of the coronary sinus as an axis and as a determined in research in individuals with coronary artery disease. And we see increase in the use of the access to the coronary sinus in structural heart disease, congenital defect, heart failure, and currently with the coronary ischemia. The augmentation of coronary sinus pressure started previously in the 1938 and 1964 by a surgeon called Beck, who open heart surgery ligate the coronary sinus to improve angina. He did several thousand cases, However, this procedure, secondary to the side effect as well as complication, were abandoned at that time. Recently, in the 1984-2003, there was a use of the Pixel device that actually created reperfusion in the myocardial, as the myocardial protection to reduce infarct size. This was not a permanent device in the coronary sinus. And now we are exposed to a new device. Coronary sinus reducer was invented originally by Neovasc and now owned by Shockwave. That is actually a stent that is displaced in the coronary sinus in individuals with chest pain and no other revascularization or medical options. This slide represents the procedure, and it's done 9-5 access from the right jugular vein over a wire and a balloon. This stent is actually placed in the coronary sinus, as you can see here, and it's not occluding the coronary sinus, but rather reduce the lumen of the coronary sinus. This is how it looks in non-invasive imaging and anatomy. As you can see, even after 12 years, the stent is located there and it's not occluding the coronary sinus, but just reducing the flow. You can use this technology of CT in order to follow up on the device if there are any question or potential complication. The first study that showed the utilization of coronary sinus reducer called COSIRA-1. And this randomized, double-blind sham study, they randomized close to 100 patients to reducer and sham control. These are patients with severe underlying coronary disease, not deemed to any other revascularization option. Coronary stent was placed and the patient was followed for 6 months with symptoms. As you can see, in a short period of time, there was significant reduction in CCS class in the group that were treated with the coronary sinus as compared to the sham group. If we look at change in angina, the majority of the patients with the coronary sinus reducer experienced significant reduction in angina at 6 months as compared to baseline. This was the first study that showed the safety feasibility of coronary sinus reducer in reducing angina in patients with non-revascularization. A post-market study called Reducer-1 continued to follow close to 400 patients done in Europe and the Middle East on the efficacy of the coronary sinus reducer. As you can see, in 6 months, the patient continued to experience angina safe, and this has continued up to 24 months. 400 patients of these were presented in a recent ACC meeting, and as you can see from this figure, patients with CCS class 4 and 3 significantly reduced from 72% to 11%, and the increase in Seattle questionnaire symptoms and quality of life increased from 38 to 66, certainly showing the feasibility and the durability of treating angina with coronary sinus reducer. When we focus on these individuals with underlying significant disease, we cannot think that maybe there is another mechanism by which this device may be helpful, and we resort to other source of non-revascularization classification with patients that have angina or ischemia but do not have ischemic or coronary artery disease and probably have microvascular angina. As we can see from this slide, this is a randomized study in inflation, acute inflation of a balloon in the right atrium, simulating coronary sinus reducer, showing significant acute reduction in coronary resistance and microvascular resistance in this patient where the balloon was inflated in the RA. What happened when you acutely deploy coronary sinus occluder or reducer? You acutely see increase in coronary blood flow, reduction in microvascular resistance. FFR doesn't change. In follow-up, CCS class significantly reduced. So it may be speculated that one of the major mechanisms by which coronary sinus reducer contribute to reduction of angina is through improvement of the microvascular circulation hemodynamics. In order to address specifically this question, we finished currently a study of 30 patients. It's an open-label, non-randomized study on patients with no obstructive disease and microvascular angina. Patients were able to enroll if they have a CFR less than 2.5 or coronary blood flow to acetylcholine less than 50. We applied Seattle questionnaire, exercise tests. Patient underwent coronary sinus occluder and have a physiology invasive studies in 4 months. As we can see, overall coronary flow reserve increased significantly from 2.5 to 3 in the overall population. Significant increase in microvascular function, non-endothelium, in 4 months. If we divide the population based on the mechanism of microvascular dysfunction, endothelium dependent and independent, in both of these mechanisms of microvascular dysfunction, coronary sinus reducer significantly increased microvascular function in the non-endothelium from 2.1 to 2.8, and in the acetylcholine from -14 to 31. Certainly emphasizing that the improvement in the microvascular function and angina is not dependent on the mechanism of microvascular dysfunction. Similarly, Seattle Angina Questionnaire significantly improved in all the population, including physical limitation, angina, frequency of angina, treatment, quality of life, and Seattle Questionnaire summary score. Again, there was improvement in symptoms together with significant improvement in microvascular function. In this study, also CCS class angina reduced from 3.7 to 2.4. This mechanism of microvascular function improvement was also true for patients with non-revascularized angina, such as patients that underwent cardiac bypass surgery and stent. In this landmark study, it was just recently published, the group showed that even in this group of population who have significant underlying coronary disease, coronary sinus reducer was associated with significant increase in CFR, reduction in IMR, together with CCS class. So the improvement in microvascular function may be a common pathway by which coronary sinus reducer improving angina and probably ischemia. Currently, we're enrolling in the COSIRA-2 study, again, patients with non-revascularized option and are randomized to reducer and sham, and we follow them throughout the years. This is a multi-center randomized study involving US and centers in Canada. In summary, coronary sinus reducer is safe and feasible novel therapy for refractory angina. Coronary sinus reducer may improve microvascular function in association with improving Seattle angina score in patients with obstructive and non-obstructive coronary disease. This may have an implication for coronary sinus reducer as a potential effective therapy for this particular patient who have no option of revascularization or medical therapy to improve their angina and ischemia. Thank you very much for your attention and hope to be with you next year.
Thank Professor Lerman gave us wonderful lectures and introduced a method for refractory angina. Then we will move to the next lecture, and Professor Kim.
Next lecture will be done by Satoru Otsuji Sensei. He will talk about the treatment strategy for coronary calcified region in the IVL era. Dr. Otsuji, please.
Okay. So, cranial, RO-cranial.
Okay. Thank you very much, Professor Kim. I'd like to talk about the calcified region, no CTO.
Cannot see the wire.
So the drug-eluting
Yeah.
stent is currently the most reliable method for the treatment of coronary artery
Okay.
lesions.
Move.
However, the coronary calcification is one of the
Okay.
leading cause of
Okay.
stent failure,
Okay.
which is largely due to poor stent expansion.
So still
Coronary calcification is
retrograde.
also associated
신,
with
신혜실 소리 좀
retrograde.
줄여주세요.
Okay, very, so the voice is overlapped. So Dr. Saito is struggling in the story. So I would like to see it instead of my presentation.
No, 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 no.
So, 斉藤さん頑張ってください。The coronary calcification is also associated with the stent delivery failure. Therefore, lesion preparation is essential, especially the heavily calcified lesion. Intracoronary imaging will provide important information about lesion morphology and procedure planning. If we do not do the intracoronary imaging, we cannot assess the severity of calcification correctly, so it lead to the inappropriate lesion preparation. As a consequence, the stent under expansion increase the complication and the prolonged procedure time, and the stent malposition and the additional stent needed. So we can use two major imaging devices, the IVAS and the OCT. So the OCT is better than IVAS because of the we can see the severity classification. We can see the severity classification by OCT, and also we can see the malposition and the stent edge detection. We can see better than IVAS. But however, the stent sizing is better than IVAS. We can decide the stent size by IVAS easily. So these represent the OCT image of the calcification, the superficial calcium, and the deep calcium, and the nodular calcium. So to decide the ideal strategy, it is extremely important to determine whether the shape of the calcification of the superficial, deep, or nodular. In addition, the thickness of the calcification must be considered to select the strategy. So these are treatment strategy based on the OCT image. If we can see if we see the calcification in the lesion, if the deep calcium, the NC was scoring balloon and the cutting balloon is appropriate procedure. But we can see if we see the superficial nodular calcium, we need a atherectomy, like a rotational atherectomy or orbital atherectomy needed. So we can calculate the calcium score by OCT. We check the calcium arc and the calcium thickness and the calcium length. We calculate the calcium score, and the calcium score is 4 is the predictor of the stent under expansion. So we need to do the atherectomy in such cases. So IVAS and OCT image this on the same region. We can see the calcium thickness by OCT, but the IVAS, we cannot see the calcium thickness. So the OCT is advantage over IVAS. But we have been using the IVAS more than 30 years, and also we have a huge data based on the IVAS. So we also introduce IVAS-derived calcium score. In that indication, IVAS calcium score, the calcium score more than 3 is we need to do atherectomy. So, but there is a limitation of the conventional through calcium. Balloon preferentially expand away from calcium, having limited effect eccentric calcium, and may predispose major dissection, and unable to modify deep and thick calcium. And On the other hand, atherectomy, the risk of distal embolization, leading slow or no flow, and procedural MI, especially using the large BL ratio bra, may cause the major dissection and perforation, especially in tortuous anatomy. This is the IVL. IVL is the intravascular lithotripsy, miniaturize and array the emitter to the local lithotripsy at the balloon. And then this is a shockwave IVL system. The negative point is the shockwave balloon is a large crossing profile, 0.44. So when you use the IVL, we almost we have to use a pre-dilation bar, pre-dilation balloon with a NC balloon, the 2.0 by 2.5, to cross the IVL system. But this is the IVL system. And acoustic pressure, the wave, one pulse travels through the tissue, and the effective pressure of almost 50 atmosphere, the fluctuate both superficial and deep calcium. This is only achieved with a low pressure balloon, 4 atmosphere. So this is the action. And IVL is only took the effective, the large difference between the fluid and the balloon. This is the calcium-like, but no effect of the soft tissues. So the advantage of IVL is the calcium. This solution allows the calcium modification to perform the low balloon pressure. This is the most advantage of the IVL than other devices. So based on this shockwave performance, this is the algorithm of the CBIT and the Japanese cardiovascular intervention. And this is the strategy based on the calcium score. If the calcium score is 4, we use IVL. But in the balloon uncrossable region, we need the atherectomy device. After checking the OCT, if there is a cracking, we put the stent. However, some ex vivo studies show the OCT, the visualization OCT is poor than that image. But we rely on the calcium crack before stenting, so we needed to crack on the calcium for the stenting. So, I cannot move. So, could you help me? Because this movie is very important to.
동영상 좀 걸어주세요.
네. 네. But at that time, I checked the slide, but in that time, it. Okay.
화면.
Okay. It's okay. So. So we try to reduce calcium volume by atherectomy before IVL. So this is the case. Okay, I try. This is a superficial calcium. You can see the very thick calcium here. So more than 1 millimeter. So we try to, in this case, first we apply the rotational atherectomy 1.75. Okay, not working still. Excuse me? Okay, I can do on this one. Okay. Change. Change image to this. Okay, we can see the some after rotational atherectomy 1.75, there is some guide bias is okay, and there are some flap. After that, IBL with 3.0, we can see the very good crack on the calcium. So we put a stent. Oh. Very difficult to control. After ballooning, and the stent, the apposition is very okay, and the stent is well expanded. The final. However, the factors, besides the calcium, there is a factor influencing the stent failure along with the small vessel disease. So this is a basket small 2 trial. This is shown this image shows that DCB is non-inferior of the DCB in the small vessel disease, and also the acute drug-coating balloon in the rotational atherectomy may have a good effect on the small vessel disease. So in this situation, this is a already diffuse small disease, and this is a significant step up here. OCT shows very 6 tight circumferential stenosis. And then in this case, we did the rotational atherectomy. The guide bias is okay. So then the bar size up, and the non-stent strategy has been done. Sorry, it's very difficult to control. This is a final angio. OCT also shows a well expanded and reduction of the calcium, no major dissection. So this is a strategy of our trying to our strategy that in the small vessel and no major dissection, we do treat the DCB. So my message, lesion preparation is mandatory in the reliable stent deployment and expansion. Intercoronary imaging-based calcium scoring system is useful for the selection of the right device. IBL is safe and simple. It is effective for pre-stent lesion preparation in highly calcified regions with a vessel diameter of 3 mm or more. In small vessel with a strong calcification with a vessel diameter of less than 3 mm, there is a concern that the function of the stent cannot be fully demonstrated. Therefore, we are trying treatment with atherectomy plus DCB in such a heavily calcified region. Sorry for the bad presentation.
Thank you very much, Dr. Zhi. Okay, before coming to the next case, we have to go to the cine room. And Dr. Saito.
Okay, so we are back.
How is the progress of your case?
Okay, no progress.
No progress, okay.
Yes, antegrade wiring and retrograde wiring faced very strong resistance.
Okay, so what is your next plan?
I tried many kinds of wires, retrogradely and antegradely, and but still at this moment I have used maybe seven choices or 5 choices of wires, different wires, together with microcatheter, and also I tried Gaia first and Gaia third as well, but not I could not pass. So maybe I have to close this session. That
Okay.
is my current conclusion.
Okay, thank you very much for your continued effort. We'll see you again later. Okay, thank you very
Okay.
much.
Sorry. Thank you.
Test.
Test.
Okay, next case will be the video live case from Gaemyeong University, and the operator is Chang-ok Nam. He is the professor of medicine and cardiology in Gaemyeong National University, Gaemyeong University Dongsan Hospital. Dr. Nam, please.
Okay, thank you. I'm Chang Nam from Gaemyeong University, and it's my great honor to have a chance to share my case. Actually, I prepared bifurcation PCI. So last year, I also prepared the 001 reason, and then I do the two-stand strategy for wrapped main. And this year, non-wrapped main bifurcation. Can you see the video? 비디오 틀어주실래요?
Video is not ready.
슬라이드는 아까 거의 업로드 했었는데 비디오를. 동영상으로만 되어 있어요. 동영상. PPT가 아니고 동영상.
앞 세션에 했던 그 같은 동영상인데.
아니면 지금 드릴까요, 거기? 드려도 돼요? 여기 그걸 해놔니까 마우스를 뽑아버려서. Okay, sorry for the wait. Yeah. So this is a 70-year-old gentleman who have a diabetes history and non-smoker. Was visit our hospital for for the resting pain. So when he checked the cardiac marker was positive. Actually, he was a cardiologist also, but outpatient clinic. So he performed the CT angiogram in other hospital first, and then we can see the CT image first. So as you can see, there is a RAD and diagonal bifurcation lesion, and then low density plaque was located at the proximal RAD, and then stenosis was detected and after diagonal branching. So CT angiogram showed 111 true bifurcation region. So we decided to perform in coronary angiogram, and right coronary angiogram was normal. And the RAD is spider view and aerial caudal, aerial and aerial cranial. There is a tight stenosis in the RAD, but still overlapped, so we performed the AV cranial view. We can detect the bifurcation. And some haziness was detected in the bifurcation area. So it's AV cranial view, aerial cranial view. So this patient, 70-year-old gentleman, and then the next elevation MI, the history of diabetes, and then according to the angiogram, definitely 111 bifurcation region, but diagonal branch looks not so long. So we have to decide our strategy, whether we do the system upfront two-stent strategy or provisional approach or additional information. So we have 3 countries, Korea, Japan, and China, and then each country's strategy can be different. So we can discuss first.
Okay. How about the Jang Won Lee? First.
Yeah, I think it looks like true bifurcation lesion, but recently I preferred one stent and then provisional additional stent or DCB. So I need more information, or some imaging or a functional study.
Okay. How about from Japan?
Yeah, probably in Japan, some specific doctor perform the DCA in this region, but it's not popular in the world. So my recommendation is that same as the previous doctor, diagonal branch for the this DCB for the diagonal branch, and the main branch I put a stent. This is my choice.
Any?
Yes, it's a very interesting case. I think before PCI, we should check intravascular imaging. It's very important because from the CT angiogram shows bifurcation disease, but from the angiogram, it seems okay. So we should check the IVUS or CT.
Okay, so we have 3 different countries' opinion, but the opinion was union. So more information about the imaging. So I performed actually IVUS, but as you can see, there is a looks thrombus in the RAD. But anyway, from the middle part of RAD, there is a moderate plaque was detected, and then very significant plaque in the bifurcation region, but thrombus looks migrated in the bifurcation area, and the proximal RAD plaque rupture and then thrombus was observed. Vessel size around 3.5 to 4.0 to the proximal part, and the really proximal part of RAD, also RAD around 5 millimeter. From the diagonal branch IVUS, there was a moderate plaque, and then crossing to the bifurcation, there is a tight stenosis with a plaque. Large amount of plaque was detected. So after the IVUS both sides, so what is your strategy? There are more panels in here. So what is your
this time from Japan first. Okay.
I usually don't change the strategy. I usually choose a provisional one, And usually, Japanese likes the modified gel technique, as I mentioned previously, and I perform there. And after that, DCB is the for diagonal branch, and stenting for the main branch, main LED.
So you mean a DCB treatment first, then the
No,
main
no, no,
method?
no, no, no. That is a very important question, and it is quite discussable. And however, in this case, we usually perform the DCB later.
Later. So main vessel stenting first, and then do the,
That's it.
How about
Of course, the stenting, after the stenting, the DCB is not feasible, not good for some kind of stent strut or something like that. And however, in our practice, as a current, there is no data about the DCB for the after stenting or something like that. Therefore, I usually do the after stenting, we use the DCB.
So you the stent in LAD first?
Yes, I can agree to stent further because for thrombosis, the DCB cannot work because the drug cannot connect with the cell. Yes, because it's blocked by the thrombosis.
Sung Lee, any comment about this?
I also did change my strategy. I prefer to provisional stenting and then the check the flow and if possible the physiologic study for diagonal branch.
Okay. As a moderator, I have another comment for that. Maybe there is a lot of thrombus. How do I remove this thrombus would be the, I think, best option. So firstly, I think I do kissing balloon inflation. And then I think I do the cutting balloon, the larger cutting balloon. Then I want to see how the lumen looks like. So then I can decide the DCB in diagonal and then put stent in the LED. That is my strategy.
Yeah, very excellent comment. Anyway, at that time, I do the similar concept. So I want to approach provisionally, and I'm not sure whether about the diagonal ostium, about the kind of just a balloon angioplasty or cutting balloon, but whether we can apply the DCB at that time. So yeah, my strategy was same as a moderator. So I need pre-dilation for diagonal branch because there was a thrombus in there. So I performed this balloon angioplasty first. So 2.5 millimeter, 15 millimeter semi-compliant balloon was applied for LAD first. And yeah, but not fully dilated. So I increased 16 atmosphere, the LAD again, and then diagonal branch, same way. And then this is after balloon angioplasty imaging. It's a very simple case, so we can have enough time to discuss. So after, actually this image is before balloon angioplasty. Anyway, so we performed the IBUS at that time. So which size should be applied for this non-left main LAD bifurcation region? So this millimeter is a lumen diameter by IBUS. So vessel diameter was bigger than this. Anyway, so distal part of LAD reference segment 3.5 by 2.96 millimeter, and then proximal part of LAD 4.27 by 3.98, so 20 millimeter vision ranks. So
again, Japan first this time.
Actually, this is a lumen diameter?
Yeah, lumen diameter.
Okay, actually, we put this stent, we consider the stent diameter. We gonna check the vessel area also. Yeah. And in the LAD, especially in the LAD, I consider the vessel area and the lumen area. So average of both it's important to put decide the stent size. So I recommend the 3.5 stent length is probably 20 or more. And this is my choice.
장훈 Lee.
Yeah, but it's a lumen size. But if I can see the IBUS image, it's very easier to decide how to do. But maybe based on this data, I'd like to try a stent size 3.0 or 3.25, and the lesion stent length should be longer than 20, about 26 or something.
Yeah, actually, recently during the bifurcation PCI, when we decide the stent size, we follow the distal reference diameter. So distal reference is 3.5 by 3.0, like so in the lumen area. Actually, vessel size is bigger than 0.5 millimeter more. So we can select 3.25 or 3.5 stent. So at that time, I select the Giants 3.25 by 23 millimeter for this reason. I adjust the location and start with 12 atmosphere, but still its under expansion was detected, so I applied 16 ATM. So after simple crossover stenting, there looks some jailing of diagonal ostium, even though I do the pre-dilation, but there you can easily detect some jailing of diagonal ostium. And then about the diagonal IBUS was 50 plaque burden, 50% plaque burden, and the reference lumen. This is also lumen, the 3 by 2.76 millimeter. So what is the next strategy after simple crossover stenting? So whether we can apply the provisional second stent or kissing referred or DCB. So actually, we discussed enough, actually. So yeah, as every commentators mentioned about that, so just the dilation with the diagonal branch and the DCB can be applied. So my strategy was the same at that time. So this is my strategy. So I want to actually we perform the pre-dilation of the diagonal branch because moderator mentioned that there was a thrombus, so we recognize whether the diagonal branch can be treated with just a DCB. So pre-dilation was performed and the simple RAD crossover stenting, and then side branch balloon and DCB, and as a Japanese side already mentioned that after stenting and then side branch treatment, and then kissing and repart can be performed. So actually, yeah, before we know that the bifurcation PCI, we need to be very careful when we provisionally approach, because we applied the smaller diameter stent for this bifurcation region. So the proximal part of a main vessel can be malopposed after just the simple crossover stenting. So we have to perform the part technique before the rewiring of a diagonal branch. So we performed the part technique with a 3.5 NC balloon, then start the rewiring for the diagonal branch. So currently, EBC recommend use the third wire for the diagonal branch, but still in Korea, some doctors use the third diagonal, 3 wire, but mostly like this way. So use the main vessel wire remove, and then from very close to side branch, then check the angio and insert the wire distally. It's a traditional technique, but even though it looks like a very good result, but we have to confirm that the wiring location with imaging, because sometimes, even though it looks like distal wiring, but sometimes the wire can pass the very abnormal location. Anyway, in this time, fortunately, the wide area stent shroud was fortunately selected, so I was satisfied this location, and then I performed the dilation for the side branch diagonal. And about we can discuss it again. So what is your DCV size for this patient? Actually, this is a rumen area, and vessel area is around 3.5. So what is the DCV size selection?
Japan?
My choice is a 2.75.
2.5?
2.75. 2.75.
2.75. Okay. How about Sung-wook Lee?
I choose the 2.5.
2.5. Okay. How do you think?
I also 2.5.
I think 2.5 or 2.75 is also okay. Because for drug-eluting, drug-coated balloon, the diameter is 0.8 to 1 is okay.
Okay.
Yeah, actually, I just want to ask about whether you applied lesser than 2.75 or more than 2.75, because the reference segment looks vessel size is very big. But when you apply the DCV, we need to very careful to don't make a dissection for side branch, because we want the DCV as a destination therapy, not the second stent. So yeah, very conservative strategy will be needed. I agree that 2.75 or 2.5, because even though 2.5, we can increase size around 2.75. At that time, actually, I applied 2.75. But unfortunately, I didn't make angio for during the DCV treatment. So this is a DCV agent, DCV 2.75 by 15 millimeter. So we already performed the pre-dilation. So I applied 2.75 around 10 ATM. Was exactly same as 2.75. Nominal pressure was applied. And then I would do the kissing balloon for this bifurcation reason, do the short overlapping for the both sides to 3.5 and 2.75, because we already see that the proximal part of LAD looks like around 4O, more than 4O diameter. So just apply the kissing with the 3.5 and 2.75 will be enough. But anyway, refot, I didn't use a more bigger balloon. So we have a limitation for usage of balloon number in Korea, actually. Insurance did not cover more than 3 in the 3 balloon for the non-left main bifurcation, so it's a limitation. So this is the result of kissing balloon and the refot, and then I performed the IVUS from the diagonal branch. The distal part has one segment of shroud was exist in diagonal part, but anyway, it's quite acceptable expanded. And about the LAD, the minimal stent area, just before the bifurcation is 8.35 square millimeter. Is quite acceptable. The stent position and the expansion is quite good. And this is a bifurcation. It's quite acceptable. And the position of a stent shroud in the diagonal branch lateral side was well opposed. And then this is the proximal part. As we mentioned that the real proximal ostial part of LAD was huge, around 5.0, more than 5.0. So I think at least 1 millimeter was malopposed. So I would like to ask that each country's strategy, the very proximal part of a malopposed 1 millimeter, should we have treat with the 5.0 balloon again, or just leave alone? What is your strategy? Can I finish with this result or additional balloon?
I think Japanese doctors use the 5-0, I think. How do you think? We have some option limitation in Korea, but maybe. How do you think?
Yeah, so in this situation, so you put this, you perform the proximal optimization at the first time. So at the time, the proximal part is almost same optimal. So your recommended part or not. So because of the, so if the treatment of distal part, stent elongation occurred in the proximally. So at that time, we gonna perform the another part to the proximal part. But in this situation, probably the length of the Malapose strut is only the 1 millimeter. So at that time, we just finish this procedure.
Okay, I think maybe very nice case, but I think Japanese doctors usually use OCT instead of IVUS. How do you think about this, Dr. Mizuno? You use OCT for this case or IVUS?
Yeah, it will be fine because the vessel size is so large, therefore we can use both of them. And because you have already used the IVUS, therefore we do not shift to the OCT in this case. And of course we can use the 5 millimeter balloon for the proximal end. And either will be fine because after the cavity, the vessel size is enough to continue the patency for the long term, especially in the non-STEMI case. Therefore, if I balloon so frequently, it induces the several inflammation and the thrombus formation or something like that. Therefore, we refrain the more balloon technique or something like that after the procedure.
Usually I like to use OCT in this situation because OCT is more sensitive for thrombosis disease and dissection. And also from the October study, it's more benefit for bifurcation disease. So I like to use OCT in this kind of case. But I think IVUS is also good. No big problem, just my favor. Yes.
Okay, so I already mentioned that in Korea we have some limitation to use of balloon numbers. So I already used the 3 balloon. So I cannot use a 5-0 balloon for this patient. Anyway, but we have some experience and data about that. The proximal part of a short segment of malposition did not make a clinical event, so I satisfied with this result. So I performed the last coronary angiogram. Even though it says there is still residual disease in the ostial of ostial of diagonal branch, but I was showed that the minimal lumen area is more than 6, so I was satisfied this result. So I performed this patient with the provisional strategy, diagonal predilation because of a thrombus in lux and bifurcation area. So I performed predilation and the LAD simple crossover stenting and do the balloon, diagonal balloon again with the DCB treatment with a little bit smaller diameter of DCB because I don't want to make a dissection for the diagonal branches. So, and then we applied the kissing balloon and leaf out and confirmed by imaging. This is my summary of this case. Thank you.
Thank you very much, Dr. Nam. We will close this session.
Yes, we'll close the section. Thank all the speakers and the panelists and Professor Kim and audience. Thank you.
Thank you very much.
Thank you very much.
Now it's time to wrap up this session. The GICS 2024 award ceremony is going to be held here next at the main arena, and there's going to be a group photo taken after the ceremony. And also, the sponsored luncheon symposium is going to be held here at the Symposium 1, room 1 at 1 p.m. Thank you. Ladies and gentlemen, the GICS 2024 award ceremony is about to begin. First of all, Dr. Bin Liu, please come to the front, please. Dr. Bin Liu, with deep application during the last 22 years of generous commitment and dedicated participation with Gwangju International Interventional Cardiology Symposium, June 7, 2024, GICS, Organizing Community, Gwangju, Korea. 예, 알겠습니다. 아. 네. 박수 달라고요?
Open. And ladies and gentlemen, esteemed colleagues. First of all, I would like to thank the GICS committee for honoring me this honor. This is a very proud moment for me and my colleagues here. My special thanks also go to Professor Jiang, the chairman of this big event, who lent me his trust and friendship for the past nearly 10 years. Being honored, being awarded with this honor means a lot to me. I think it's not just my own honor. It is a recognition of all efforts you and I both contribute in this field. Collaboration and collective efforts between us make true difference in lives of patients suffering from cardiovascular disease. For somebody has come to the GICS for 10 years in succession, I must admit, I'm deeply impressed by the work you have done for spread and communication of latest research and opinion in field of cardiovascular disease. This is a very great opportunity for us to share our knowledge, to expand our knowledge, to exchange our idea, and also push the boundaries of what is possible. Every time when I come to GICS meeting, I'm especially pleased to see so many fellows and friends in the audience, and very passionate for the development of cardiology in South Korea. It is a very great time for me to meet my old friends and new friends here. In closing, I would like to once again thank Professor Jiang and the GICS committee and all colleagues present here today. I hope the great success of this meeting. I look forward to collaborating with Professor Jiang and other colleagues here in future. Thank you so much.
And I'd like to invite Professor Young An for next GIS World Inner. So Professor An, come to stage.
For a second, Dr. Moo-Hyun Kim, please come to the front, please. Dr. Moo-Hyun Kim, with deep appreciation during the last 22 years of generous commitment and dedicated participation with Gwangju International Interventional Cardiology Symposium, June 7th, 2024, GICS, Organizing Committee, Gwangju, Korea.
예, 영어로 하는 것보다 한국어로 주로 하겠습니다. 네, GICS 어워드를 주신 우리 안정근 교수님, 정명호 교수님, 그동안에 지방 의료를 이렇게 이끌어 주신다고 많이 노력해 주셔서 그동안 진심으로 감사드리고요. 저도 JCR 미팅을 한 25년 전부터 했었는데 아마 지방 의료를 계속 좀 유지하라는 뜻으로 이 상을 준 게 아닌가 그렇게 감사를 드립니다. Ladies and gentlemen, I think the GICS meeting is an outstanding international academic event held locally, and it is a pleasure as an interventional cardiologist to see the conference evolve each year with the variety of the program and active participation from its members. And I am confident your ongoing effort will continue to ensure it remains a leading academic event representing Korea. I would like to express my deep gratitude to the many mentors and the senior colleagues who have guided me, as well as the wonderful staff at Department of Cardiology at Dongha University Hospital. I also wish to acknowledge my family who always support me to welcome source of strength and support. Thank you for all. I look forward to seeing you continuing development and further success of GICS every year. Thank you very much. 감사합니다.
Congratulations again to Dr. Bin Liu and to Dr. Moo-Hyun Kim. Ladies and gentlemen, the sponsor luncheon symposium is going to be held at 1 p.m. at Main Arena 1 and Symposium Room 1. So may I ask you all to be here 5 minutes before the session starts. Thank you.
There will be a group photo. All members come to the front. Thank you.
단체 사진 찍겠습니다. 앉아 계신 모든 분들 다 앞으로 나오십시오. 네.
and gentlemen, the sponsor lunch symposium is about to. If you see at the back, there are lunch boxes provided. Please take one and have their seats. Thank you. 뒤편에 보시면은 점심 박스가 제공되어 있습니다. 한 분씩 한 gan씩 챙겨서 자리를 착석해 주시기 바랍니다.
The lunch box is prepared in front of the gate. Please come by one of each, please.
네. 조금 시간이 이르긴 하지만 대부분 다 오신 걸로 같아서요. 런천 세션을 시작하도록 하겠습니다. I'm sorry for the faculties or foreign persons because this is a lunch time. So many Korean audience, if they can digest well, maybe Korean language is much better. So many people also want me to please the Korean expression is good for the luncheon session. 그래서 우리말로 진행하겠고요. Just only one person, I think it's 오주지 sensei. He understands Korean language very well. So if you have some problems in the Korean translation, please contact with Dr. 오주지. 예, 그러면 이 연천 세션은 유한양행에서 스폰서를 하는 것이고요. 두 연제가 있는데 첫 번째 연제는 제가 소개하고 두 번째 연제와 디스커션은 우리 김무영 교수님께서 진행해 주시겠습니다. 김무영 교수님 다시 한번 시상을 축하드립니다. 첫 번째 연제는 전남대학교 병원의 김민철 교수께서 what is the role of empagliflozin in the heart failure prevention에 대해서 말씀해 주시겠습니다. 예, 김민철 교수님 부탁드립니다.
네, 안녕히 계십니까. 소개 말씀 감사드립니다. 제가 방금 말씀해 주신 대로 제가 말씀드릴 내용은 하펠리어 환자에서 프리벤션과 트리트먼트에서 SL2 이니비터인 엠파글리프로진의 역할에 대해서 말씀을 드리도록 하겠습니다. 아시는 것처럼 하펠리어는 굉장히 유병률이 높고 굉장히 페이탈한 컨디션을 가지는 그런 증후군이 되겠습니다. 전 세계적으로는 6천만 명 이상이 신부전으로 진단을 받고 치료를 받고 있는 상황이고요. 국내 코리안 서베이를 보아도 지금 저희 2020년에 나온 신부전학회에서 나온 팩트시트인데 2000년대 초반만 해도 저희가 전 인구의 0.8% 정도인데 2018년도에 2.24%로 굉장히 특히 이제 2010년부터 급격하게 유병률이 증가하는 것을 확인을 하실 수가 있겠고요. 2018년도에 약 120만 명의 환자가 진단을 받고 신부전으로 진단을 받고 치료를 받고 있습니다. 이거는 이제 에이징 소사이어티 영향이 굉장히 큰 것으로 생각이 되고요. 하펠리어는 굉장히 치료비나 국민 이제 건강보험이나 그런 개인에 있어서 버든이 많은 그런 상황을 만들 수 있는데요. 개인적으로는 제가 5명 중에 1명이 결국 이제 평생 라이프타임에 있어서 하트페일리어를 진단받을 가능성이 있는 거고, 하트페일리어는 모든 저희가 심장 질환의 종착역이 되겠습니다. 코로나리든 아리스미아든 카디오마이오패스든 간에 결국 이제 하트페일리어로 진행을 하게 되는 것이고요. 5년 내에 약 절반의 환자가 사망하는 것으로 되어 있습니다. 이게 이제 왜 안 좋은 거냐면은 퇴원 후에 다시 재입원할 확률이 굉장히 높다라는 것인데요. 두세 달 안에 결국 이제 3명 중에 1명이 다시 입원을 하게 되고, 재입원을 반복하면 반복할수록 결국엔 사망률이 올라갈 수 있기 때문에 경험적으로 모두 다 아시는 내용일 것 같은데요. 굉장히 치료에 있어서 주의를 요하는 그런 상황이 되겠고요. 이러한 하드 클리니컬 엔드포인트뿐만 아니라 피지컬, 소셜 그리고 에모셔널한 임팩트를 가지고 있습니다. 그래서 데일리 라이프에 있어서 굉장히 저희가 임페어먼트를 야기하는 그런 상태가 될 수 있고, 제가 에모셔널하게도 엔자이어티나 디프레션을 일으킬 수 있는 확률이 약 50% 정도 증가되는 것으로 알려져 있습니다. 그래서 미국 데이터긴 한데 신부전 의료 비용 굉장히 높고 인당 연간 의료 비용 부담도 굉장히 높죠. 그래서 국내 서베이도 다르지 않을 것으로 생각됩니다. 지속적으로 증가를 할 거기 때문에 이에 대한 대비가 필요하게 되겠고요. 신부전의 진단은 저희가 바뀐 지가 몇 년 됐는데요. 예전에 제가 이렇게 학교 다닐 때만 해도 시스탈릭 하트 펠리어, 다이스탈릭 하트 펠리어 그런 용어를 많이 썼는데, 지금은 LV 이젝션 프랙처, 즉 신부전의 대부분은 좌심실의 기능 부전입니다. 레프트 하트 펠리어가 되겠는데, 레프트 벤트리큘러 이젝션 프랙션으로 해서 클래시피케이션하는 시스템을 사용을 하고 있습니다. 신부전의 진단은 예전처럼 복잡하게 이렇게 프라이밍 크라이테리아를 이용하는 것은 아니고요. 지금은 새로 증상이 발생을 하거나 원래 신부전이 있던 환자가 증상이 월스닝 되는 경우에 저희가 진단을 하게 되겠고, 되게 신부전의 증상이라고 하는 것은 갑자기 발생한 디스니아 그리고 컨제스천, 폐에 물이 차거나 몸이 붓거나 그런 것들이 포함이 되겠고요. 그 외에 스트럭처란 카디악 어브노멀리티가 확인이 되는 경우입니다. EF가 떨어져 있거나 다르스러스 디스펑션이 있거나 밸브라 디스펑션이 있거나 그런 경우가 포함이 되겠고, 진단에 있어서 BMP, 그러니까 브레인 타입 나트리우레트 펩타이드 롤이 굉장히 큽니다. 그래서 진단에 이용할 수가 있기 때문에 제가 진단할 때 그리고 예후 인자와 반드시 체크를 해야 되겠고요. 또 이러한 컨제스천 사인도 진단에 있어서 굉장히 중요한 사인이 되겠습니다. 그래서 LV 이젝션 프랙션으로 저희가 진단을 나눌 때 되게 40% 미만일 때는 하프 레프, 하프 펠리어 위드 리듀스드 EF, 50% 이상일 때는 하프 페프, 프리저브드 EF를 하고, 그 사이에 있는 EF가 이 사이에 있는 경우에는 예전에 이제 미드레인지라고 했는데 지금 이제 마일드리 리듀스드 하프 MREF라고 표현을 하고, 처음에는 저희가 하프 레프였다가 회복이 되는 경우는 따로 하트 펠리어 위드 임프루브드 EF, 하프 임프루브드 EF라고 저희가 클래시피케이션을 하고 있습니다. 물론 전통적으로는 하프 레프가 굉장히 좀 안 좋을 것으로 생각을 하고 있죠. 초기 사망률도 굉장히 높습니다. 그래서 하프 레프에서 하프 페프로 갈수록 초기 사망률이 더 낮은데요. 하지만 장기적으로 봤을 때는 하프 페프도 결코 예후가 좋지는 않습니다. 2년, 3년 갈수록 이 사망률이 높은 것을 제가 확인하실 수가 있고, 그래서 하트 페프 같은 경우도 결코 예후가 좋은 상황은 아닐 것 같습니다. 그래서 보시면은 지속적으로 아까 말씀드린 대로 하프 페프 환자가 하프 레프로 가는 비율은 낮지만 장기적으로 갔을 때 사망률은 결코 낮지가 않기 때문에 반드시 주의를 해야 되겠고요. 하프 레프와 하프 페프는 이게 클리니컬한 컨디션이나 이런 피지올로지컬한 그런 컨디션이 좀 다른 것 같습니다. 특히 하프 페프 같은 경우에는 하프 레프보다 주로 이제 인플라마토리 스테이터스가 올라가 있고 억시데이티브 스트레스, 그리고 리피드 메타볼리즘의 임페어먼트가 있고, 이런 여러 가지 NO 시그널링이 다운 레귤레이션 되는 그러한 패소피지올로지를 가지고 있다고 알려져 있습니다. 그래서 또 특징적으로는 하프 레프보다는 다른 이제 논 카디악 코모비디티가 훨씬 많이 있다고 알려져 있습니다. 오베시티나 DM, COPD나 하이퍼텐션 같은 그런 논 카디악 컨디션이 많이 더 가지고 있는 것으로 알려져 있고요. 그러면은 하프 페프가 방금 말씀드린 대로 하프 레프에 비해서 결국 그 롱텀한 모탈리티가 낮지 않습니다. 하지만 제가 SGLT2 이니비터 나오기 전에는 특별히 제가 입증된 치료가 없다라는 것이 문제였는데요. 그래서 핫펠리어 환자의 절반 정도는 하프 페프입니다. 하프 페프이고요. 이거는 뭐 지속적으로 증가를 하고 있습니다. 이거는 이제 메이오 클리닉 데이터인데 굉장히 오랫동안 관찰을 했을 때 지속적으로 가파르게 증가를 보이고 있습니다. 앞으로도 계속적으로 하프 페프 환자는 늘어날 것으로 생각이 되고 있고요. 이 프라이밍 스터디에서 제가 뉴온스 하트펠리어 환자들을 따로 분류를 했을 때, 제가 30년에 걸쳐서 관찰을 했을 때 하프 레프 환자는 유병률이 좀 감소를 하고 있습니다. 하프 MREF는 비슷한 반면에 하프 페프 환자는 유병률이 늘어나고 있습니다. 프레발런스가 늘어나고 있고요. 특히나 연령이 증가함에 따라서, 그리고 여성 환자에게 있어서 하프 페프의 유병률은 훨씬 늘어나고 있습니다. 아까 말씀드린 대로 하프 페프 같은 경우에는 하프 레프보다 이런 하이퍼텐션이나 뭐 DM 이러한 논카디악 코모비디티가 유의하게 많이 더 가지고 있거나 굉장히 많은 트렌드를 보여주고 있습니다. 그래서 방금 말씀드린 뭐 COPD나 어네미아, DM, 리널 디스펑션 같은 것들이 더 많이 가지고 있거나 뭐 확실히 더 높은 트렌드를 보여주고 있고요. 아까 이제 모텔리티가 결코 낮지 않다고 말씀을 드렸는데 하프 레프의 약 80%, 85%의 환자는 결국은 이제 시민성으로 사망을 하게 됩니다. 카디오바스큘라 데스, 카디오바스큘라 모텔리티를 보여주게 되는데, 하프 페프 환자는 또는 이제 논카디악 코모비디티가 많기 때문에 카디오바스큘라 데스는 약 60% 정도이고, 논카디오바스큘라 데스가 하프 레프보다 훨씬 많이 경험을 하게 되겠습니다. 그래서 이렇게 예후가 좋지 않음에도 불구하고 SGLT2 이니비터 나오기 전에는 특별하게 입증된 치료가 없었다라는 것이 문제였습니다. 아까 말씀드린 게 메이오 클리닉 데이터인데 보시면은 하프 레프나 하프 페프나 아까 제가 말씀드린 대로 장기적으로 봤을 때 모탈리티에 차이가 없다라는 굉장히 큰 에피데미올로직 데이터이고요. 이러한 모탈리티 말고도 데일리 액티비티의 리미테이션도 하프 페프가 이러한 하프 임프루브드 EF 그리고 하프 레프보다 훨씬 데일리 액티비티의 리미테이션이 더 많이 경험하게 된다는 것은 굉장히 중요한 사실이 되겠습니다. 그래서 이것도 뭐 비슷한 내용이 되겠고요. 아까 말씀드린 대로 굉장히 많은 랜드마크 트라이얼이 제가 하프 페프에서 이러한 여러 가지 제가 하프 레프에서 필라 메디케이션으로 사용하는 뭐 ARB나 AS 이니비터, MRA나 뭐 비교적 최근에 나온 RNA 같은 경우도 사용을 해봤지만 이렇게 프라이머리 엔드포인트를 입증을 하지는 못했고요. 그래서 2021년 가이드라인까지도 하프 페프에서 입증된 치료는 기저질환에 대한 치료, 그리고 컨제스천을 개선시키고 증상을 양호하게 하기 위해서 다이어리틱스 사용하는 것 외에는 특별히 입증된 치료가 없었습니다. 방금 말씀드린 2021년 ESC 가이드라인 레커멘데이션이고, 기저질환에 대한 치료와 더불어 다이어리틱스를 사용해 볼 수 있다라고 레커멘드를 하고 있습니다. 하프 마일드 리듀스드 EF, 하프 MREF에서도 제가 필라 메디케이션은 이렇게 2B로 레커멘데이션이 되지만 사실 뭐 거의 사용을 한다고 보시면 될 것 같고요. 그래서 이 엠파글리플로진에 저희가 긴 사실 뭐 10년 정도가 됐는데요. 그래서 간단히 좀 말씀을 드리고 특히 하프 페프에 관해서는 뒤에 조경 교수가 좀 더 잘 말씀을 해주실 거로 생각이 됩니다. 2015년 제가 유럽 당뇨학회에서 발표된 엠파레그 아웃컴 트라이얼인데요. 뭐 아시는 것처럼 아반디아 이후로 제가 모든 당뇨약은 반드시 카디오바스쿨라 제가 세이프티를 증명을 해야지만 FDA에서 승인을 하고 있습니다. 그래서 제가 엠파글리플로진도 처음 나왔을 때 제가 타입 2 DM 환자에서 세이프티 증명하기 위해서 진행된 트라이얼이 엠파레그 아웃컴 트라이얼이고요. 흥미롭게도 보시면 아시겠지만은 제 기대한 것과는 다르게 카디오바스쿨라 모탈리티나 올코스 모탈리티를 플라세보에 비해서 유의하게 감소를 시키는 효과를 관찰을 할 수가 있었습니다. 그래서 한번 프라이머리 엔드포인트는 아니지만 한번 관찰을 해봤더니 뭐 약 4년 정도 관찰을 해봤더니 하트펠리어로 인한 재입원율을 35%나 줄일 수 있었다라는 것이죠. 이 차이는 이제 처음부터 굉장히 벌어지고 있었고요. 그래서 이러한 하트펠리어로 인한 재입원율을 줄이는 것은 제가 하트펠리어 환자에서 저희가 진행되는 트라이얼에서 굉장히 중요한 아웃컴입니다. 그래서 요 베이스로 해서 그 이후에 진행된 연구가 2020년에 나온 이제 곧 말씀드릴 건데 엠페럴 리듀스드 그리고 엠페럴 프리저블드 엠페럴스는 어큐트 하트펠리어로 인한 입원 환자에서 영향력을 받던 거고 최근에 작년에 다파 MI 오늘 뭐 다파글리플로진이니까요. 엠팩트 MI가 금년에 또 아웃컴 퍼블리시가 됐고요. 먼저 보여드릴 연구는 뭐 너무나 잘 아실 연구가 되겠는데 엠페럴 리듀스드 트라이얼입니다. 엠파렉 아웃컴 트라이얼에서 카디오바스쿨라 모탈 베네핏이 분명히 있을 것 같다라고 해서 이러한 타입 2 DM 여부에 상관없이 하트펠리어 크로닉 하트펠리어 환자를 대상으로 진행을 했고 EF가 40% 이하로 떨어진 하프 레프 환자를 대상으로 해서 플라시보와 엠파 10mg을 비교를 했고 컴포지 프라이머리 엔드포인트는 CV 데스 그리고 하트펠리어란 재입원율을 컴포지트 아웃컴을 관찰을 했습니다. 너무나 잘 아시는 것처럼 2년 동안 관찰을 했을 때 플라세보에 비해서 엠파글리플로진에서 25%의 렐러티브 리스크 리덕션을 보여주었습니다. 비교적 초기부터 이 베네핏이 확인된다라는 것을 보실 수 있고요. 그 세컨더리 아웃컴 중에서 가장 중요한 하트펠리어는 재입원율도 마찬가지로 30% 정도 렐러티브 리스크 리덕션을 보여주었습니다. 그 외에 리널 프로텍션 이펙트도 있었는데요. 여기에 대해서 따로 뭐 이렇게 트라이얼이 진행이 되고 있기는 했지만 초기에는 플라시보에 비해서 GFR이 좀 떨어지긴 했지만은 종국에는 제가 약 3개월째 될 때부터 역전이 되기 시작해서 결국에는 리너 프로텍티브 이펙트 EGFR이 플라시보에 비해서 약 3.3 정도 저희가 좀 더 높은 그런 걸 보여주었고 오늘 이제 슬로프로 봤을 때도 1.73 정도로 플라시보에 비해서 리너 프로텍티브 이펙트를 확연하게 보실 수가 있습니다. 그래서 하프 레프 환자의 50% 정도에서 GFR 감소 효과를 리널 아웃컴을 감소를 시켰고요. 그래서 엠페럴 리듀스드 모두 이 카디오바스쿨라 그리고 리너 프로텍티브 이펙트를 확실하게 보여주었습니다. 그래서 그러면 이제 그 하프 레프 환자에서 엠파글리플로진의 효과는 확인을 했고 그 다음은 당연히 하프 페프 환자에서 그 효과를 보는 것일 겁니다. 엠페럴 프리저블드 트라이얼이고요. 2021년에 제가 퍼블리시가 됐고는 하프 임프루브드 EF 환자를 포함을 했습니다. 그래서 40% 이상 LVEF 환자를 대상으로 했고 엠파 10ml와 플라세보를 비교를 했습니다. 프라이머리 엔드포인트는 엠페럴 리듀스드와 동일한 연구가 되겠고요. 마찬가지로 크로닉 하트펠리어 환자를 대상으로 진행을 했습니다. 그 아시안 파퓰레이션이 약 14% 정도 포함이 되어 있고요. 그리고 40% 이상을 등록을 했다고 했는데 50% 이상 하프 페프 환자는 약 65% 정도였습니다. DM 환자는 약 절반 정도였고요. 80% 이상에서 라스트 이니비터와 베타 블로커를 사용을 하고 있었다라는 것입니다. 그래서 결과를 봤더니 엠페로 리듀스도 마찬가지로 약 21% 정도의 렐러티브 리스크 리덕션 프라이머리 엔드포인트를 충족을 시켰고요. 서브그룹 애널리시스를 봐도 성별에 상관없이 주로 이제 아시안 파퓰레이션에서 좀 더 아웃컴이 좋은 그런 트렌드를 보여주었습니다. EF에 따라서 나누어 보는 게 굉장히 중요할 것 같은데요. 아직은 그래도 그 EF가 떨어지는 환자에서 효과가 좀 더 클 것 같고요. 50% 이상인 환자에서도 확실하게 이렇게 프라이머리 엔드포인트의 베네핏은 있었습니다. DM 여부에 상관없이 그 베네핏은 컨시스턴트 했고요. GFR도 마찬가지입니다. 하지만 GFR이 20 미만인 환자는 제외를 했기 때문에 아직까지 엔드스테이지 리날 디지즈 환자에서는 조금 이렇게 사용은 조심스럽게 해야 된다라고 말씀을 드릴 수가 있고요. 포레스트 플러스는 굉장히 중요한데 기저질환으로 아무래도 저희가 하트펠리 환자이기 때문에 이런 하트펠리 약물들에다 사용을 기본적으로 하고 있는지가 굉장히 중요할 것 같고요. 그런 라스 이니비터나 MRA 그런 사용 여부에 상관없이 아웃컴은 굉장히 일정하게 유지가 됐습니다. 하트펠리어로 인한 초기 다시 재입원율을 세컨더리 아웃컴으로 관찰을 했을 때도 플라시보에 비해서 27% 정도의 개인이 있었고 엠페럴 리듀스드와 동일하게 EGFR의 레노프로텍티브 이펙트도 확실하게 증명을 하였습니다. SL2 이니비터는 사실 굉장히 막 좋은 것 같지만은 부작용도 사실 만만치 않습니다. 그럼에도 불구하고 플라세보에 비해서 잘 알려진 부작용인 하이포텐전이나 유글라이세믹 케토에시도시스 그리고 하이포글라이세믹 이벤트, UTI나 제니탈 인펙션 레이트는 차이가 없었습니다. 하지만 우리 특히 UTI나 제니탈 인펙션은 고령의 환자에서는 굉장히 주의를 해야 되고 특히 이제 케토에시도시스 환자는 굉장히 이렇게 아주 이제 어큐트한 디컴펜세이션된 하트펠리어나 카디오 샥 환자에서는 유병률이 굉장히 올라가기 때문에 그런 환자분들에서는 초기에는 조금 사용에 주의를 해야 된다라고 말씀을 드릴 수가 있습니다. 그래서 엠페로 리듀스드와 동일하게 엠페로 프리저블드에서도 프라이머리 엔드포인트인 CV 데스나 하트펠리어란 재입원율의 컴포지트 이벤트의 베네핏을 증명을 했고 리노 프로텍티브 이펙트 또한 보여주었습니다. 그래서 아까 이제 보여드렸던 저희 그래프인데 그래서 지금까지 연구와는 다르게 엠페로 프리저블드에서는 이러한 하프 페프에서 SL2 이니비터 특히 엠파글로진의 베네핏을 보여주었기 때문에 아시는 것처럼 현재 가이드라인에서는 하프 페프에서도 클래스 1으로 이렇게 SL2 이니비터를 사용하는 것으로 변경이 되었습니다. 그래서 특별한 금기증이 없다라면 반드시 사용을 해야 되는 것이고요. 실제로 저희 환자에서 이제 사용했던 케이스인데 한 2년 전에 제가 치료했던 케이스인데 74세 여성분이었고요. 하이퍼텐전으로 오랫동안 치료를 했습니다. 내용을 했을 때 어큐트 하트펠리어였습니다. 근데 그레이드 2 정도였고요. 리널 펑션은 정상이었고 프로비엠피는 1200으로 올라 있었습니다. ECG는 큰 이상은 없는데 엑스레이는 이렇게 확실히 컨제스천이 약간 마일드하게 있는 것을 확인하실 수가 있습니다. EF가 정상이었고 특별하게 스트럭처럴 어버너멀리티를 확인을 할 수가 없었고요. 하지만 E2 프라임 레이쇼가 16으로 약간 올라 있었기 때문에 결국은 제가 옛날 기준으로 다이스트릭 하트 페일리어가 다이스트릭 디스펑션이 있다라고 말씀을 드릴 수가 있고요. 처음에 말씀드린 대로 저희가 그 하프 레프보다 하프 페프에서 기저질환, 그러니까 넌 카디악 컨디션이 많다고 말씀드렸는데 고령, 여성 그리고 하이퍼텐전 모두 충족시키는 그런 환자분이 되겠고요. 원래는 이제 ARB를 메디케이션을 하고 있었고요. 제가 퇴원할 때 이렇게 MRA와 프로세마이드 그리고 엠파 10ml를 추가를 했습니다. 그랬더니 3주 후에 제가 외래에서 팔로우업을 했고 엑스레이도 깨끗했고 증상은 거의 없었습니다. BMP도 270일까지 떨어져서 현재까지 아무런 문제 없이 외래 팔로우업하고 있는 환자입니다. 예, 경청해 주셔서 감사합니다.
예, 김민철 교수님 감사합니다. 다음 연재는 전남의대 조경훈 교수께서 자디앙 The First Successful Result for Heart Failure with Preserved Ejection Fraction이라는 연재로 강의해 주시겠습니다. 조경훈 교수님 부탁합니다.
네, 안녕하십니까. 전남대학교 순환기내과에서 근무하고 있는 조경훈입니다. 자디양에 대한 내용인데 김민철 교수님께서 앞에서 이제 가장 중요한 엠퍼러 리듀스드 엠퍼러 프리저브드 트라이얼에 대해서 더 자세히 설명해 주셔가지고 저는 좀 중복된 내용들은 빨리 넘어가고 진행을 하도록 하겠습니다. 이제 엠파글리플로진이 이젝션 프랙션에 상관없이 카디오바스 데스와 심보전에 대한 입원을 유의하게 줄이는 거의 첫 번째 약물로 이제 증명이 됐습니다. 그래서 앞서 설명을 해주셨던 엠퍼러 리듀스드, 엠퍼러 프리저브에 대해서 메이저 카디오바스 엔드포인트를 유의하게 줄였었고요. 또 이제 키드니에도 굉장히 좋은 효과를 보였습니다. 엠퍼러 리듀스드, 엠퍼러 프리저브 공이 이 EGFR의 감소가 엠파글리플로진을 사용함으로써 EGFR의 감소를 굉장히 둔화시키는, 그러니까 신장에 이제 보호 효과가 있는 그런 결과를 보여주었습니다. 그래서 이런 이젝션 프랙션 상관없이 이 엠파글리플로진이 이 사망과 심보전의 입원을 줄여준다는 것은 이제 증명이 됐고요. 그 이젝션 프랙션을 좀 더 자세하게 나눠보면 이게 이제 엠파라 프리저브드 이제 엠파라 프리저브드 엠파라 리듀스드의 이젝션 프랙션입니다. 보시게 되면 10%부터 40% 같고 또 이제 40% 이상에서부터 거의 80%까지 분포가 되어 있는데요. 이 환자들에서 공이 이 프라이머리 엔드포인트의 감소가 1 미만인 것을 알 수가 있습니다. 이제 이젝션 프랙션이 올라갈수록 조금 더 이 그 이득은 줄어들지만은 여전히 1 미만으로 이 카디오바스쿨 이벤트 감소 효과를 증명을 하였습니다. 그리고 이제 이 엠펄스라고 하는 그런 이제 연구가 추가로 시행이 되었는데 이것은 이제 기존의 연구들은 이제 아큐트 스테이지는 아니었습니다. 근데 임펄스는 이 아큐트 허트 페일러 환자에서 어떤 베네핏이 보이는지 증명을 했고요. 36% 정도 카디오바스쿨 이벤트를 감소시키는 효과를 보였습니다. 간단히 설명드리자면 이 아큐트 허트 페일러 환자 530명을 엠파글리플로진을 주는지 아니면 플래시보를 주는지 랜덤을 했고요. 입원해서 평균 미디안 값이 3일째 환자가 랜덤이 되었습니다. 그러니까 굉장히 초기에 엠파글리플로진을 사용을 하게 된 건고요. 이 환자들에서 이제 사망이나 하트 페일러 이벤트, 타임 투 퍼스트 하트 페일러 이벤트 그리고 퀄리티 오브 라이프를 측정을 했고요. 결과를 봤더니 이러한 그 컴포짓 클리니컬 이벤트가 플라시보에 대비해서 이 엠파글리플로진이 우월한 것으로 설명이 됐습니다. 그 정도는 36% 정도 플라시보 대비해서 엠파글리플로진이 이러한 사망 또 하트 페일러 이벤트 이런 퀄리티 오브 라이프에 있어서 또 우월하다 이렇게 결과가 나왔고요. 그래서 정리하자면 엠펄스 결과는 올코스 모탈리티 그리고 하트 페일러 이벤트 관련해서 엠파글리플로진이 플라시보 대비해서 유의한 그 카디오바스쿨 이벤트 감소 효과를 보였다라는 것입니다. 이게 이제 우리가 하트 페일러 환자 중에서 드누보 그러니까 전혀 하트 페일러에 과거리가 없었던 환자나 아니면 하트 페일러 환자가 있었던 환자가 급격히 악화됐던 디컴pensated 크로닉 하트 페일러 환자나 공이 이 엠파글리플로진이 이득을 보였었고요. 또 이젝션 프랙션이 40% 미만이었던 환자나 40% 이상이었던 환자 모두 엠펄스에서 유의하게 카디오바스쿨 이벤트 감소 효과를 보였습니다. 세컨더리 엔드포인트는 이제 하나씩 다 봤을 때도 이제 플라시보 대비해서 유의하게 이 카디오바스쿨 이벤트를 감소시키고 퀄리티 오브 라이프를 개선시키는 결과를 보였습니다. 애드버스 이벤트를 봤을 때 이게 까만 게 플라시보, 보라색이 엠파글리플로진인데요. 유의하게 증가시키는 그런 결과는 보이지 않았었습니다. 그래서 인하스피탈 아큐트 하트 페일러 환자에서 36% 정도 플라시보 대비해서 엠파글리플로진은 클리니컬 베네핏을 보였었고 이게 이젝션 프랙션과 상관이 없이 또 드노브인지 디컴pensated chronic heart failure인지 상관없이 이득을 보였다는 것이고 사이드 이펙트 면에서도 특별한 문제가 없었다는 것입니다. 그래서 엠파라 리듀스드 엠파라 프리저브드는 이제 크로닉 하트 페일러, 또 엠팔스는 아큐트 하트 페일러 환자에서 이 엠파글로프로진이 컨시스턴트하게 좋은 결과를 보였음을 증명을 하였습니다. 추가로 서브그룹이나 이런 이제 좀 살펴볼 건데요. 저희가 이제 결국 엠파글로프로진을 쓰게 되면 이게 이제 다이우레시스, 소변을 보게 하고 그러기 때문에 이제 뭐 디하이드레이션 된다든가 혈압이 떨어진다는 그런 걱정을 하실 수가 있는데, 이런 엠파라 리듀스드 그 트라이얼에서 이 혈압이 기존에 110 미만이었던 환자들에서도 특별하게 하이포텐션이나 심토면 하이포텐션을 늘리지 않는 것으로 보고가 되었습니다. 그리고 저희가 이제 미네랄 코티코 리셉터 안타고니스트를 많이 사용하는데 이거 사용과 관계없이 카디오바스 아웃컴에 베네핏이 있었고요. 이제 다이우리시스를 하기 때문에 이제 여러 가지 일렉트로 임밸런스가 생길 수가 있는데, 하이퍼칼레미아의 발생은 플라시보 대비해서 오히려 엠파글로프로진 줄였고요. 하지만 하이포칼레미아는 그렇게 또 증가를 시키지 않았었습니다. 그리고 이 이뇨제를 사용을 하는 그런 빈도도 엠파글로프로진이 더 줄였습니다. 그리고 이 굉장히 이게 좀 특이할 만한 이제 파인딩인데요. 저희가 사실은 이 약을 썼을 때 이득이 언제 나타나는지 그런 게 중요한데, 엠파라 리듀스 앤드 프리저브드 공이 다 지금 12일째, 18일째 통계적으로 유의하게 엠파글로프로진 이득이 나타났습니다. 굉장히 특이할 만한 상황이고요. 그러니까 약을 쓰면은 보통 2, 3주 이내에 이 약의 그 굉장히 효과가 그 클리니컬한 베네핏이 증명할 정도로 효과가 빠르다는 것입니다. 그리고 이제 중환자실에 입원하게 되는 그런 이벤트도 리듀스드 프리저브드 모두 엠파글로프로진이 유의하게 감소를 시켰고요. 퀄리티 오브 라이프 스코어를 측정했을 때도 허트펠러 환자들의 심텀을 굉장히 개선을 시켰습니다. 그래서 이 엠파글로프로진은 이제 다른 여러 가지 신부전 약제에 비해서 하루에 한 번 사용하고 또 싱글 도스이고 타이트레이션 필요 없는 굉장히 편한 약제가 되겠습니다. 그래서 2016년에 유로 가이드라인에서는 리듀스드 이젝션 프랙션 40% 미만인 허트펠러 환자에서 스텝와이드 어프로치를 레커멘드 했는데, 2021년에 이 네 가지 약제를 처음부터 이제 쓰는 게 좋겠다고 공고를 했는데, 그 중에 SGLT2 이니비터가 들어가 있습니다. 유럽 허트펠러 가이드라인에서 2021년에서 이제 이 엠파글로프로진, 다파글로프로진이 이 허트펠러 리스크를 감소시키는데, 이 리듀스드 이젝션 프랙션 환자에서 클래스 1A로 레커멘드 됐고요. 또 이 네 가지 약을 사망을 감소시키기 위해서 허트펠러 리듀스 이젝션 프랙션, 이젝션을 40% 미만의 환자에서는 꼭 써라 강조를 하는데, 이제 아르니, 베타블로커, 미네랄 코드 리셉터 안타고니스트와 SGLT2 이니비터가 이렇게 강조가 되고 있습니다. 그래서 이 허트펠러 리듀스 이젝션 프랙션 환자에서 이제 가이드라인에서 가장 중요하게 강조하는 약이 이런 아르니, 베타블로커, 미네랄 리셉터 안타고니스트, SGLT2 이니비터 첫 번째 스텝 1에서 사용을 하는데, 중요한 것은 동시에 그냥 바로 시작을 하고 뭐 타겟 도싱에 도달할 필요도 없다. 그리고 절대 이 네 가지 약은 딜레이 되면 안 된다. 이렇게 강조를 하고 있습니다. 그리고 이 레커멘데이션은 클래스 1A는 여러 가지 이제 RCT에서 증명이 됐다는 것으로 이제 그 보고를 하고 있고요. 2022년 미국 이제 가이드라인에서 이제 그 SGLT2 이니비터가 40% 이상인 마일드 리듀스드 이젝션 프랙션 40에서 49%, 그리고 50% 이상인 프리저브 이젝션 프랙션 환자에서도 40% 이상에서 클래스 2A로 SGLT2 이니비터를 레커멘드를 했고요. 일단 그 당뇨가 있는 환자 중에서 ACE CVD가 있거나 하이리스크 환자는 이 허트펠러의 입원을 감소시키기 위해서 클래스 1A로 이젝션 프랙션 관계없이 타입 2 DM에서 하이 리스크 환자들은 SGLT2 이니비터를 쓰라고 강조를 하고 있습니다. 그래서 마일드 리듀스드 40에서 49%, 또 프리저브드 이젝션 프랙션 50% 이상인 허트펠러 환자에서 클래스 2A로 레커멘드 됐는데, 이 레커멘데이션은 다른 허트펠러 드러그인 아른이나 MRA, ARB보다 훨씬 더 높은 레커멘데이션입니다. 다시 말씀드리지만 당뇨가 있는데 환자가 ASCVD가 있거나 하이 카디오바시 리스크가 있다고 하면 SGLT2 이니비터를 이젝션 상관없이 사용하라고 클래스 1A로 강조를 하고 있습니다. 그래서 리듀스드 이젝션 프랙션 40% 미만인 허트펠러 환자에서는 뭐 당연하게 이제 SGLT 이니비터가 그냥 클래스 1A고요. 이제 40% 이상에서도 클래스 2A로 공고가 되고 있는 가장 허트펠러 드러그 중에서 가장 효과가 입증된 약이다라고 설명드릴 수 있겠습니다. 그래서 이 처음에도 말씀드렸지만 허트펠러는 전 세계 6천만 명이 겪고 있고 65세 이상에서는 이제 입원하는 가장 첫 번째 원인입니다. 그리고 입원 이후에 다시 재입원하는 비율이 30% 이상으로 굉장히 높은 이런 그 재입원율을 가지고 있는 질병이고요. 그래서 또 이런 신부전 환자 중에 입원을 하게 되면 30%는 1년 내에 사망하는 굉장히 치명적인 질병입니다. 이 질병이 이제 엠파글루프로진이 이런 효과를 이젝션 프레임에 상관없이 카디오바스쿨 이벤트를 감소시키고 이 효과는 여러 가지 카테고리, 또 이게 처음 발생한 허트펠러인지 아니면 디컴pensated 허트펠러인지 또 아큐트 허트펠러인지 상관없이 효과를 보였었고요. 특별히 애드버스 이벤트가 유의하게 증가하지 않은 세이프한 약이다. 그리고 하루에 한 번이고 특별히 타이트레이션도 필요 없고 굉장히 안전하게 이젝션 프랙션 eGFR이 20 이상이면은 안전하게 사용할 수 있다는 그런 좋은 약으로 증명이 돼서 저희 클리니컬 프랙티스를 많이 바꾸게 된 약이 되었습니다. 이 자대항이 이제 제2당뇨병에 추가로 이제 만성 신부전 환자에서 이런 사망 및 신부전을 감소시키기 위해서 현재 이제 보험급여가 적용이 되었습니다. 네, 경청해 주셔서 감사합니다.
조계은 교수님 감사합니다. 혹시 김민철 교수님도 계시나요? 아, 예. 두 분 위에 잠깐 올라오셔서 질문 한두 개만 하고 하겠습니다. 김민철 교수님 먼저. 혹시 플로우에서 질문 있으시면 하시고요. 제가 김민철 교수님 뭐 아까 질문 하나 드리면 그 아시아인들이 조금 더 효과가 좋은 걸로 그렇게 돼 있는데 혹시 뭐 바디웨이트나 바디매스 인덱스가 적어서 그런지 아니면은 실제 효과가 좀 다른 건지 한번 어떻게 생각하십니까?
사실 이게 뭐 이렇게 샘플 사이즈 자체가 맞춰지지는 않았는데 굳이 뭐 이렇게 제 생각으로는 그 말씀하신 대로 전체적인 체질량 자체가 좀 작고 이게 뭐 플루이드를 빠지면서 이게 효과를 나타내는 약제이기 때문에 그런 부분들이 조금 관여하지 않았을까라는 좀 생각을 하고 있습니다. 네.
예, 조경훈 교수님. 예, 이게 이제 당뇨 약제다 보니까 실제로 우리 쪽에서 약을 쓰고 싶긴 한데 당뇨 파트에서 약을 다르게 쓰고 있으면 이걸 어떻게 좀 해결하는지 거기에 대해서 한번 좀 의견을 주십시오. 또 반대로 우리는 안 쓰고 싶은데 그쪽에서는 아주 세게 쓰고 있는 경우도 있거든요. 그래서 혹시
네, 당뇨 파트에서 같이 다니는 경우 말씀하시는
그렇죠, 그렇죠. 예.
네, 솔직히 좀 민감하고 어려운 내용인 것 같습니다. 제가 그냥 당뇨약을 쓰고 있으면 이제 그 예를 들어서 DPP4 이니비터 쓰고 있으면 저는 요즘 이제 SGL 이니비터로 그냥 많이 바꾸는 경우인데, 만약 내부민내과를 같이 다니고 있는데 내부민내과 교수님이 그냥 DPP4 쓰고 있고 굉장히 그 당뇨가 조절이 잘 돼요. 그럼 저는 사실 그냥 그대로 두고는 있거든요. 그래서 예, 교수님들의 또 어떻게 하시는지 궁금합니다.
아마 여러분 잘 아시다시피 그 해리슨 텍스트북이 있지 않습니까? 지금 해리슨 텍스트북이 21판까지 나와 있거든요. 그 20판의 하페일러 편을 보면 그 SGLT2 이니비터가 이머징 그 뭐 원오브 드러그 포 하페일러 이런 비슷한 용어로 써져 있어서
이제 굉장히 SGLT2 이니비터가 그 하프페일러의 각광을 받을 것이다라고 이제 서광을 비춰주는 이야기를 했다가 드디어 이제 2021판 해리슨 텍스트북 보면 그 사실 교과서에 어떤 약이 등장하기는 쉬운 일이 아니거든요. 가이드라인에 나와더라도 한참 검증이 끝난 상태에서 이제 나오는데 21판에 확실히 하프페일러의 그 중요한 드러그로서 이제 인정받는 것이 나왔는데요. 두 분께 같이 질문을 드리고 싶은데, 그럼 이거는 SGLT2 이니비터의 클래식한 이펙트입니까? 아니면은 그 특정 자대양 같은 약물에 더 선호할 수 있는 그런 이펙트인가요?
예, 그 뭐 저기 자리가 자리인 만큼 뭐 저도 자리양을 많이 사용은 하고 있는데, 아시는 것처럼 제가 2021년에 엠페럴 그 프리저블드가 나오고 작년에 저 ESG 하트페일리어 가이드라인이 좀 업데이트가 됐습니다. 하트페일리어만 주로 업데이트가 됐는데 주 업데이트된 내용이 저기 하프 MREF와 하프 페프에서 드디어 저기 엠파글리프로진과 다파글리프로진이 클래스 1 인디케이션을 획득을 했거든요. 그래서 지금 현재 이제 제가 그 하프 페프에서 쓸 수 있는 무기가 하나 이제 늘어났다는 것이고, 그래서 현재까지는 그 두 약제가 가장 파워풀하고 이제 제가 특별한 컨트라 인디케이션이 없다면은 반드시 제가 최근에는 이제 응급실에 와도 EF에 상관없이 저희가 처방을 하고 있고, 아쉽게도 아직 뭐 하프 페프에서는 보험이 안 되기 때문에 뭐 이렇게 오프레벨로 해가지고 처방을 해서 굉장히 많은 저희가 베네핏을 좀 보고 있습니다.
네, 조경 교수님도 뭐 하실 말씀 있으세요?
저는 사실 두 가지가 다 있다고 생각을 하거든요. TPP4 이니비터도 뭐 클래스 이펙트도 있지만 또 약마다 조금씩 다른 효과와 또 부작용이 있고, 그런데 지금 뭐 엠파글루프진, 다파글루프진 굉장히 다 효과적으로 보이고 있으니 클래스 이펙트는 뭐 기전적으로나 맞는 것 같지만 또 약마다 또 약간씩 작용도 다르고 여러 가지 좀 사이드 이펙트도 다른 걸 보면 또 아주 클리니컬한 그 어떤 트라이얼에서 또 증명된 엠파글리플로진을 쓰는 것이 그래도 더 또 임상 현장에서는 또 더 많이 그렇게 진행되지 않을까 그렇게 생각이 됩니다.
네, 감사합니다.
네, 두분 인자분 감사드립니다. 이거로 유한 스폰서 세션을 마치도록 하겠습니다. 감사합니다. 네, 감사합니다.
나중에 할게. 뭐 컴퓨터 이렇게 갑자기 느려지냐? 네, 쌤. 아,
Ladies and gentlemen, it's time to open the live case session 5 and 6, TVAR, and TAVR. Let me introduce the chairman of this session, Chris Gwangju Wong from St. Paul's Hospital, Hong Kong, Satoshi Yasuda from Tohoku University School of Medicine, Japan. Thank you.
Announcement. May I ask all the panelists if possible to come and join us? Dr. Jing Zhuang from Zhongnam Hospital University, Dr. B.H. Huang, Dr. Wang Jen Kim from the Champudang Hospital, Dr. Sang Yong Nim from Korean University, Dr. Yisik Kim from the Chung Pok National University, and Dr. J.H. Choi from the St. Carol Hospital.
Yeah, welcome to this live session, case 5 and 6, TAVR and TAVR. So I'd like to welcome to the operator of this live session, Dr. Kim and Dr. Han, and the live session will be delivered from the Chongnam National University.
Thank you, Chairman. It's a real live. It's not that real live. It's a recorded case.
Okay.
I'm the Joan Kim from Chongnam University Hospital, and Daewon Hyun is the co-operator. My case is 85 female patient. This is a past history is AVR, maybe 19 years ago, but they developed the dyspnea. So echocardiogram is tissue valve is a dysfunction with severe aortic stenosis, and the moderate AR with the moderated paravalvular leak. And as this score is very high risk, and coronary artery, peripheral artery is insignificant stenosis. Let's see the echocardiogram. This is a destruction of the tissue valve with the AR and the severe aortic stenosis with the moderated paravalvular leak. And cardiac CT for measurement is my minimal diameter is 18, maximal diameter is 12, and perimeter and area divided is 19 millimeters. So calcium is this deposition, and this tissue valve is C magna 30 and 21 millimeter. So we measurement is and the recommended for the if the balloon is stable is sapien 21 millimeter, and the self-disturbance is Evolor Pro 23 millimeters is recommended. Cardiac CT is aortic angulation is 50 degree, and coronary height is available, and the valve 2 RCA and the valve 2 LCA is below above the 5 millimeters. So coronary is not impossible to no protection required, and abdominal aorta is no problem. And if the cerebral protection system is innominator is very large, so filter is not in this area. So if the cerebral protection system is we use this area the filter. Discussion point is which valve selection, balloon is stable or self-stable, and discussion is coronary artery obstructions, and so this case is valve fracture is available or the recommended or non-recommended. This is implant depth. This is a discussion point. Let's discuss.
So I think we can discuss one by one. In terms of the Before that, actually, can I ask the panelists, how many of you, when you do the valve, will put in a protection device for the carotid arteries, like the Sentinel? Anyone?
I used it. I wanted the Sentinel is wanted prepared the cerebral protection Sentinel, but Sentinel is the recommended areas is it's a more large artery is innominate artery, but we available this area is a Sentinel is covered the filter. It's not this area. Discussion is
Yeah. I mean, you decided to do or not to do the Sentinel device? Not to do.
We just available the one is a central device is available, but other device is not available in Korea.
Okay. Yeah. How about any Japanese experience? No. Yeah.
Maybe the
we have two type of valve is
Yeah.
available. Yeah, right
Okay,
now.
yeah.
Yeah. Sorry.
Yeah. And we can talk about the next one. Yeah. What kind of valve will be suitable? Yeah. Self-expand or balloon expand type valve that you choose for this patient. And another thing is, do you want to fracture the first valve before you put in a larger valve? Because 19 is a very small valve, and the benefit might not be as obvious, but will you actually consider to fracture the valve beforehand? Yeah, any panel comment?
So it's a size is 21 and so 22 millimeter balloon using the Atlas Gold. This is a fracturable this patient. So I choose the balloon fracture. And the other discrepancy is implanted depth, because the recommended depth is 4 millimeter, but this patient is paravalvular leak is operation the valve, so a tissue valve outside the paravalvular leak is present. So I wanted the more deep implantation the valve for the cover the PVR of the OP valve. So usually recommend the 4 millimeters depth, but I selection the deep implantation.
Yeah.
And the cerebral protection system. So our plan is a valve C magna to 21 millimeter using Evolo Pro plus 23 millimeter valve, and deep implantation and using the valve fracture with the Atlas Gold with cerebral protection system. How about?
So another question that sometime when we're doing the valve, although I don't know, not all the operator might use TEE guidance as well. One features in situation like that, particularly if you want to do a deep implantation, TEE might be helpful because you don't want to pinch on your anterior leaflet of your mitral valve, because that might causing problem as well. So actually, most of the time, if we want to have a valve-in-valve situation, we would like to put in a TEE as well. We would like to do the whole operation under GA so that we can put in a DE, and we would like to monitor the depth of the implantation at the same time so that we don't want to have a pinching on the leaflet of the mitral leaflet. So I think, I don't know whether you will have any comment on that or not.
So this is cerebral protection, so with left radial puncture and the aortogram, and this is other side is left radial approach to the pigtail, and left temporal insertion with using the left femoral vein and the temporal pelvis insertion. And test the pacing. and aortogram. This is a left radial lateral approach, and aortic regurgitation. So and paravalvular leak, and then right femoral puncture, and the dilation with the sentinel introducer Swiss insertion, and then the Swiss this is a Medtronic system. This is a 14 branch the sentinel introducer Swiss insertion. And then sentinel insertion with the choice PT wire. This is a choice PT wire in the sentinel insertion. Some angulation, but the wiring is overcome, and then and the aortogram for the innominate artery and the arch to the left carotid artery, the Swiss, and the selection the and first filter is this area. So because the innominate artery is very large, so we must see the filter is the first filter is this area, and we selection the left carotid artery. Whenever they ask the questions, so we stop the play. So and arch and the distal filter is insertion at this area. And then with the TAVI procedure. First time the cross the wire, but very difficult. This patient is cross the aortic valve because this is maybe the 19-year-old tissue valve and the very severe aortic stenosis, and but luckily the wire crossed, and then exchange wire to the stiff wire. And I plan to the pigtail cassetta and the hemodynamic check.
What's the measurable gradient across the hemodynamic check? Can you show us?
Yes. Pardon? One more question?
Yeah, your hemodynamic check, I mean the intra-valve gradient.
Oh, yes. Pressure gradient. I want so insertion the pigtail and then the two pressure gradient. But 지금 pigtail is an insertion fail to the cross the valve. So with the more the stiff wire exchange, but pigtail is not fail. So we balloon, small balloon, the 7 millimeter size, the pre-dilation, the ballooning. And retry the pigtail insertion. Just the small dilation, pre-dilation with the 7 millimeter size balloon, because the crossover the pigtail. But we we pigtail insertion is fail. So we just AL cassetta reinsertion, and then check the pressure gradient. Check the pressure gradient is peak to peak is 97 millimeter mercury, and then with the insertion the safari wire. And test the valve mounting state, check. And the predilation with the 22 millimeter size the balloon with the pacing. And we try the TAVI procedure. It's cross is very good. Well, it's this time. And but axis is very angle is 50 degree, but aorta is, arch is very straight, so the axis is mismatching. So I pushed the wire and the valve, but it's not the correction. So I tried this area. And I wanted the deep insertion, so usually the 4 millimeters is not the 4 millimeter. I wanted the 8 above the 8 to the 10 millimeter depths. And started the deployment. But this angle is so very not alignment. Alignment is not so. Maybe the more the for the LV size. So
do you think this is a little bit too deep at that moment?
That is but check the level is so mild, the deep, and the so I recapture.
Yeah, so you actually retrieve and then deploy a bit higher.
Yes. So one more try.
Dr. Chuan Kim.
Yes.
I'm Kyuk Jang.
Yes.
Yeah. Did you hear me? My voice. So your implantation view is not actually not three-cost view. So why do you choose this implantation view? Is two the surgical valve frame, the parallel, one is the outside, the other side. So I ask you the three valve frame is the equal distance. There is perfect implantation view, right?
I totally agree. But at the time, it is axis I don't know, so change the view and then try. But this is mild deep. I planned the 8 millimeter, but it is maybe the 10 millimeter. But this is acceptable, so I totally the implantation. Because the covered the paravalvular leak in the outside of the tissue valve.
And may I ask you another question?
Yes, sir.
Yeah. So this patient originally received surgical valve of 21 millimeter. So actually, we define small aortic annulus less than 21. So in patient receiving surgical valve less than 21, the valve fracture should be needed. I think valve fracture, and then the larger size evolute are 26 millimeters, better for her patient later hemodynamics or long-term durability.
Okay, this is one more option. So, but either using the 23 the self-extendable valve the insertion, and then 22 millimeter the balloon using the valve rupture is try. And so we to the echocardiogram at that peak to with and we use the post dilation with the Atlas Gold, the 22 milli size the balloon. It's also insertion and
Yeah, doctor.
left pacing with the balloon, and this is main the not the covered, so with maybe the dilation pressure is maybe to the 20 mercury at that time, at that ruptured and disappears. So pressure decreases in the balloon side. This is successful the balloon rupture. And check the echocardiogram at that time. So if the before the balloon fracture is peak the velocity is above the 3 meter mercury, 3 meter per sec the velocity the aortic valve. So after the balloon rupture is maybe the below the I wanted the 2.5 meter per second low is wanted. Peak velocity is 2.5 meter per sec. So maybe the successful the balloon rupture, balloon with the valve rupture. So we check the hemodynamic. And the peak to peak also remained, but our model cell line injection and then time. And then peak pressure gradient to check the mean is 3 millimeter mercury. And the aortogram was the mild PVR.
Dr. Kim, how did you confirm the valve was fractured or not? Which sign did you recognize during the atherosclerotic ballooning?
So dramatically pressure is maybe the 20 ATM is decreased by the 0 to decrease, and the sound is tuk, and the balloon is expanded. So it's recognize the valve fracture.
I think you planned valve fracture, and 26 millimeter evolute is better than 23. If you decide valve fracture, the implantation.
And then sentinel remove. This is my slide, and then pressure gradient is mean pressure gradient is 44 millimeter mercury, and the post the TABA is 3 millimeter mercury per mean gradient, and the many material is filtered to the sentinel. This is maybe the silk in the using the valve, tissue valve to the aortic material. So cerebral protection is needed for this patient. And after echocardiogram, it is Vmax is 3 meter per sec. The mean pressure gradient is 22. And the paravalvular leak is moderate. Is very mild or the scanty paravalvular leak the decrease. So it's a successful the compress the tissue OP valve, and then the other compression the paravalvular leak is a successful procedure. This is my last slide.
Yeah, that's very nice, actually. Thank you very much, Dr. Kim. Any questions from the panel?
Go ahead, Dr. Zhang.
Yeah, I've never done the cerebral protection device. So I ask two questions. How many patients do you use the cerebral protection device? And second one is which time is better to perform the valve fracture, before balloon fracture, before balloon implantation, or after balloon valve implantation? Which one is better?
My experience of cerebral protection is just 22 patients. So because the available in Korea is a very recent time. So, but I usually this time is maybe the 1/3 patient is cerebral protection system. But this is not insurance, so the patient is wanted and then using the cerebral protection system. And second is valve fracture is pre-valve fracture compared to the post valve fracture is data is more safety in the after TAVI, and the valve fracture is more safety is in data. But I don't know, but Dr. Zhang recommended the pre-dilation, pre-valve fracture, and the more large the TAVI system is okay. But I'm just small the TAVI valve, and then after the valve fracture is I'm using. I don't know which is more the.
Yeah, but she had a moderate AER before
Yes.
this procedure, so maybe she will tolerable with the pre-valve fracture. I think I just the opinion.
Previous the aortic regurgitation is one is the valve destruction, and then at that time at the area is the regurgitation, and the moderate to the paravalvular leak is because the valve outside the aortic regurgitation. So I wanted the valve fracture and the dilation the TAVI valve, the compress this area wanted as a deep insertion. So this result is decrease the aortic regurgitation in the valve area, and the paravalvular area is covered the TAVI valve.
Any question from the panel?
One more question. In most usual TAVI cases, we decide implantation depth within 3 to 5 millimeters to prevent to protect left bundle branch. How can you decide your in this patient implantation depth?
So usually the depth is target is 4 millimeter, but this case is I wanted the compress the north side and the paravalvular leak is covered, so high inflammation. But if this patient did not develop the complete alveolar, but some it's very risky for the
yes, very high risk.
very deep insertion and then the valve fracture. And this is risky for the complete alveolar.
Have you considered just deploy about 6 millimeter down instead of 8, which is a little bit very deep actually to our concern. So it might be actually another possibility that might resolve your paravalvular leak as well. Because nowadays the modern they have the skirt that also preventing some of the paravalvular leak as well. So that might be one of my considerations in this situation. Yeah, but anyway, this is a very good case demonstrating that nowadays we not just doing primary TAVI, but we can do valve-in-valve situation, which is a very complex consideration. And in this 85-year-old lady, the surgical risk is so high and the redo of aortic valve replacement is so high. So this is demonstrating that nowadays with this kind of minimal invasive technique and with the cerebral protection devices, we really can actually give her the best choice to compensate or to treating her very difficult case to treat. So we should like to thank Dr. Kim for his excellent case. Yeah, thank you.
Okay, we move to the next topics. I'd like to welcome Dr. Daisuke Hachinohe, Sapporo Cardiovascular Clinic, Sapporo, Japan. The title of his special lecture today is Management of the Embolized THV. So if Dr. Hachinohe, if you are ready, please start.
Okay, thank you very much. Good afternoon, ladies and gentlemen. So I'm from Sapporo, and I'm Daisuke Hachinohe. So thank you for having me. Actually, I studied at the Chonnam National University Hospital 15 years ago. So Professor Chong or Ang or other doctors are my teachers. So I have these conflict of interest. So as you know, there are some causes of valve migration or embolization, and ranging from anatomical issue and technical issue. So this is a female in her 80s. This is very usual case of TAVI. And you can see the bulky calcium at the non-coronary side. And this annulus area was 385. So at that time, only Sapien XT was used in Japan, so we implanted XT23. But during the implantation, pacing failure occurred. So I will skip this one. So like this, so pacing failure occurred. So valve moved to downward, and within 10 minutes, like this. So the this THB go toward downward to LV. So what we did was recross wires through both native valve and THB. So fortunately, we can cross very rapidly and recapture with a 23 millimeter balloon. So I'll skip this one. So we can bring back the balloon to the annulus, but migrated again and again. So what we did next is post-dilation using 25 millimeter balloon, and immediately after that, severe transvalvular leakage occurred and fell into shock status. And immediately we implanted 26 millimeter balloon, like a tub-in-tub procedure. So actually, patient recovered fully, and the patient is very nicely getting better. So this is next case is a female in her 80s. This is also very ordinary case. The area, but annulus area is 425, and the perimeter is 75, and there is no specific feature for tower. So in this case, we use Nabita valve, and after using box 3, this is non-compliant balloon 18, so according to minimum diameter of annulus, but we can see some NUE. NUE stands for non-uniform expansion, so you can see not fully expanded THP, especially at the side of non-coronary side. So again, so we use 20 millimeter balloon, I mean the size up to 20, and still we can see some non-uniform expansion, but we suppose this is okay, so we implanted this Nabita 27 millimeter balloon. So during the implantation, as you can see, the balloon gradually moved upward, like this. Can you see this one? So gradually it moved to aorta, and the patient blood pressure goes down, and the pulmonary hypertension occurred. So this is due to severe aortic regurgitation. So in the case of Nabita is available in Korea, I'm not sure that, but we have to take care of this non-uniform expansion in the case of Nabita. So this is after deployment. So this is non-uniform expansion, especially in Asian patient. Patient has severe calcium at the non-coronary and the right coronary side. So we can identify such not fully expanded at the non-coronary side. And in the case of evolute case, we sometimes identified invaginate, I mean infolding of the valve. So before implantation, we have to check the steep RAO view. So this is the coplanar view. So usually valve is fully expanded, but at the cusp overlap view and steep RAO view, from steep RAO view, so these valves cannot be fully expanded. So immediately before implantation, we have to change the fluoroscopy to steep RAO view to identify the NUE or infolding. So what we did before the valve implant procedure, we had to check the Nabita features. This is a Nabita 27. So there is some chance of coronary obstruction due to sinus sequestration. So actually, we implanted the Sapien 3 Ultra Regia 23 in Nabita 7. Fortunately, the coronary was not occluded, but actually 3 months later, patient came back with subtotal occlusion of left coronary artery, and they did PCI for this patient. So the tub-in-tub procedure is very problematic in Asian patient with very small sinus of Valsalva. So this is another case, the female in her 80s. This is also very usual case for TAVI patient. And this is Evolute Pro 26. And as you can see, so this is a cusp overlap view. So we can identify the valve is fully expanded. So this is a real view and deployment. But so we can identify that this valve is not fully expanded at the steep array view like this. So this is a very important issue for such patient. So it was very difficult to remove nose cone, and finally valve was popped up to the aorta due to impingement of nose cone to THP. So after that, So at first, we can grasp this sheet valve with snare catheter, and again BAV, and another evolute valve was implanted. So we have to grasp this initial valve before second valve implantation. And after that, so if we remove detachment of the snare catheter, so evolute valve was dancing like this. So some doctors said this is okay, so dancing valve is okay, but some papers showed already, sometimes aortic dissection occurred in late phase, so we have to secure this valve. So the snare catheter was deployed at one C-tab. So this is not so difficult. So within 1 minute we can catch. And the other side, so we have to grasp again and bring back this THB to the ascending aorta and secure the valve. And after that, detachment of this snare catheter, and finally AOG showed very nicely secured. So this is the ordinary way to retrieve the catheter, not catheter, THB, and secure the valve. And the final case is especially for the accurate nail or Navita case. So actually the accurate nail doesn't have any C-tab, as already you know, and Navita doesn't have very big C-tab. So it is very difficult to grasp using snare catheter. So in such cases, how to retrieve the THB? So this is a JR catheter, and also we can use IMA catheter. And through this strut, so we can insert the 3.5-inch wire and cross to the descending aorta and catch by N snare or one snare catheter. And externalization like a CTO, and bring back the wire, and we can retrieve the THB very easily. So we can easily cross the wire through the strut, even to the non-coronary side and the left coronary side. So this is very easy way. So this is during my stay in Italy. So I experienced this case, 84-year-old female, and Navita valve was embolized to the ascending aorta, and we can cross the guide wire and catch into in the descending aorta and bring back like this. So this is very easy way to retrieve the catheter. So the surgical conversion is the most solid way to retrieve the catheter, but sometimes we have to do the TAVR procedure, and also sometimes we have to snaring the catheter, and the second valve should be implanted like this. So, but we have to take care of aortic dissection or coronary obstruction like these cases. So in this summer, we have CVIT 2024 in Sapporo. Please come to Sapporo. Thank you very much for your time.
Yep. Thank you very much, Dr. Hachinohe, for your presenting very suggestive cases. So we don't have so much time left, so we would like to move to the next topics.
Yeah,
Thank you very much.
Yeah, thank you very much. And we'll continue with the complication of TAVI by Dr. Ramesh Dagubati. Hello.
Good day, everyone. This is Ramesh Dagubati. I'm speaking on complications of TAVR today.
Yeah, please go on.
I have no disclosures. So the most common complications are stroke, valve embolization, annular rupture, coronary obstruction, conduction disorders, paravalvular leak, and vascular complications or others such as tamponade or ventricular septal defect. So I think the most important thing that we can learn from each other is how can we prevent these complications. I think depending upon appropriate patient selection and screening, using CT scan of the chest, and we actually do it from the jaw to all the way to iliac and femoral arteries, and respecting the iliac and femoral diameters, but there's calcium or tortuosity, and also looking at the aorta, whether there's atheromas in the aorta or not. And we have to learn some new techniques such as ultrasound-guided puncture with micropuncture needle to avoid vascular complications and to ensure that the pacemaker is in a good position, or pacing over the wire also is allowed nowadays. Appropriately sized valve and bailing out yourself with crossover balloon occlusive techniques, and obviously be good friends with the cardiac and vascular surgeons to help us out in terms when there is a need for surgery. So some of these valves have disappeared due to the complications such as direct flow or even lotus valves. And other new valves will be coming, and we still need more data to see whether these valves will really make it into the market or not. So the all-cause mortality at 1 year with a low-risk population has come down. Obviously, we are doing now a TAVR in inoperable, high risk, and intermediate risk, and as well as a low risk patient. But keeping an eye on all-cause mortality at 1 year, and whether we are doing the right thing, offering them TAVR in low risk patients is also a very important point to keep in mind. PVL has come down over the years, and I've been doing it since 2009 to now. Obviously, there's less than 5% of severe PVL in our TAVR patients nowadays. Thank God the innovation of having a skirt at the bottom of the valve, but that comes at a cost with an increased pacemaker rates. And as you see, with the S3 valve in 1 year, the pacemaker rates up to 17%. And in inoperable patients. So I think, but how to reduce the pacemaker rates are by placing it slightly higher, maybe 80% aortic and 20% ventricular is what we have learned. And our pacemaker rates now at our institution are about 6 to 7%, even though we use 60% self-expanding valves and 40% balloon expandable valves. And there is no difference between the two valves actually. So stroke is a very debilitating disease. It's decreasing compared to feasibility trials, but has been stable since. And I think the timing of stroke is variable. It can be procedural versus non-procedural, and predictors of stroke after TAVR is not easy to predict. And so some of these people we really struggle, and what we can do best. In the beginning, in 2009, we used to do carotid pressure at the time of advancing the sheath, careful manipulations, minimizing post-dilatations, and whether to pre-treat carotid disease is always a question which is there in our mind. several embolic protection devices have come into the market, and they're still being investigational. Sentinel ID trial showed that there is no difference in major strokes. However, minor strokes, there is a benefit by using Sentinel device in these patients. So I want to show you some pictures here on the right side as I advance the valve, and as you can see that I was dragging some atheroma which was there in the descending aorta now into the ascending aorta. We stopped here and we said what should we do in this particular patient is actually was not very clear. So the surgeons and I actually decided that since we have already gone over the arch, let's actually complete the deployment of the valve. What do you normally do is something that actually in a question in this patient. So the valve deployment went well. We did drag into the ascending aorta. You can see the flap in the ascending aorta, which is being pushed by the nose cone. So then when we pulled back, actually the atheroma came back into the descending aorta. So we thought, oh my God, I think we probably are now okay because it has come out. And but it resulted in vascular problems here in occlusion, which the cardiac surgeons repaired the femoral artery. And as you see in hospital strokes, 30-day major strokes are still a problem, and many publications came out, and with the transfemoral tower versus transapical tower, there's still, I think, it's old data that actually shows that it didn't make any difference, and transapical tower may be slightly less actually because you're not going over the arch. And so duration, I think it can happen at any time, but the procedural is the most important one, and I think embolic protection versus pharmacotherapy has been seen. And over 120 days, I think it is mostly hemorrhagic, maybe due to the dual antiplatelet therapy that we use in these patients as well. My patient 2 days later was agitated and had an MRI which showed actually multiple infarcts in the brain, and she ultimately succumbed to death in this patient. So a Sentinel device, I think we do use in people who have calcium score more than 2,000, or where we are planning to do multiple balloon dilatations, or actually younger patients probably, but who is to say that it cannot be used in every patient? So I think cost might be a concern, but I think stroke expenditures are much higher than actually prevention with this device itself. So the next patient is a valve-in-valve TAVR that we were doing when the SAPIEN XT was approved for valve-in-valve originally. And as I was inflating here, you can see that we pre-dilated and we're inflating the valve here in the SAPIEN XT on the right side. And towards the end of the inflation, the balloon suddenly deflates. And I noticed that. And I was kind of alarmed at that. And because I suspected balloon rupture in this patient, we stopped here and we tried again to think what we can do. We called the vascular surgeons and they said it's okay to pull the balloon back into the sheath. And unfortunately, the balloon pulled back into the sheath and it was not coming easily. And we tried to remove everything in one device, but it got stuck. And so what we know that the patient became hypotensive, immediately had here abdominal aortic as well as iliac and femoral injury on the left side. And so this woman passed away on the table, even though the vascular surgeons tried to repair the abdominal aorta. And the reason is because I think this valve balloon is very stiff, and as you can see, it is like an umbrella which is being dragged down with an open umbrella into the aorta, and that actually scraped the entire aorta, and that is what unfortunate situation. And after this, we had one more patient where the balloon ruptured like this, and in that patient, we actually stopped. We didn't pull it back into the sheath. We actually asked the cardiac surgeon to open up the chest, and that patient survived. So we never know whether it is a transection of the balloon that happens or a linear rupture. So if it's a linear rupture, nothing will happen. But if it's a transection, that is what we are worried about. And so annular ruptures are seen not commonly now, because in the past we used to oversize, and now we are accurately sizing, and any prosthesis more than 20% oversizing with a balloon expandable valve can result in annular rupture, along with the calcifications and post-dilatations or eccentric annulus. And so how to prevent is sizing and the slow inflation of self-expandable or using self-expandable valves if adverse features are present. here is one patient that we are pushing it in a 26 sapien valve, and as you can see that it is expanding, and maybe overexpansion might have resulted here. As you can see, it looks like it came out of the aortic frame, and immediately double shadow and cardiac effusion, and the patient had a tamponade. And options are surgery or valve in valve, and this patient we tried to do another surgery, but she also passed away. So conduction disorders, I think obviously low implantation and presence of calcification with the right bundle branch block on pre-TAVR ECG is a risk factor for pacemakers, and the proper positioning of the valve, I think, is the most important in these patients. So PVL is another complication that happens. This is probably a slightly lowly paced valve, and this one was treated with another valve which treated the PVL. So valve embolizations are unfortunate, and here loss of capture of the pacemaker, and they immediately jump back. So I think it's important to make sure that the pacemaker is kept on pacing until the end. And so this patient, the embolized valve was brought back into the descending aorta and went back with another valve, which was not bad at all. So before you put another valve, post-dilate the valve in the ascending and descending aorta valve. So this is another valve-in-valve procedure where recently was done, and a degenerated evolute valve, and then it embolized, the sapien valve embolized into the ventricle, and so this patient underwent surgery, but unfortunately did not make it the next day. Coronary obstructions are also common in valve-in-valve procedures, especially with the supraannular type of valves, and so either you protect them with a guideliner or a stent itself, and looking at high-risk features in these patients and trying to avoid actually maybe a valve-in-valve TAVR is also recommended. So this patient had severe ST depressions after TAVR and hypotensive, and we thought there's anti-wall hypokinesis on TEE, and we thought it is due to the left main ostium, so we immediately put a stent in the left main and deployed it, and that resolved everything. So what are the predictors of coronary obstruction? Women, balloon expandable valve, small aortic roots, coronary heights less than 12, and the VTC less than 3 millimeters are the ones. And the prevention is by actually having a basilica in valve-in-valve procedures, or actually putting a chimney type of stent, or actually having the guide wire and everything ready to deploy the stent if there is a coronary obstruction. In successful patients, the mortality is 22%. Unsuccessful PCI in this coronary obstruction, mortality is 100%. So I think it is really important to know. So residual gradients are another feature that actually can impact on patient survival over long term at 1 year. And so patient processes mismatches not well. So valve in valve in surgical valve, and you can do a balloon valve fracture of the surgical valve, and so expanded. So this you can see at the end it'll give away here, and so that's what we want to do. And the gradients can be less after balloon valve fracture, so as compared to baseline or after valve in valve TAVR. I think so. Hypotension at sheath insertion or removal, and peripheral perforations and early angiography is the way to look at it. After you pass a stiff wire, if the patient becomes hypotensive, maybe severe MR or the wire causing tamponade, that can be confirmed by an echocardiogram. And balloon after BAV, if the patient becomes hypotensive, probably due to severe AR or tamponade. And again, echo is a crucial modality to detect that. And after valve deployment, the severe AR, coronary occlusions, tamponade, I think depend on echo, iodogram, and coronary angiogram. I think in summary, the TAVR complications, patient selection is the key. Adjunctive techniques will help you to control and manage catastrophic situations. And alternate access site, if you see abdominal aorta, now our preferred access is right transcarotid and as an alternate access. And heart team with knowledgeable and complementary members, I think, is the most important. I'll stop here, and I'll be happy to take any questions. Thank you very much.
Yeah, thank you. So we should proceed to the Next live case, it will be by Dr. B.H. Yong-hee Wang from the Catholic University Hospital.
Thank you, Chairman. I'm Kyuk Jang of Seoul St. Mary Hospital. So can you hear me?
Yeah.
Yeah. So recently, Revito was first introduced in Korea. So I know the Japanese doctors have many a lot of case experience in Navito. However, the Korea is new to Navito, so I chose my live case as Navito implantation. So patient was 78-year-old female. So came to emergency room due to severe dyspnea. She has chronic kidney disease stage 3 and stroke history. Yeah, her peripheral angio has no problem. And then pre-TAVI CD measurement, her perimeter was 26.5 and area is 441, which matches with 27 millimeter of Navito. As you can see, yeah, as you can see in this slide, so the aortic leaf calcification is very small. So previously I preferred Sapien in this kind of patient with less calcification. As you can see, the small calcium of each leaflet. But I assumed that this kind of patient is will be appropriate for Levito implantation because Levito is very has weaker radial force during 80% of implantation. So I like to introduce the Levito valve, very similar to Evolud R, but large cell design is the unique feature so for easy coronary access. And then the outer ceiling cup is far different from Evolud R. It is. I think you should the Google for the difference between the seal cup and Evolud R seal. And another important thing is this is outer skirt height is in 23 or 25 millimeter valve, only the 9 millimeter, and 27, 29 millimeter valve is the outer skirt length is only 10. So sometimes in Evolud R implantation, the NCC side is shallow, but LCC side is sometimes more than 10. So you can extensive regurgitation through this open frame. So you should be careful about Levito valve implantation, especially LCC side. So balloon aortic valvuloplasty is strongly recommended in Levito implantation because the radial force of Levito is less than the Evolud R during the early stage of implantation. But after final release, the radial force is similar. So you can worry about the migration into the ascending aorta after successful Levito implantation. But during initial implantation, the pre-ballooning is increase the likelihood of successful valve frame expansion on initial attempt. You can see non-uniform expansion of valve strap frame in the previous lecture. So that's very important point in Levito implantation. And then initial the delivery system position is very similar to Evolut. The stand frame the matches the nadir of aortic annulus. Initial valve deployment, the target implant depth is recommended as 3 millimeter. So in my experience, the Navitor is very flexible and compared to the Evolut R. So usually the located at the center. But during Evolut R implantation, the valve is very steep. So usually the valve located against lesser curvature. So the NC side is shallow and LC side is deeper, but this Navitor is far different compared to Evolut R. So 80% at the time of 80% of valve deployment, the lock button is initiated and no further deployment occurred. Even though we the rotate the button. So at 80% valve deployment, confirm implant depths, both cost overlap view or frame parallax view, and then also as the previous speaker suggests, extreme the RA view is should be done to visualize the non-uniform expansion the presence. Final deployment. So most important thing is during the 80% deployment and from 80% deployment to final deployment, you should wait for the valve is stable for another several minutes. But instead of waiting, the 80% deployment to final deployment is rapidly done. The valve may be migrated into ascending aorta. And then the slow implantation is very important. And then pull the guider back is similar to Evolut implantation. And usually during Evolut R implantation, the one tab is released, and then we need a slow deployment because rapid deployment is suddenly pull out of other two tabs, and then the more unstable. And then during the Navitor implantation, one tab release, but Navitor deployment process has no problem because very simultaneous release of 3 tabs. This is similar to Evolut R implantation. And this is a summary. And I like to show our case. The first process of our TAVI procedure is the puncture of right radial artery because we inserted a pigtail catheter through the right radial artery instead of left femoral artery. If without other indication, we usually get right radial artery access and only one femoral transfemoral access. So the bleeding complication is minimized. Sorry. and then transfemoral access. So the PK catheter is inserted through the right artery. Just a moment. And this is for the wire pacing. So we put the needle through the skin, and then the one side of electrode connected. Yeah. This is the this needle electrode for wire pacing, and then probe right. After then, introduce sheath. In LV wire crossing. And then this is our first Levito case. The foreign the valve mounting specialist visited our center. He showed his first case of valve mounting. It's a little bit different from the evoludar mounting process. Yeah. This group is preparing mounting, and we make a pre-balloon size. And then this is valve frame, and the Levito valve is connected here, and then water is inside. And the all water, and then the small touch, the valve valve leaflet, and there is the process of air removal. Yeah, air removal process. And she's the our valve mounting specialist. Her saying is the mounting, Levito mounting is easier than evolular mounting and sapien mounting. But this is first time, looks difficult. Yeah, we prepare valve. At this point, I changed the position, the operator, and then first assistant. Levito valve is a smaller length than Evolut, so one operator can do everything, the release and then positioning. But our team decided two doctors needed, one positioning and one release, the same as the evoludar implantation. Just a moment. This is 18 millimeter balloon. Mean diameter was only 18 millimeter. We chose 18 millimeter balloon. That's perfect for this kind of patient is less calcification. Just a moment. So Debito is very flexible and yeah, easy to cross the aortic arch. Just a moment. Yeah, this is our implantation view, 3-course NCC overlap view. This is nadir, and I adjust the length and zone 0. As you can see, it's maybe more central than compared to Evolut. And Dr. Huang, the elevator catheter. At that point, the valve was very stable. But the Evolut R case, the valve first attached the NCC and finally approached the LCC. But this valve is, I think maybe attached the whole three valve deplete simultaneously. So valve was stable, not moving into the ventricle or aortic side until 80% of implantation. The depth is only the 3 millimeter. And then the other side of just a moment. Yeah, at the LCC side only 2 millimeter, and then NC side is 3 millimeter. Very successful implantation at this moment. And LAO parallax view is also looks nice. 다음으로 넘어가야지. So we waited for 5 minutes until the valve is stable, and then the external cuff is stable. But during waiting, she developed the complete AV block. We inserted a temporal pacemaker. Until implanting temporal pacemaker, this is wire pacing. So temporal pacemaker is inserted. And this is final. This is our first case, so we proceeded very slowly. But at this point, we proceed immediately, not in the case of Evoludar. Then the depth maybe the 3 millimeter. This is final aortogram. 돌아 찍은 게 없네. This is final. Yeah, only the 3 millimeter depths in LCC, NCC. When he transferred to the CCO, she immediately recovered his conduction system function. So the temporary pacemaker was removed, but during his stay in CAS room, the temporary pacemaker was needed. Yeah, so this is me. So these days, so the echo specialist didn't visit our classroom. So after pressure, I checked echo by myself, and during echo, no PVL was observed. And this is our final. So we do only one prograde, and then the one femoral. So the hemostasis complete after these two combination. So this is my take-home message. Implantation process of Revito is very similar to Evolut R implantation, but difference is more flexible frame of Revito makes Revito more centralized, and then easy to very stable. And weaker radial force during 80% implantation need pre-dilation. And the outer skirt length is only 10 millimeter. So we should careful in LCC depths. So my feeling of first Navit case was that implantation process was easier than Evolut, but case selection might be the important factor for the success. Thank you for your attention.
Any question from the panel? Dr. Huang, can I ask just one question? I mean, during the implantation, you do have heart block. Will you consider putting a permanent pacemaker later, or you just monitor the case during his stay in the hospital?
Yeah. Luckily, she recovered from complete AV block just after leaving the CAS room. So after she arrived in CCU, her rhythm was normal sinus rhythm. So we didn't need pacemaker, permanent pacemaker.
Any question from the panel?
There are many experiences in Japan regarding some Navito. What is your strong recommendation regarding the two previous devices? Would you recommend a Korean doctor? Japanese.
Well, not much recommendation from our Japanese friend yet. Yeah. I'm from Hong Kong. We tend to use either the Evolut R or the Sapien. The Leviter, I have no experience on it yet. But personally, I tend to use the self-expand valve more than the balloon expander one.
So, my personal opinion is the competition will occur between Navito and Sapien. Evolut is somewhat different from Navito. So Evolut patient has a lot of calcification, extensive calcification. Navito is not appropriate. It's my personal opinion. So the next calcification patient, Sapien or Navito, that will be the future, I think.
Dr. Zhang, I have a question. Congratulations for your Navito cases. Actually, you said after initial implantation, and then you you said you wait 5 minutes, right?
Yeah, right.
Why do you wait 5 minutes? 5 minutes is a very long time.
But it's time to talking with my colleagues and then my technicians and nurses. Previously, I experienced valve migration during evoludar. After 10, during that time, I immediately released. But after I experienced valve migration into ascending aorta, I waited for the 5 minutes. The from the 80 or 90% of implantation of evoludar and to finally. But this is I felt 3 minutes is okay. 5 minutes longer.
If there's no further question, I think we are quite happy to close these sessions, and we'd like to thank all the panelists, the speakers, the operator. Once again, we should show our appreciation with our usual manner. Thank you.
Yes, thank you very much for sharing. Thank you very much.
Now it's time to wrap up this session. From now, we will have a short break. Please feel free to use this time. The next session will start at 4 p.m. So may I ask you all to be back in your seats 5 minutes before the session starts. Thank you for your cooperation.
Good afternoon, ladies and gentlemen. I'm Gwangju from Jeonnam National University Hospital. We are preparing a case of
Now it's time to open the live case session 7 and 8, coronary NTA-VR. Let me introduce the chairman of this session. This session is going to be co-chaired by Seung-un Na from Korean University Kuro Hospital, Korea, Holger Thiela from Heart Center Leipzig at University of Leipzig, Germany, and Hiroshi Yoko from Fukuoka Sano Hospital, Japan. Chairman, please come to the front and have your seats. Thank you.
Hi, I'm Dr. Ra, working at Korean University Kuro Hospital. There are two co-chairs, but not arrived yet, so let me start this session. We have an expert panelist here. Would you introduce yourself from left to right?
Okay, my name is Jerzy Pręgowski. I am from Warsaw, from Poland, and my main area of expertise is mitral and tricuspid valve, and I am relatively fresh in the TAVI area, so I hope to learn a lot here during this session.
Good afternoon. I'm Hao Park from Prochon Sejong Hospital. I'm interventional cardiologist, especially to TAVR and complex PCI. I'm very glad to enjoy this session. Thank you.
Hi, my name is Young-Uk So. I'm working near Cheomdan Hospital. I'm an interventional cardiologist. I'm very honored to be here as a panelist and enjoy.
Thank you. My name is Son-Ho Hwang. I work at the Gwangju KS Hospital. I'm an interventional cardiologist. It's my honor to attend this wonderful academic session. Enjoy this time. Thank you.
Okay, so let's start live case 7. Let's connect to Jeonnam National University. Can you connect? One missing, the lady panelist. Sorry. Taiwan, from Taiwan.
I am Donna Lin, interventional cardiologist from Taiwan, and it's my privilege to be here. Thank you.
Welcome back. Can you connect to Jeonnam National University?
Yeah, I'm Kyung-jo from Jeonnam National University. I am preparing a case of
this is not real life.
Yeah, taped live. Yeah.
Taped live.
Yeah.
Okay. Okay, I confused that this is real life. So this is a 4 to 4:30. Will be taped, recorded live case. Okay. So you will present the live and discuss after finish the live presentation.
Yeah, during the presentation.
During the presentation, okay. Please.
Yeah. 슬라이드 보여주세요. Okay. I'm preparing a case of long diffuse calcified coronal lesion in LAD. So let's introduce our case. Could you introduce the case summary?
Let me show you our case summary. A 67-year-old female patient was brought to our tertiary center due to chest pain. Her past medical history included unstable angina, hypertension, and diabetes mellitus. The patient previously underwent PCI for ICA, and she had diffuse severe stenosis in LAD lesion. Laboratory finding was normal, and surface ECG shows normal sinus rhythm. Echocardiogram showed good LV systolic function. Initial electrocardiogram shows normal sinus rhythm. On July 17, 2023, we performed stent deployment at severe stenotic lesion at proximal ICA. Meanwhile, we found very severe calcified coronary stenosis in proximal to mid LAD. At the time, we decided to deploy this lesion. Echocardiogram showed good LV systolic function. At the outpatient clinic, we evaluated the cardiac CT angiogram, which showed that diffuse severe calcified region in LAD. This is our discussion points in this case presentation. First of all, which one is the better strategy in this patient? Angiography only PCI versus image-guided PCI. Second, if we choose image-guided PCI, which imaging modality is the better option, IVUS versus OCT? Third, if we decide to perform rotablation for this heavily calcified lesion, which one is the first procedure? Balloon angioplasty versus rotablation, the first.
Thank you for your case summary. Yeah. Could you please could you show the previous coronary angiogram? Yeah. Right coronary angiogram showed patent stent in proximal RCA with good distal flow. Left coronary angiogram showed diffuse long severe stenosis over proximal to mid LAD and tandem stenotic lesion in distal LAD. We are trying to perform balloon. Yeah, this is the case I prepared. And 1 year ago, he underwent successful PCI for severe stenosis at proximal RCA. And at that time, the mid-LAD severe stenosis lesion was deferred. And recently, she complained of chest pain, and we decided to perform intervention for LAD lesion.
Okay, for this particular region, the LAD D1 bifurcation, calcified tortuous region, to get the good ideal performance outcome, they suggested good discussion point. I didn't remember, but we have to do the D1 protection, saving the bifurcation strategy. Second one is when we consider the image-guided intervention, OCT is better or the IVUS is better. Third one, primary rotablator or balloon angioplasty or failed and bailout rotablator. Please discuss your opinion.
Okay, so I think that intravascular imaging will help us decide whether to go upfront for rotablation or try
primary rota first.
Yeah.
Primary rota first.
Yeah.
What would you do for the imaging?
I would do IVUS.
IVUS.
Because I've got much more experience in IVUS, so I do IVUS. I can very well assess calcium with IVUS, so I will go for IVUS. But I know that there are people who disagree with me.
Actually, all the data-based or the experience-based real calcium, the OCT is known to be better than the IVUS in real calcified region. But this kind of eccentric, some circumference, not the real encircling calcium, the IVUS has some residual room to assess the looking at the vessel area, not the total encircling calcium. So IVUS can be feasible. And problem is this real tortuous hard. If we cannot do the proper region preparation, IVUS catheter insertion itself is very difficult. How about Dr. Hauk? What would you do? Primary, some situation, I heard that some Korean center primary rota, the reimbursement is sometimes trouble. They don't do the pre-dilation attempt. That sometimes insurance cut. So many some other general hospital, they are trying to do primary. They are hesitating to do primary rota. The balloon attempt failed and do the rota. How do you think about that? You are working at the second specialized cardiac center.
But I think maybe either IVUS and OCT imaging tool is either both okay, but I'm friendly to IBUS, so I choose IBUS. Primary rota ablation is maybe helpful for this patient because of rotablator's role is very important to lesion preparation for diffuse calcific long lesion. But balloon angioplasty first strategy may be induce diffuse dissection and some severe complication. So maybe rotablation first strategy is okay for this patient. And Paul?
Yeah.
Yeah,
Can I
okay.
keep going? Yeah.
Okay,
I've got a long history, so
sorry.
yeah.
So just one comment, because I heard that kind of reimbursement cut indicates primary rota is more safe because balloon-induced contrast straining, dissection, and injury is more dangerous for the bailout rotablator. So primary rota is more safe and more efficient and less procedure time. That is a safer strategy. So in the case, it's better to do short attempt to balloon that you can describe the balloon. It's difficult to cross several attempts, and so we did the primary rota. Just that's it, is to the primary rota. Please keep going.
Yeah. Angioplasty with a small diameter non-compliant balloon.
Please show the. Okay.
네. 예. 천천히 빼주시고. 천천히 빼주세요. 네. Good afternoon. I tried balloon angioplasty first using 2.25 non-compliant balloon. $20. Okay. Balloon angioplasty for the stenotic lesion in distal LAD at 28 ATM. And then sequentially, we performed balloon angioplasty from middle to proximal LAD using 2.25 non-compliant balloon at 20 ATM. 여기 심하다. 여기 안 된다. However, the under expansion was observed in the proximal LAD.
20 is too low pressure.
괜찮으세요? So under we tried OCT, but the OCT catheter could not pass the lesion. The severe stenotic lesion, so we will try additional balloon angioplasty. 22. Yeah. 22. We performed a non-compliant balloon angioplasty at 26 ATM.
Still low pressure.
Yeah, the slightly more lumen area was achieved after 26 this balloon angioplasty. Okay. Deflation. 테스트 조금만. 테스트. 흘러가 보게. 좋고 오케이. 디플레이션. 조금만 들어가서 좀 더 할게요. 네. 2.25 non-compliant balloon. 다 들어가면. 네. This is the OCT after balloon angioplasty. 네. Good. ST 체인지 생겼고. 네. 되겠습니다. 잠깐만. 다 들어가면. 네. Severe, heavily calcified lesion. In some area, nearly circumferential, 3/4 calcium deposit with a long distance of calcium. The length of calcium lesions is about 32 millimeter. The thickness of calcium is about 1 millimeter. It's very thick. Okay. In the target region close to second diagonal branch, the thickness of calcium was about 0.44 millimeter, and it seems like a circumferential calcium deposit in this target region. We will try to perform balloon angioplasty with drug coating balloon in the distal region, and then we will try to perform root ablation in the severe calcified region in proximal to mid LAD. Number 8. This is Prevail drug coating balloon angioplasty. 한명수님 혹시 가슴 아파지면 말. This is the follow-up angiogram. Deflation. 연결성 있으면 꽉 잡아주시고 와이어. And then we tried root ablation. 플로로 다시. 오케이. 플로로. 다이너그로 들어갈게요. 들어갑니다. 들어오세요. 오케이. 다이너그로 그대로. 굿. 따라와 주시고. 와이어 굿. 좀 따라와 주시고. 이제 따라와 주시고. 굿. 됐지?
What size of bar?
Okay. I selected 1.5 diameter rota.
Why you did not the primary rota?
Yeah. Yeah, I would like to use the intravascular imaging, so the balloon angioplasty, yeah, I selected. Stop. 리케이지 괜찮지? 네, 괜찮습니다. 오케이. 불러. I felt the moderate to severe the resistance to root ablation. 조금 아프세요? I checked angiogram to assess whether the no reflow or slow flow occurred. 이 정도 됐겠지? 네. 오케이. 굿. 오케이. OCT? OCT. 이거 빼고. 예. 이거를 내가 빼면 따라만 가요. 네. Yeah, this is the OCT after root ablation. 잘 됐네. 오케이. 가봅시다.
Dr. Jo, wire is still rota wire. LED wire is rota wire.
Rota wire. Fracture. And we could get the more lumen area. You can see the arterial dissection. 타겟이 on OCT exam after root ablation shows a lesion length about 50 millimeter, and the proximal reference diameter is about 3.0. And distal reference diameter is about 2.5. Good. 여기가 거긴갑다. 저기 5mm 거기. 응. 약간 되는데요. 그러네. 왜냐면 이게 28이 안 되니까. So we performed stenting using 2.5 by 28 millimeter synergy stent for the distal to mid LAD. And then we performed stenting using 3.0 by 28 millimeter synergy stent for the mid to proximal LAD.
At this point, at least I hoped you protect wire protection at least at D1. Why did you not protect side branch?
Yeah.
You cannot 100% guarantee. And the standard procedure must be after, because due to the friction in the calcified and the culprit region, the rota bore can unexpectedly going down as you show. So the region location can be more distally spread out. So after rota, then balloon come down, then looking at all the entire LAD region, then you can decide where to wear the DCB or where to wear DS if we want to do the hybrid strategy. But primary DCB, then do the rotablator, that is not the usual process in my idea. That is my comment. Anyway, please keep going. And the other panelists, you can give the other opinion if you have. And this also needs to be protected at least before the stenting for the diagonal branch.
This is follow-up angiogram after stenting.
D1 appears to be jailed and proximal looks worse.
So,
adjuvant?
Yeah, under expansion was observed in this lesion, so we performed additional angioplasty using 3.0 non-compliant balloon at 22/18.
Before adjuvant, why you are not protecting again?
Yeah. This is follow-up OCT. 아주 좋네. 아따 좋다 2.5. Angiogram looks not bad. However, OCT 어디가 타겟이었지? 아주 좋아. 굿. Yeah, this is the OCT after non-compliant balloon. So this is the final OCT. However, this region between below the diagonal branch, the lumen area was measured 3.63 square millimeter. So we tried additional angioplasty using non-compliant balloon at the more higher atmosphere. Minimal lumen for that region. 26. So we tried additional angioplasty non-compliant balloon at 26 ATM. Positive? Yeah, this is real final OCT. This the LED, mid LED. 조금 커진 느낌인데 약간 30, 35, 35제. 조금 커진 것 같아. In the target region, we achieved minimal stent area of 4.17, so it was acceptable. So we tried, we finished our procedure. With 3.0 non-compliant balloon at 26 atmosphere showed minimal stent area of 4.17. So we are satisfied with this result. So we decided to finish this procedure. Final angiogram.
어디?
angiogram. 디지털 가지고 디지털. Good. Yeah. We finished our procedure. A case of severe long diffuse calcified lesion in the proximal to LAD. So we performed OCT guided rotablation, and we got a good result. It's time to wrap things up. Thank you for your attention. Thank you.
Thank you.
And some strut looks like a strut separation on the expanded strut beyond the stem strut. Some flow is maybe septal area, septal direction in the OCT, right? Still, fortunately, diagonal is not dead. When I look at the Octavius trial, the OCT I was published from the Asa Medical Center, they reported the OCT optimal stent area, I remember the 4.5. So 4.17 is not so bad. It's okay. Any other comment? Okay, Dr. Lin?
I have a short question regarding, you said the OCT could not pass initially. Which side was the catheter stuck the first time when you tried to push the... Primarily because we actually do not have the OCT before the balloon angioplasty. And I think the advantages of OCT compared to IVUS is greatest in terms of the thickness of the calcification, the evaluation of the thickness. Now, if we do see circumferential calcification, like 360 degrees, if the thickness is thin enough, then there is a chance of creating calcium cracks with cutting balloons or high pressure NC balloons. But if it's thicker than a certain, say 60 something, then there's a very low chance of we creating calcium cracks. Then in that case, perhaps balloon angioplasty does not need to be attempted beforehand and can go straight on to rotablation. So I think this is, for me, I would choose OCT over IVUS because this lets us know the chances of failing the balloon angioplasty attempt in the first place. The second thing is, after the OCT run, did you think of going on to a larger rotablation burr? If we don't consider the costs or reimbursement, would you move on to a larger burr? Would you think that would help?
Yeah, thank you for nice comment. In the to the first comment, I agree with your point of view to some extent. And second, the vessel diameter was measured from 2.5 to 3.0. So I performed 1.5 millimeter per root ablation, and I think, yeah, it is enough to get a acceptable result with stent implantation. So I did not use 1.75 per.
Actually, in Korea, we can use two different size borehole with the reimbursement. So two are freely used, and at least 1.5. If you use the bigger NC balloon, usually just once we make crack with 1.5 usual NC balloon, bigger NC balloon, we can make it enough predilation to accommodate the stent expansion. So without the stent expansion, without the enough expansion by NC balloon, we may consider the further rotablator. For me, I think that before you replied the predilation for the imaging, but in my case, the safe procedure is a primary rota, then the NC balloon, then we can do the imaging for the safe strategy. Then we can enoughly assess the internal milieu.
Do you think it would be better?
Yeah,
primary rota, yeah.
Primary rota.
Yeah.
Anyway, primary rota is most convenient and safe.
Yeah.
Safe.
Yeah.
Because a huge dissection is more dangerous for the rota.
Yes.
That is
that is one point I want to discuss about, because prime rotablation can debulk the calcium. So after prime rotablation, you can get the more the acceptable result with balloon angioplasty after prime rotablation.
That is a labeled indication. Before making huge dissection, it's better to do rota. Yeah. Okay, due to time limitation, we have the one chairperson on the online, Dr. Holger. Can you hear me?
Yes, I can hear you. Yeah. Okay. First of all, thank you very much for inviting me. And unfortunately, I'm not able to be in person. I'm really impressed to see how you deal with this highly calcified lesion in the, or long lesion also in the LAD. Regarding my preference, probably I would have chosen IVUS also to reduce the overall use of contrast dye, because IVUS allows us to do nearly zero contrast PCIs. The rest I probably would have done exactly the same. First rota and then put in drug-eluting stents. But you have really perfectly dealt with this complex, very long calcified lesion.
Okay. Dr. Cheng is here or online, the next lecturer. So first lecture, Dr. Cheng from Yanbian is missing. A second lecturer, Dr. Noguchi.
비디오로 가겠습니다.
누구 첫 번째요? 두 번째?
네.
Dr. Noguchi, Teru Noguchi looks recorded lecture from National Cerebral and Cardiovascular Center. Cheng is recorded lecture. 틀어주시죠 뭐.
Thank for Professor An and Chairman give a chance to present our work is NICE GICS 2024. The topic is cross-sectional analysis of AMI patient of the Korean and Chinese. Outline. First topic is the difference in patient with AMI between Yanbian area and Korean. The method. study for two population, Yanbian University Hospital, and 5,014 AMI patients. Some of reason previous AMI and previous cabbage and others program is excluded from this study, and 4,655 patients. Camera study is just included 12,075 patients. This phase result is just focusing white panel in Yanbian and Korean. Just age and marriage is higher in the Korean, but in the other parameter, exception of the systolic blood pressure, is other parameter were higher in the Yanbian area. So this is very interesting. And so here is STEMI is very higher in the Yanbian area, almost in 80%. But non-STEMI is around 10%, somewhat included 20%. But camera is quite different. In the STEMI is about in 50%, and the non-STEMI also about 50, but somewhat slightly changed. But the reason I don't know exactly. Another is parameter risk factor is hypertension, smoking, diabetes, yes, and AMI. I find a difference in both groups. However, the number of risk factors is 1, 2, 3, no significant difference. And laboratory testing, so here, white blood cell neutrophil platelet, and CKMB, and creatinine, and somewhat higher Korean, but repeat profile is lower in Korean people. So there is no difference between Yanbian Korean patient with AMI, except in the systolic blood pressure. The proportions don't stand well significantly higher in Korean. There is no difference in the distribution of the modifier risk factor in both groups. Second topic is the circadian and seasonal variant in the onset AMI. Circadian region is reported in the end 3 Nobel Prize. So here is the first reported circadian region AMI in 1906. In the past, there is no different study on the seasonal and circadian region of the AMI onset in the Yanbian area. The purpose of this study was to determine whether there is no difference in the seasonal and circadian region in the AMI. This method, same population from our Yanbian hospital, and some of the region the patient not defined onset and something and excluded. It just included our study, and the Chinese Korean is 1,096, and the Chinese Han is 1,179 patients. Division time is 0 to 6, 6 to the 12, 12 to the 16, 18, 18 to the 14. Season fourth region, and stratification age in the younger is less than 50, intermediate 50 to the 75, oldest in the 75. So just age difference in the four group, others no change, and maximum and maximum CMD and the maximum CMD is somewhat changed in the four group. And the probability data I saw the Korean and Chinese Han is, and so here, mean age AMI is higher than Han, but keep score and it can have the percentage in higher in the Chinese Korean. So age is quite different in the both group, but Korean Chinese Korean age is most higher in the Chinese Han. Next, in the laboratory finding is that the maximum CK anti-dopamine and creatinine per platelet, but somewhat changed, but not so much changed in the both group. This is the main result. And so in all cases, quite similar to previous study in the morning time, 7 to the 9 were higher. Even separated Han and Korean is not almost similar to the old case. But the season region difference in the May and October, I don't know the exact mechanism. I don't know in the May and the August, in the maybe daytime and nighttime, were quite different. So the sympathetic activation or the predicate aggregation activation may be contributed. and smoker age similar to the old case. But interestingly, the age-dependent change, and the middle age is similar to the old case. But young age was higher, tops higher in the 7 o'clock, and the earliest in the shift in the morning time. So instead of AMI, AMI is higher circadian region, and instead of AMI is just 2 months in the May and August, and the winter were lower. Further study need to mechanism study. So topic progress implication of the admissions dopamine high level and D2B time. So for some reason, exclude some patient and divided to 3 groups. And low level, normal level dopamine is less than 0.1, and the middle age level is the 0.1 to the 3 nanogram. Over 3 high group, and T2B time is according to the 90 minutes. At the end point is the primary cardiac adverse cardiac event is heart failure and cardiovascular mortality. So this is my first result. And so here is a lookout in the auto-dependent dopamine level is have difference in the incidence of cardiac death and heart failure. But in D2B time, 1 year follow-up in the just only high dose were effectiveness. And D2B time analysis and so here, so that finder so did that in hospital deaths and HF were difference in the D2B time, but 1 year death, 1 year follow-up, no effect. And 3 days and 1 year individual and composite event as so here. D2B and dependent D2B time still is hospitalization 3 days significant difference. 1 year follow-up is lost in the D2B time effect. And our curve in hospitalization event, when we have both of the cardiac dopamine and D2B time very effective. But 1 year follow-up lost of D2B time effect. Just only cardiac dopamine level is predictable. And just admission risk composite clinical event. And so here, in the high level, not only in hospitalization and 1 year follow-up very effectiveness, but D2B time in the analysis lost of the both effect. So their conclusion, third conclusion, the level dopamine level admitted to the hospital is an effective predictor of outcome in the STEMI patient. And certain D2B time is the beneficial effect for the patient outcome in the short time day, but it limited various predicting long-term outcome. And combined evaluation of the admission of the cardiac dopamine level and the D2B time might be more objective and useful to predict the prognosis of the STEMI patient after PCI. So this paper published to journal, and the latest photo is of our first meeting in the MBA. I just come to the MBA University. So to cherish the main result in the basic research, still working in the collection work and muscle regeneration, so this kind of young bone marrow transplantation, and human umbilical cord derived mesenchymal stem cell transplantation, and also collection in the information response and so on. And also focus study in the stress work. So it's collection the difference to prevent kidney damage and moderate stress-related cardiac artery thrombosis and stress-related muscle atrophy and adipogenesis, so on. This is working in Nagoya University. In the end, Nagoya, Japan is so much stress as just Hanami time is just no stress. We enjoy the waste students. Yes, many students study in the world and Nagoya University.
그 온라인 디스커션은 안 되는 없죠? 그 연결이 토론은 안 되는 거죠? 되나요? No discussion? 없는 거죠? 예. Dr. Cheng is not connected online for discussion. He's one of my old friends. He worked at the Nagoya University before, did a lot of basic research and invited to his hometown, the Yanbian University. Actually, I regularly visit the Yanbian University for the medical service, the intervention for the Chinese Korean patients, 3-4 times in a year for more than 10 years for medical service. I did a lot of stent implantation there for more than 10 years, for a long time before. I went to the Baekdusan, the mountain between the border zone, North Korea and China. But these days it's difficult to go. So I know very well about the Chinese Korean people living there. So I fully understand the situation. So if you have any question, I can answer instead of that. Any comment? We cannot receive any.
Just one comment, looking at this incidence of NSTEMI and STEMI, it is completely similar in Europe, that we have much less STEMI and...
Seasonal variation?
Yeah.
Much STEMI?
We have more NSTEMI.
More NSTEMI.
And the decline in the rate of STEMI cases.
Okay.
So this is happening worldwide, I guess.
Actually, in Korea, we have similar, right? When you CAMIL data, NSTEMI, STEMI is similar now in Korea.
Looking at the trend, the number of STEMI is decreasing, and still the numbers are similar, but...
NSTEMI is increasing.
Yeah.
And NSTEMI have a much more multi-vessel involvement. Okay, due to time limitation, let's move on to next presentation. Okay, next presentation will be Dr. Noguchi from Japan. Title looks very long. Aquamarine CKD study, please.
Good afternoon, everyone. Thank you, moderators. Coronary CT angiography, CCTA, is an indispensable modality in the current practice of coronary artery disease. The Scott Hart study showed that intervention with CCTA compared with standard care reduced incidence of cardiac death and myocardial infarction after 5 years, and subsequently promoted the widespread use of CCTA in clinical practice. However, patients with chronic kidney disease, CKD, might have limited benefit due to complications of contrast agent nephropathy and decreased diagnostic accuracy because of coronary artery calcifications. Coronary MRA has several advantages over CCTA, including it's not affected by calcification, it does not involve radiation exposure, and it's possible to choose a method that does not use contrast media. This slide shows a representative case of coronary MRA, volume rendering, CPR, and stretch view images showing a normal angiogram of left and right coronary artery systems. The left panel of this slide shows a diagnostic performance of coronary MRA and CCTA in the detection of significant coronary stenosis caused by moderate to severe calcifications using invasive conventional CAZ as a gold standard. 3 experienced radiologists unaware of the result of invasive coronary angiography independently assessed for the presence of significant stenosis on CCTA and the corresponding coronary MRA images. As shown in this table, the average AUC of MRA for the 3 readers was significantly higher than that of CCTA. The right panel shows Dr. Yoon from Korea. She demonstrated that whole heart coronary MRA is useful for predicting risk for coronary events in patients with suspected coronary artery disease. Based on these results, coronary MRI has emerged as a novel imaging modality for detecting stenosis without contrast media that is not affected by calcification. In addition to the evaluation of vessel stenosis, we have previously shown that coronary high-intensity plaques, HIPs, on non-contrast T1-weighted image associated with characteristics of high-risk plaques, including positive coronary artery remodeling, lower Hansfield units on CCTA, plaque attenuation on intravascular ultrasound, and slow flow phenomenon after PCI. HIP is quantitatively assessed using a coronary plaque to myocardium ratio, abbreviated as PMR. PMR of this HIP was 1.78. Moreover, we conducted a prospective observational study to determine the prognostic significance of coronary HIP. As a result, PMR of 1.4 was the best cutoff value for predicting coronary events, and multivariate analysis for all coronary events demonstrated that the presence of PMR greater than or equal to 1.4 was the strongest predictor. Thus, cardiac MR can detect high-risk coronary plaques as well as vessel stenosis. Chronic kidney disease is an independent risk factor for the development of coronary artery disease. The optimal strategy for evaluating coronary artery disease in patients with CKD remains a topic of contention spanning over several decades. So some patients with CKD have extensive radiation calcification disproportionate to the severity of obstructive CAD, which limits the diagnostic value of CCTA. Therefore, we conducted a prospective multi-center randomized study called Aquamarine CKD study to investigate the clinical impact of non-contrast T1-weighted image and coronary MRI on management and risk stratification in patients with CKD with very high risk for CAD, estimated by Japanese Urban Risk Score, SWITA score. This slide shows the details of SWITA score. SWITA score is composed of 8 coronary risk factors categorized including CKD. A previous study showed that SWITA score was more accurate for predicting CAD than Framingham risk scores in Japanese population. We employed SWITA score greater than or equal to 66 points, corresponding to an estimated 10-year risk of CAD greater than 22%. I'd like to show a study flow chart. Patients with grade 3 or higher CKD with high coronary risk estimated based on SWITA score greater than or equal to 66 points were recruited. We randomly assigned enrolled participants for evaluation CMR group or to the stress myocardial scintigraphy control group and assessed outcomes over 1 year and 3 years. This is the primary endpoint. A composite of cardiovascular events at 1 year after study examinations, all-cause deaths, deaths from cardiovascular disease, non-fatal MI, non-fatal ischemic stroke, and ischemia during unplanned coronary intervention. We started the recruitment of participants from 6 institutions in Japan from September 10th, 2021, and the recruitment was completed until the end of this March. Discussion. This prospective multi-center randomized study will assess the added value of the clinical implication of CMR in an outcome-focused care pathway for CKD patients at very high risk for CAD. We will open the primary outcome next year. Thank you for your attention.
Thank you for a nice presentation. Open for discussion, comment.
May I have one comment?
Dr. Doi.
Yes, thank you very much for your excellent presentation, Noji Sensei. I'm Takahito Doi from Copenhagen in Denmark. Looking at the individuals with CKD, now the randomized control trial using IL-6 inhibitors, ziltivekimab by Novo Nordisk actually, and these patients are quite high-risk patients. So so that's why they chose such individuals. My question is, after the detection of the coronary artery stenosis, what kind of procedure should we choose? PCI or CABG or both? What do you think? Or maybe inhibiting resolution of the low-grade inflammation?
So you mean which therapy is preferred
because
for?
your main concept is to reduce the contrast exposure to the contrast media, right?
Thank you. So as you know, the grade 4 or 5 with CKD patient, so we will hesitate to use contrast media to do the PCI, but depend on the patient's condition, we should do that. So even the severe chronic CKD disease, and I think up to the patient's condition.
Thank you.
Actually, the coronary angiography is known to be the gold standard to finally decide to whether to do the PCI or the CABG or any other revascularization. So due to the CRI, and we have to confront the more worsening of renal dysfunction. Even we try to minimize the contrast, even no contrast technique like IBIS-guided intervention or minimal fluoro-guided wire, every branch wire using intervention, or anything, there's some chance of progression. So we have to do something once you diagnose even by minimal risk of contrast by MR. What we have to do after the high risk coronary by your strategy? We have to do angio at least, finally invasive angiography.
Sorry, your question is sorry.
Final decision, before making final decision, you can decide without coronary angiography for going to PCI or CABG?
Yes, but that depends on each institute interventionist.
How about panelist opinion?
I have 2 questions. So I think this is a CKD version with the MRA of the Scott-Hart trial. Is that what the initial design was? And in the Scott-Hart trial, primarily it was not looking at how the patient received revascularization. It was to see if CT angiography compared to routine care improved the decision-making process. And so I think in the Scott-Hart trial, the primary care physician it was mandatory for them to make a decision on the next step within 6 weeks of receiving the results of the CT. And I'm not sure what was the design, or maybe I missed it in the aquamarine CKD. This is the first question. Second question is, we know that cardiovascular events in patients with CKD, atherosclerotic events decrease in percentage as the renal function worsens. So as the patient's renal function worsens, non-atherosclerotic cardiovascular events increase. How do you think that might affect the results of this current study? Thank you.
Thank you. So first question, as you mentioned, the Scott Hart made a two-step evaluation. First one is depend on the patient's symptoms and which modality, CTA and conventional strategy better. And the second one is published on New England Journal to do the CTA or standard of care. And I'd like to do the second session of Scott Hart. So Aquamarine is quite similar to the Scott Hart as second evaluation. And the second question is, it's very difficult question. And on JAC, last year, the review demonstrated that greater than CKD 4 or 5 higher, the rate of mortality didn't increase, depend on the cardiovascular mortality and depend on the all-cause mortality. And that is problem. But anyway, I want to know which modality as a CMR without radiation and without contrast media is better for these patients. It's my focus.
Okay, if you don't have a question, okay, thank you so much.
Thank you very much.
The last presentation, last live case 8 from Jeonbuk National University. The Professor Sang-Ruk Lee will present this live case.
Thank you for your nice introduction. I'm Sang-Ruk Lee from Jeonbuk National University Hospital. I'm last speaker of the last session. Because of time limitation, I will go fast. Okay. My case is for TAVR. Okay, my topic is for the timing of intervention in aortic stenosis. 81 years old lady visited our hospital. She detected aortic stenosis during routine health examination by murmur. After visit to our outpatient department, she complained at first no pain, no dyspnea. After only long time interview, she complained only mild dyspnea. That developed 2 months ago. Lab finding there was not specific except mild renal dysfunction. Cardiomegaly, and there was no RBBB, LBBB, and there was no non-specific except T-wave inversion. In echocardiography, there was a aortic stenosis. Peak velocity was nearly 4.1 meter per sec. Maximal pressure gradient was nearly 67. If we take a look at echocardiography, there was a stenosis in here. Aortic valve area was nearly 0.9, and peak velocity was 4.1, and only small calcium like this. So my first question is, in this only mild symptom patient, medical therapy may be sometimes possible with close follow-up. Or other option is like in this case, TAVR or SAVR also available. This is my first question. In Korea insurance, more than peak velocity 0 and aortic valve area less than 1.0 square centimeter will cover the TAVR procedure because she are only mild symptom and more than 80 years old. So we checked the CT angio. In 2017, European Heart Journal recommended in guideline in symptomatic patient, there is no doubt to conduct TAVR or SAVR. However, in asymptomatic patient or mild symptomatic patient, such as stage 1 or stage 2 stage, there are gray zone to aggressive intervention or surgery. My case may be between stage 1 and stage 2. So there are some ongoing trial like AVATA, early TAVR, DANAVA study. There is no clear answer. There are risk and benefit of early intervention. Early intervention sometimes provoke procedural complication. However, if we postpone procedure, there is sometimes a lot of long complication may be developed. If we take a look at the strain data of this patient, this concept is not good for me, but my colleague, echo staff, usually check the strain data on severe AS patient. In pulse, is the peak atrial longitudinal strain is the concept for atrial contraction. In pulse was nearly 23. And LAFI, LA function index, is a kind of strain data. In this patient, nearly 33. According to our hospital data, we conducted 116 severe AS patients during that has more than 2 year follow-up, more than 1 year follow-up. According to the pulse and LAPI, pulse less than 15 and LAPI less than 32.5 has a more poor prognosis after TAVR procedure. So in this patient, she complained only mild pain, mild dyspnea, and 81 years ready. And strain data, the pulse was 23 and LAPI was 33. So my colleague recommend TAVR procedure in this patient. Is there any discussion or question?
I think that in this kind of asymptomatic patients, you may also consider exercise tolerance test.
Yeah, there's good option too, but because of osteoarthritis, she cannot take exercise treadmill test.
Okay, I understand. And the other comment is that if we have borderline area, we also do sometimes transesophageal echocardiography to measure it planimetrically.
Yes,
and before making final decision.
In some guidelines recommend laboratory test for pro-BNP, but in this patient, the pro-BNP was increased nearly 1,000. So my colleague and patient all want to TAVR procedure in this patient. So I go TAVR in this patient. Okay. This three-dimensional data. BOD diameter was nearly same, 1 millimeter smaller compared to annulus level. If you take a look at the coronary height, left coronary was nearly 17 millimeter, and right coronary was also 17, more than 10 millimeter in this patient. However, annular angle was nearly 62 degree, more than 65, 66 degree. And this horizontal aorta was observed. If we take a look at the calcium burden in this patient, there are only small calcium burden in this patient. Okay, and the aorta level, the aorta was tortuous, as you can see. There are bending in abdominal aorta and thoracic aorta, and horizontal aorta was also observed. If you take a look at the iliac and the femoral artery, the femoral bifurcation was below the femoral head level, so we can easily puncture in this common femoral artery in this patient. Our procedure plan is right femoral puncture and main access by right side and left access subside. Okay. In Korea, there are only 3, and so far, a couple of weeks ago, approved the diabetes system, but at the time, 2 weeks ago, when I did this procedure, SAPIEN 3 Ultra and Evolut Pro Plus acute Neo 2 system is only available. According to the 3D analysis, the annulus was, according to the SAPIEN 3 Ultra, 23, 35, 352, relative lower border zone of the 23. If we take a look at the Evolut Pro system, annulus perimeter derived diameter was 21.2. So it's a middle point of the Evolut system. However, in this patient, the annular angle was more than 60 and tortuous aorta nearly 3 times bending. So I choose the acute Neo 2 system in this patient. The perimeter-derived area was derived annulus diameter was 21, and the LVOT diameter 19.6. So this is the middle portion of the small acute neo2. Is there any comment or question? Okay, I go. So acute, as you know, acute neo2 system is supraannular design and top-down deployment, relatively high, good in terms of flexible delivery system and good radial force in the 5 to 7 millimeter nominal implant depth. There's nearly no incidence of permanent pacemaker implantation during TAVR procedure. And moreover, as you know, commissural alignment possible in acute neo2 system. By commissural alignment, future coronary access and TAVI in TAVR procedure possible. So this is our procedure. Right. Coronary was normal by right main axis. We mild sedation.
펜타닐 절반 half dose.
Sorry.
Okay. 멈추고 this one is Boston eye sleep 14 pressure sheath, very soft and flexible. We will insert this sheath. Okay. 펜타닐 절반. Okay, we check the sleeper's view. Okay. Let's go.
By floppy straight wire, we can easily enter LV.
Enter LV.
And after that, we check the by pigtail pressure gradient.
However, because of sensitive drop, we cannot believe this gradient in this patient.
So, just the light sedation you are doing?
Yeah, right sedation.
Dr. Lee, how about real pressure gradient between LV and aorta?
Yeah, because as you, in usual situation, we cannot believe the gradient in this patient because there are paper by sedation. The pressure gradient decreased, so we cannot believe that. There are some paper. Acute neo2 system require pre-dilatation. So by GMED 20 millimeter balloon, we pre-dilate this patient.
Pressure, play, 1,000, 2,000, 3,000, play. Okay, much better.
So this patient require pre-dilation?
Yeah, because in acute neo2 system, all patients recommend pre-dilatation because of the relatively weak radial approach of valve system. And after that, we put the valve system.
Okay, good. Please enter.
Tortuous aorta.
Please go back distal portion. Anchor. There are some resistance. Okay, right enter. Okay, breathe. Okay, good.
This angle can easily overcome by this system.
Overcome by this system. Okay. Stop. Go to the area. Okay, area. Anchor.
Before the entrance of the LV, we check the commission alignment.
Okay.
In cusp overlap and three
Front
cusp
view.
lap, three cusp view,
Okay.
we check the commission alignment.
We have to check the commission
They
alignment
reported
indication.
more than
Okay.
95% avoid commissioner misalignment.
Okay, good. Okay.
And after that, we enter LV.
Okay. 2-1.
Okay. This marker is the annulus level.
Test.
Were high, so we push the valve system.
We go deploy this.
They require step
Step 1A.
1A and 1B and step 2. Step 1A means the upper crown deployment. Step 1B are
Okay,
upper crown
crown.
here.
Okay, stop.
Step 1B require anchor. Okay, 1B here. Only rotation.
Tail is over the movement. Okay.
Because of horizontal aorta, I push the system by push. However, somewhat forward movement developed.
Minus, please.
Like this. So I pushed again.
High. Okay, I will forward the pressure in this position. Deeper. Okay.
And
Test 준비. Minus.
final deployment do not usually require pacing. However, proper position may be get by pacing, high left pacing. Like this.
Everybody agree? Yeah. Let's deploy. Okay.
By pacing.
Pacing. Pacing.
By left hand, I push. Pacing like this.
Pacing. Deploy. Deploy.
Okay.
Okay.
But somehow
Stop.
upward movement develop.
Recording.
To remove the system, we have to take care, like every system, nose cone. Sometimes nose cone pull up the whole system, like this. And after that, recapture, same way, like every system.
Okay.
And after that, we checked aortogram.
High.
Like this, some high implantation developed.
에코 한번 봐보고 싶다.
However, in echocardiography, there was no problem. There was no only scanty PPL, and AR index was nearly 38, and no block. no visible PVL in this patient. So we checked the final aortography in this patient, like this. No high implantation, however, there's no PVL, no problem, and patient was good. So we decided to finish this procedure. Thank you.
Okay, nice result. Please give any comment or questions.
상동리, I think she has some septal hypertrophy sigmoid septum in echocardiography. So about the slightly migration may be due to septal hypertrophy, I think.
Yeah, that's a good point. According to the 3D analysis, there are 1 millimeter diameter difference between annulus level and LVOT level. By this one, that what the kind of region, one possible explanation of high implantation in this patient.
So what is the image you guided? How did you do image guided? By TT?
Yes, TT, yeah.
TT is enough for this?
Yeah, TT is enough in usual case. In some case, more than 60 patients, we use ICE examination. But in this patient, because of horizontal aorta, ICE imaging may be not so good, I think. So I did not use ICE in this patient.
The usual case, you prefer to do the ICE?
Yes.
This particular case, TT?
Yes.
In your study, you have only some selective criteria for the general anesthesia?
Yes, such as high cushion burden, high-risk intervention, such as bicuspid. Simple bicuspid may be possible by this kind of way, but high cushion burden, bicuspid, and low ejection fraction patient, sometimes I usually prefer general anesthesia.
What is the current selection criteria for the valve type among the different TAVI valve?
Pardon?
What is your preference for the choice of valve?
Yeah. In this patient, all three systems may be possible in this patient, but because of tortuous aorta, I exclude the Evolo system, and Sapien and Accurate Neos 2 system is possible in this patient, but however, sizing, in terms of sizing, Sapien 23 is the low part of the in this patient. So I exclude the Sapien system. Last one is Accurate Neo 2. So I choose Accurate Neo 2 in this patient.
Basically, this patient is not, the calcium is not so extensive, right? This
yes.
patient. So either self-expander or the balloon expander is not so risky also. So
yes, balloon expander is also possible, but sizing is matter in this patient.
Okay, any other comment? Or this session is scheduled to be finished until 5:20, so I think it's time to wrap up. The co-chair, the Dr. Thiele, Dr. Holger, any other comment for this session for finalization?
Yeah, first of all, it was also a very nice live case, which I've seen. Honestly, I'm a little bit lucky that there was no embolization of the valve, because this was really very high implanted. And I've seen lots of, a few embolizations in this case. Anyway, so I think this was a very nice session on two very interesting live cases, one in TAVR, the other one in a severely calcified lesion. And we also for sure had very interesting abstract and presentations with, hopefully also some data we see from the Japanese trial on the patient with CKD. So I really enjoyed it and looking forward, or unfortunately I cannot be there to join you for the dinner, but I hope you still have a very nice meeting. Thank you very much.
Okay, thank you, every lecturer and the panelists. Thank you for your active discussion and participation. I'd like to close this session. Thank you so much.
Bye-bye.
Wrap up this session. A lottery for a gift certificate will be held here at the main arena soon. We will appreciate if everyone could join the event. Thank you.
곧 그 경품 추첨이 있을 예정이니 잠시 대기해 주십시오.
For the international faculties, we do have a faculty dinner at third floor of the Holiday Inn Hotel at 6:30. So welcome to stand by 6:20 at the Holiday Inn third floor. Thank you.
네, 경품 추첨 시작하겠습니다. 거기 서 계신 분들이 좀 앉으셔도 될 것 같습니다. 네, 김계영 교수님, 윤현주 교수님, 이기홍 교수님, 김유리 교수님 앞으로 나와서 추첨 부탁드리겠습니다. 또 윤남식 교수님 아까 계셨는데, 예. 또 누구 계신가요? 예, 일단 지금 첫 번째 3만 원 스타벅스 상품권 5명 뽑겠습니다.
이건 좀 비리 같은데 이렇게 뽑아도 되는지 모르겠는데 저희 순환기내과 비서 박관미. 제가 평소에 일을 좀 자주 시켜서요 미안했나 봅니다.
네, 전남대병원 윤다혜 선생님입니다. 네.
저는 안 뽑고 싶었습니다만 나도 받고 싶었는데. 자, 전남대병원 박대성 쌤.
핸드폰 번호 마지막 자리가 0입니다. 0. 핸드폰 번호 마지막 자리가 0. 여기 사람 있나요? 기혜진 선생님, 전남대학교 병원 기혜진 선생님. 네.
전남대병원 박효진 선생님입니다.
교수님도 아직 들어가지 마시고요. 스타벅스 5만 원권 2명 뽑겠습니다.
네, 2장 뽑았는데요. 중앙대 광명병원 조준환 선생님. 없으십니까 혹시? 없죠? 그러면은 아쉽지만 넘어갑니다. 전남대병원 홍문아 선생님. 목포중앙병원 박상현 선생님.
이기영 교수님, 예. 스타벅스 상품권 10만 원짜리 한 분입니다.
을지대병원의 이규성 선생님.
네. 그다음에 이제 2등입니다. 갤럭시 버즈 1명, 과장님께서 뽑아주시겠습니다.
갤럭시 버즈입니다. 조선대병원의 주낙중 선생님. 오셨습니까? 오.
네, 1등 아이패드 프로 130만 원 상당 되겠습니다. 정명호 교수님께서 뽑아주시겠습니다.
네, 영광스러운 분이신데요. 강남 세브란스 병원의 이승현 선생님. 축하하고요. 상품. 한 말씀 듣겠습니다. 노래 한 자리 할래요?
노래는 나중에 하겠습니다. 저 긱스 처음 사실은 15년 근무하면서 긱스 처음 왔는데 이런 큰 상을 주셔서 너무 감사합니다. 감사합니다.
네, 고맙습니다. 오늘 이 자리에 참석해 주신 여러분께 진심으로 감사드리고요. 마지막 우리 과장님 말씀 한번 드릴게요. 윤현주 과장님. 제가 94년에 메이오 클리닉 갔을 때 오늘 첫 번째 강의했던 분이시죠. 닥터 라바 슈월츠가 있었는데 그때 이제 처음으로 워싱턴에 가서 제가 라이브 하는 걸 봤거든요. 그래서 한국에 가면 꼭 해와야 되겠다 해서 2003년부터 해서 오늘 22년째가 된 것 같습니다. 그동안에 후원해 주신 여러분께 다시 한번 진심으로 감사드리고요. 우리 과장님 말씀 듣고 마치도록 하겠습니다.
네, 안녕하세요. 저 순환기내과의 윤현주입니다. 네. 우리 정명호 교수님을 비롯해서 우리 과의 인터벤션 주로 하시는 중재 시술을 하시는 교수님들 중심으로 정말 오랫동안 끊임없이 열심히 하시면서 이 심포지움을 계속 준비하고 그래서 우리도 이 김대중 컨벤션 센터가 낯설지는 않은 것 같아요. 그래서 여러 상황이 쉽지 않고 또 오늘 또 종일 참석하는 것들이 쉬운 일은 아니었을 건데 참석해 주셔서 감사드리고요. 그리고 좀 앞으로 내일까지 있으니까 공부도 열심히 하고 또 오늘 저녁도 좋은 시간 되셨으면 좋겠습니다. 감사합니다.